different parts of the world. Let me tell you in brief about the OSS mission. Operation Straight Spine, a charitable mission project endorsed by Scoliosis Research Society USA, who has put forward the endeavor to treat children and young adults surgically with spine deformity. In collaboration with Jagannath Gupta Institute of Medical Sciences and Hospital, OSS has organized the 3rd Kolkata Spine Deformity Conference, wherein distinguished spine surgeons from India and abroad will be sharing their knowledge and expertise with the delegates. The 16th Operation Straight Spine mission that offers a holistic approach, both surgical and developmental, has exhibited spine deformity surgical workshop and the conference today to illustrate the unique learning opportunities through case presentation, panel discussion, and debate. They couldn't agree more to the fact that JIMSH is the preeminent platform for the same, which is committed to deliver healthcare facilities and medical education that is within the reach of all. Without much ado, let's begin with the very first section. I would like to call upon stage for the welcome address our respected Principal Sir, Professor Dr. S. Butterbell. Can we have a round of applause for Sir? I would request our respected SVP Sir, Brigadier Dr. Soumitra Chatterjee, to come to the stage for the welcome address. A round of applause for Sir.
चलो এখানে বসি আচ্ছা আমরা ওখানে গিয়ে বলে যে ভালো হবে
I would request everyone to be seated.
May I start?
Sure, sir.
Good morning, everybody. This is my great privilege and great honor to welcome all of you in this spine deformity surgery, which is organized by the OSS Trust. I welcome all the surgeons, anesthesiologists, nurses, and the paramedics who have come abroad and to accompany with us from the different countries like Palestine, United Kingdom, United States of America, and also Italy. I appreciate the efforts made by our President and Chairman, Dr. P.Ali Burman, and also our Chairman, Dr. Ujjwal Kumar Devnath, for organizing this type of workshop in the Jagannath Gupta Institute of Medical Science. And the Jagannath Gupta Medical Institute of Science is always extend their cooperations and always keen to the development of any kind of development which is encourage the students and also helpful to the patients. And it is one of the important workshop where the patients having a spine deformity which requires explorations and also higher cost. And sir, you are here, which are very much helpful to us for giving this type of operations in these institutions. At the same time, I just observed there are so many panel discussions where there will be intensive discussions with different topics and different things are coming out. And our faculties, our students, our PhDs also very much helpful to hands-on skill training which is given by you. And this institution always we try to be hold different types of seminars, workshops. Recently we hold the workshops on microbiology state chapters where students and other participants participated here. Recently we also encourage our students to awareness with the digital health care in the different aspects. So sir, again I welcome all of you, particularly the dignitaries from abroad and also our faculties. And I hope and I am sure a good discussion should be here and our students will be helpful. At the same time, the most important part, which is our main motto, to help the patients who are getting this deformity will be benefited and helpful. Thanks a lot. Thanks you all.
Thank you, sir. I would request our MSVP, sir, for the welcome address.
Good morning to all of you. Respected ladies and gentlemen, this is indeed a great honor and privilege on my part to share the same platform along with you all, the eminent and elite group of spine surgeons from all over the world and also the various healthcare workers who have come from all over the world and also from eminent institutions of this country. We are informed that we are gratitude to you that you have spared your valuable time and offered your helping hand and professional expertise to make this mission a success. I do believe that the blessings which you will receive from these patients and the patient relatives will be an eternal asset for you in your lifetime. I also want to put it on record that the Vice Chairman Sir, the Chairman Sir, the COMD of this hospital, the Executive Director, the management staff, the employees of various ancillary and auxiliary groups who have helped and supported and given the infrastructure support to make this mission a success. Last but not the least, the man behind the machine, Professor Ujjwal Devnath, I must thank him and my sincere gratitude to him for making this project a success for the second consecutive year in this hospital. As a member of the JIMSH family, we are all very proud of him. Jai Hind.
Thank you, sir, for the warm welcome. I would request Principal Sir and MSVP Sir to take their seats so that we can begin with the case presentation. Up next, we have Introduction of OSS 2023 and a case presentation by Dr. Anzar and Dr. Kashinath. Round of applause for Sir.
नहीं मेरे को ये देखना चाहिए Good morning, everybody. The Operation Straight Spine. It was a dream project of two spine surgeons, Dr. Jeffrey Bucknell and Dr. Ujjwal Devnath, which led to the establishment of a charitable mission project to provide spinal disease and deformity treatment for the poor and underserved in India. The Operation Straight Spine had an initial goal to develop a medical aid project to provide spinal surgery services to an Indian population in a developing country. It also had the aim of establishing a self-sustaining spinal surgery units in different parts of the country. It is completely a charitable mission and the first global outreach program for spinal surgery in India, which was endorsed by the Scoliosis Research Society of the United States. Since 2006, OSS has been conducting several complex spinal surgeries and medical care for the children and adults with musculoskeletal diseases from low economic backgrounds who otherwise could not afford high cost of surgeries. We have been performing several spine surgical camps in different local hospitals in West Bengal for the last 17 years. Every year we have specialized spinal surgeons and nurses around the world coming down and participating voluntarily in our surgical camps. We have been able to provide spinal implants for surgery donated by the implant companies. We also have a developed scoliosis awareness program in the communities around West Bengal. OSS also helps to train and educate the orthopedic trainees and nursing staffs in various recognized medical institutions. It also supports a comprehensive rehab and recovery process after spinal surgery for the underprivileged patients to maximize their ability to become self-sufficient and independent. Till date, we have impacted the lives of 220 children and adults through 220 complex spinal surgeries during the course of the 17 annual surgical workshops and monthly surgical services. The most important recognition came from the Scoliosis Research Society of the United States when OSS was invited to Anchorage in the United States for the SRS annual meeting in September 2014 to speak on Deformity Mission Kolkata. This was recognized as the first global outreach program based in India, which was an important milestone in the OSS effort to continue reaching its goal sets out nearly 10 years ago. In 2017, as many as 15 volunteers had assisted in the OSS surgical workshop from the UK and US. In March 2020, OSS Trust got associated with the Orthopaedics Department of the Institute of Postgraduate Medical Education and Research, Kolkata, to conduct the first Kolkata Spine Deformity Conference. This was followed by a 7 days of spinal deformity workshop. In 2022 April, OSS collaborated with the JIMSH Hospital Budge to perform 8 spinal deformity surgeries after the second Kolkata Spinal Deformity Conference, which was attended by 20 eminent spinal surgeons from India and 5 spine surgeons from abroad. Under the OSS Trust, till date we have successfully operated 54 adults in idiopathic scoliosis cases, 22 congenital scoliosis cases, and 54 TB spine patients with neural deficits. The key impact factors of our OSS programs are the positive surgical outcome after the spine deformity surgery, the cost-effective analysis, the psychosocial impact on parents and children, and also the education for doctors, nurses, and OT technicians. I pay my sincere tribute to the team OSS from the UK, US, and Europe in developing the dream concept into a reality as the Global Outreach Spinal Surgery Program for the Eastern region of India for the last 17 years. I also welcome you to the 2023 edition of OSS program. Thank you. I just have a audio visual to show you. This is a small audio visual just to show the journey of OSS till date.
Operation Straight Spine really began back in 2001. At the time I was completing a second spinal fellowship at the University of Nottingham in England. I met a gentleman by the name of Ujjwal Debnath, who was a research fellow in the orthopedic department at University of Nottingham. And we became very fast friends, enjoyed many things together, including having a pint of Guinness once in a while, and we got to talking, and we both knew that we had a passion for basically wanting to start a project where we could give back to
সুস্থভাবে আমি যেন ভালো হয়ে যেতে পারবো আর কিছু বলার নেই সোজা মনে হচ্ছে যে হাঁটলে আরো ভালো হবে ভালো হয়ে গেলেই ভালো
এরকম ডাক্তারবাবুদের আমি কোনো দেখিনি চোখে দেখিনি আর যেন আমার যেন মেয়েটা যেন খুব ভালো হয়ে ফিরে যায় বাড়িতে এটা ভগবানের কাছে আমার খুব কামনা আর আপনাদেরও কামনা
Deepa was a 16-year-old girl who came to us with having a history of a febrile illness which she contracted several months earlier. She developed progressive pain in her back and wasn't able to walk. And by the time that we met her, she'd been laying in the hospital bed for over 4 weeks. Well, it was clear that she had tuberculosis and that it had spread to her spine.
সেখানে অন্য হসপিটালে ভর্তি ছিলাম অনেক জায়গায় ওষুধ খেয়েছি কিন্তু ওষুধ খেলে কমে যায় ওষুধ বন্ধ দিলেই আবার সেই একই অবস্থা থাকে রাত্রে কপালে জ্বর আসতো
হয়েছে?
আমার পিঠটা ব্যথা ছিল।
ব্যথা ছিল? এখন কি?
এখন ডাক্তারের কাছে গিয়েছিলাম।
তারপর অপারেশন হয়েছে? এখন তুমি ভালো আছো? ব্যথা নেই তো কোনো?
Thank you, Dr. Anzar, for giving us an insight of how OSS has beautifully helped people, especially the underprivileged one. Well, we move on to the next section. Up next, we have got Ms. Joanne Shilprandi to discuss about enhanced recovery pathway in AIS surgery. To talk about ma'am has been the specialist surgical care practitioner in UK, and currently she is working as a specialist in surgical care at Norfolk and Norwich University Hospital, UK.
Good morning, everyone. My name is Jo Siliprandi, and I'm a specialist spinal surgical care practitioner at the Norfolk and Norwich University Hospital in the UK. My role enables me to be part of the whole journey our patients take when having this kind of surgery. I see them in new patient clinics, assisting the consultants during the operation, see them in recovery, on the ward after their surgery, and then again in all of their follow-up clinics. I'm going to talk to you today about enhanced recovery pathway in AIS surgery, and my talk is based around our pathway that we use at the Norfolk and Norwich Hospital. So this is my team at the Norfolk and Norwich, some of them. You might be able to spot myself and Mr. Swami in there. This is us when we're being professional. And this one is when we go out and have a good time together. We're a really, really close-knit team and we work really well together. So what is an enhanced recovery pathway? Enhanced recovery pathways have been implemented in a variety of surgical settings to safely improve the care of patients from the very beginning of their journey to discharge. I'm going to focus mainly on the pre and the peri-operative element, as my colleague Mike Farrow will be talking to you all about the post-operative aspects later on this morning. The pathway heavily relies on a multidisciplinary approach, with a vast number of healthcare professionals being involved in the care of the patient throughout. Individual institutions have their own protocols and policies in place, and these are based on evidence and studies done globally, showing the effectiveness of the pathway. The introduction of enhanced recovery pathways for patients undergoing AIS surgery has been associated with a decrease in hospital stay, decrease in opioid usage, lower pain scores, a reduction in complications post-operatively, and ultimately a decrease in the overall cost of the procedure. There have been numerous studies across the world that have shown the differences and ultimate advantages of an enhanced recovery pathway in comparison to that of a traditional one. As we all know, AIS surgery is a massive undertaking for our patients and their families. They go through major surgery, bringing huge amounts of both physical and psychological trauma. These can be carefully managed throughout the pathway and ultimately improving the patient and their family's experience. There are a huge amount of things that can affect each individual patient's journey, but with an effectively communicating multidisciplinary team, all of the challenges faced can be dealt with. So this is just a slide with some of the studies that I looked at that are on our protocol at the NNN. So at NNUH, the patients have a lot of build-up to their surgery, and it involves them being engaged and informed by all of the healthcare professionals they come into contact with. You can see on the slide there's an information booklet that we give our patients and their families. And they also have medical illustration, baseline neuromonitoring, and the patients then get to meet a variety of healthcare professionals. This gives them the opportunity to ask any questions throughout. This slide just tells you a few of the names of our team. I just wanted to talk briefly about Jo Norton. She's one of our volunteers. Her daughter Daisy had scoliosis surgery under Bob Crawford a few years ago, and Jo is a vital part of our team. She talks to our patients and the parents and tells them their expectations after surgery. So for an ERP to work effectively, the recovery of surgery to be ideal, the patient and their family have to go through this huge pre-op workup. This includes many tests, appointments, scans, etc. It does also give them the opportunity to ask questions. On here, I've put a picture of somebody with adolescent acne. It's something that we see a lot of in Norwich, and we assess this very early on in the process and treat it accordingly so that the patient isn't delayed in having their surgery. You can see lots of other things that they have to have done before they come to have their procedure. So on the day of surgery, all the documentation is complete and available, and the informed consent is done. This includes ID bands, the consent form, anaesthetic chart, drug chart, pre-op assessment, multidisciplinary notes, and blood results. All expectations of post-operative pain, mobility, and the effects of medication and anaesthetic are clear to the patient and their families. Intraoperatively, we use extensive monitoring throughout the operative period, as listed here. Everything we do is to make sure that the patient is safe and to give them the optimum care for the best chance of a successful recovery. I'm not going to go into depth about the immediate, about post-op recovery, as I say, because Mike's going to cover that in a bit. But these are just a few of the things that are covered in the pathway immediately post-op. Oh, sorry. I just wanted to say a massive thank you to the OSS team. It's been an absolute pleasure to come and join you this week. And I'll just show you a picture of my family. That's it. Thank you.
Thank you, ma'am. Up next, we have got a word by Professor Dr. K.K. Mukhopadhyay, who is a part of the scientific committee and the convener from WBOA, and he shall be talking about how do I prevent infection in AIS surgery. Can we have a round of applause, sir? as we are anticipating a little delay of Dr. K.K. Mukhopadhyay, we shall move on to the next section. I would request Mr. Michael Farrow to come up to the stage to share his word about the tips for advanced care after scoliosis surgery. To talk in brief about Sir, he is a special OT technician in UK, HSC certified offshore medic with 5 years of offshore experience in renewable energy sector and 12 years acute experience in National Health Service. HSE approved safety representative he has always been. A round of applause, sir.
We just get the presentation on. Right, good morning everybody. Thank you very much for letting me come here and speak to you all. As a very quick introduction, my name is Michael Farrow. I work in the theatre in Norwich. I've got 15 years post-qualification experience and some advanced training in order to be a first surgical assistant. I'm also the orthopaedic team lead for Norwich. We do a wide range of orthopaedic procedures, including complex spines and also scoliosis correction. Sorry, next one. I'd just like to say you've all been so kind in sharing your beautiful city, your amazing city with me, so I hope you don't mind me just to share a little of my beautiful hometown with you guys. So, just to make sure you're all awake, a little audience participation. Patient recovery from scoliosis. When does this phase begin? Anybody? So, when we think about recovery of patients, there's often a misconception that this begins after the operation, but actually it's, as covered by Joe just before me, the pre-recovery, the prehab, the pre-operative phase is so important for the patient pathway. So why do you need to know this? Why am I here telling you this today? There are proven links between an effective recovery of patients and patient outcomes, and there's also you can have the best surgeons, the best team, the best implants, and perform the best surgery. But if the recovery phase for this patient is not adequate, your work can come to nothing and patients can suffer. So, here's just a few of the benefits of an enhanced recovery program. I won't dwell too much on this because Joe's obviously sent quite a lot of these, but you're looking at shortened length of stays, early discharges, lower costs for the hospital, and by following these pathways you can improve training for staff and you can improve and recreate also in the pre-operative stage, as Joe covered a little there, by involving patients in families and doing extensive goal setting, you can reduce the stress for the patients and also for their families. Following this pathway, you can increase post-operative recovery, comfort and care, and you can produce specific care plans for patients. So to implement this, we need three stages: pre-op, post-op. Joe has extensively covered the pre-op stage. I just want to talk again about the goal setting and expectation management with patients and families, letting them know what they're going to experience, what they're going to go through so that they are able to better care for this on their own. We're going to look at some perioperative factors that we in theatres can do to assist recovery, and then we're going to just have a quick look at the Norwich programme for post-operative care. So in theatres, we look at all the ways we can do to improve outcomes for patients, and one of the ones that we see as a really big issue is maintaining normothermia, or stopping patients getting hypothermic. In the UK, it's estimated surgical site infections, often as a result of hypothermic patients, can cost between £20,000 and £100,000 to treat. And also by maintaining good temperature for the patient, you decrease surgical bleeding, increase speed of wound healing, and again, reduced length of stay. So we use intravenous warm fluids, and we keep the ambient theatre temperature between 21 and 23 degrees. And again, Joe has covered quite a lot of this again, so I won't go over too much of it. But on the next slide, some of the things that we like to do to focus on. So we use cell salvage. So on the left there, we've got our cell salvage machine. Take the patient's blood, clean, filter it, and give it back to them. We use our bear hugger warmer, air warming blankets to help maintain temperature of patients. We've got nasopharyngeal temperature monitoring to make sure that we are achieving our goals in maintaining temperature. And also on the right-hand side here, the prone view that you may have seen on the last slide. It's a very soft rest for the face with eye cutouts and a mirror underneath. So you can see the patient's eyes, you can see the pressure areas, and it just allows the anaesthetist to have a much better overall view of the patient. So moving on to the start of the actual post-operative recovery phase, there's a dedicated pathway for this. Immediately post-operatively, patients move to the HDU or high dependency unit. There's multimodal use of analgesia, mostly PCA use where applicable, but in the initial phase you might need to titrate opiates. We have continuous monitoring, blood pressure, heart rates, O2, respirations, temperature, also drain, pressure area care. And we also monitor and assess neurofunction hourly. In the initial phase, patients may not be able to actually tolerate drinking water, but encouraging having sips can help. And at each phase, patients are reviewed by the MDT. So after this, day 2 to day 3, day 4, patients are still monitored, removal of arterial lines, CVPs. We encourage feeding of patients as and when they can tolerate. Again, PCA is still in use, pain score checked hourly, 4 hourly at this point, and encourage with deep breathing exercises. Patients can often, because of the pain, they can breath hold and not breathe deeply at risk of chest infections, so they encourage slow, deep breathing. And then looking at towards the end of the pathway, from 48 hours after surgery to the discharge phase, you're looking at, in Norwich, we have a dedicated children's ward, which is Buxton, which they've been moved back to. Again, we continue the monitoring of patients, but at reduced intervals. Catheters removed, so as and when patients are able to get up and go to the toilet themselves. And this is the point that the MDT meet again to discuss a discharge plan for the patient, making sure that they have follow-up appointments and pain control to take home with the patient. And in Norwich, most patients tend to go home around day 5 or day 6. After patients have been discharged, they're followed up at 2 weeks for a wound check, which is done by the specialist scoliosis practitioners at the NNN, such as Joe there. 6 weeks post-operatively, they're brought back for an X-ray, and then they're followed up again at 1 year. One of the big things we also do is a patient questionnaire, so we're able to get feedback from patients. And this is just an example from SRS of a timeline to complete recovery. So you're looking, these are very extensive surgeries, looking at 6 months really 6 months to a year before you can resume full activities. So hopefully between myself and Joe, we've shown you the benefits of enhanced recovery and the recovery phase, its importance, the importance of goal setting with patients, and the evidence-based practice is leading to successful outcomes for patients. It appears me and Joe have used the same slide, the same picture. That wasn't intentional, I assure you. I'd just like to say an enormous thank you to our organisers, our hosts, and all of you for having me here today. It's been an absolute honour and a privilege to be here this week.
Thank you, sir. We are privileged to have the presence of Professor Dr. Alauddin Ahmed from Palestine, and to introduce sir, I would request Professor Dr. Ujjwal Devnath to come to the dais.
Can I have slide for Dr. Alauddin Ahmed, please? Can I have the slide, please? Yeah. So Dr. Ala Ahmed has been coming and we are eminent presence in OSS for the last 3 years consecutively. I speak to him now and then on the text message. Sometimes he's in the US, sometimes he's in Nicaragua, sometimes in Turkey, sometimes in Tanzania. Now he's going to Vietnam. So he is spanning the globe with his surgery. This is amazing. This man is an energetic, spine surgeon, and he is fellowship in pediatric orthopedic surgery from Los Angeles Shriners Hospital. He is a present World Orthopedic Concern. He is a global outreach program in North American Spine Society. He is an active member in Scoliosis Society, and he practices in Ramallah, Palestine. But how long, how much time he practices in Palestine, I am not aware. He practices all around the world. So he is a global man for scoliosis and spine surgery. Here is Dr. Ala Ahmed. I invite him to the dais to give a talk on scoliosis surgery in underprivileged countries, my experience. Thank you, Dr. Ala.
Thank you very much. Thank you, Joel, for this kind words about me. And I'll not spend a lot of time talking about what I did, but briefly, I'm a pediatric orthopedic surgeon. I'm based in Ramallah in Palestine, and part of my work is an adjunct professor in the University of Toledo in Ohio in USA. I do global activities since more than 14 years in South Asia, in India, Pakistan, Vietnam, and in Africa, in Tanzania, Kenya, Rwanda, Mozambique, and in Latin America, in Salvador, Nicaragua, and Ecuador. So I'm going through 3 continents. This is beside, of course, the Middle East, Jordan, Egypt. Can I have my presentation? So I'll concentrate on talking on what I learned from the global work. And I'll talk about it in titles because each title has a lot of things to talk about, a lot of details, but you think about global activity for complex surgery like scoliosis. Where's my presentation? Actually, it's the dissemination, something. Let me show you. Just a second. Dissemination. Open it, please. Just oh yeah, here. Here we go. So I'm also, as Dr. Dibrat said, I'm in some activities. I have some activities in global organizations. So we have this problem that there is a myth about the problem of scoliosis, implementing it in in low-middle income countries, that it's expensive. And the price of the implants are expensive, which is not the true issue. Here we can see there is true. When you talk about it, you have financial resources, which is something very important, of course, like surgical equipment that are donated, doctors from developed countries volunteering and perform surgeries for free. This is one side of the problem, which is the easiest side. But the real problem is the organizational resources. Here we can see that you should have effective training, equipped nursing and assisting staff, clear guidelines and protocols regarding medical error, accountability, liability. clear protocols about communication with different health institutions, incentives for data collection, and many more. And if we look at that, this organizational issue might be working more with developed countries. Unfortunately, this is the real deficit that we have in the low middle income countries. And this is the main problem that we are facing. Why is that? So, as a result, though financial issues can be solved sometimes through material donation, but in the absence of more holistic vision, such assistance remains temporary, operating as a stopgap measure. And this is not affecting the structural context of your work. It will not be a sustainable program. It will be just a temporary issue and missions. And what happens on the long run? We have the end of the program, either because the person who is in charge for the program finish his work or quit or something, or because, there is a volunteer and donor exhaustion, which is not uncommon when the funds dry up. It will dry up sometime. Actually, I was talking always to people in countries that I go that you can have a charity once, you can have a charity twice, but it cannot be for 3 or 4 years. You need to put a plan. It is a big step. That's good, the beginning, but you need to think about it seriously, how it can be a last-standing program. So there will be an exhaustion, and also you cannot always find people who can work and come every year. It's an exceptional issue, so it will end the program. This is what happens in general. And there are challenges. Actually, I want to tell you something. I had the privilege to be in the position of the local surgeon, because I was beginning my life as a surgeon in Palestine, and I had the privilege to be a global surgeon, expert global surgeon. So I understand, maybe I would claim that I understand more about how local people would think seriously when they have these missions come. The local surgeon will have weak organizational environment, and the burden is on his shoulders or her shoulders, which he must go through training and learning. So the surgeons are unlikely to be motivated because the system doesn't give motivation. It's not the lack of instruments or implants. So global surgery might help in this way, that it can participate to, within the context of these countries, can improve the organizational issues within limits, but can support the local surgeon in beginning activities that will facilitate some structural changes in the future. But it's beyond their shoulders to change the context. Of course, it's a political issue, it's related to the country, but we need to focus on how to help the local surgeons to put a structure that can be sustainable for these complex surgeries. So, for example, in training, we need to differentiate between knowledge and information. Information is a blueprint. You give information, which is something that we need to give, but it's not the main issue. But the knowledge is involving solving problems that are unstructured, and it cannot be done except with learning by doing. And this is the most important issue, involving the local surgeons more and more in the activities that you go through these programs, and not just giving advices or giving solutions. It cannot work like that. Looking for champions. If we don't acknowledge this, we will not do anything. Actually, you can have the support of the Minister of Health, you can have the support of everybody, but if you don't have the support of the people on the ground, the local people who are working on the ground, you cannot do anything. And with the mal-organized structures in general for low middle income countries, These people who begin this issue are pioneers, real pioneers, and they are putting on their shoulders doing this complex activity in a media full of skepticism, full of mal support, full of whatever you can say, and he or she should go on with all these difficulties and do these things. Or in my practice, what I have seen in my life, that all what I need when I go to a country to begin a scoliosis program or a complex spine program is to look who is the champion that we should focus on. And this champion will begin the activities, and he or she will have many difficulties to go through, and they are near the key guys, and they can have connections, and they do some politics, and they can succeed most of the time, and it's not even guaranteed. But you need to focus on these people because they know their country much better than you as an expert surgeon, and they are motivated, should be motivated, and it should be, they are well focused, should be well focused. All what you need is support them in the lack of knowledge and the access of skills. I think this is one of the major issues that we sometimes don't acknowledge in our activities. Because of that, when I insist, for example, when I went to Nicaragua or Kenya or Tanzania, that I should have two people, one neurosurgeon, one orthopedic surgeon, to be with me in every surgery, and they should be in charge for pre, post, intraoperative, and they shouldn't change because you need to give them knowledge, and these people will be the scoliosis surgeons in the future. So they'll disseminate after that knowledge. Don't think that because you are an expert surgeon, you can disseminate knowledge or the wishful thinking that you'll succeed. It cannot come like that. Without the local surgeon that is motivated, you cannot do that. Experts are abroad. If you know that 80% of all orthopedic surgeons are residing in 26 advanced countries, developed countries, and the concentration is higher even for orthopedic spine specialists. So the champion is very, very important, and you know, you cannot even, one who can go through these difficulties and succeed, this local surgeon need full support from us. Training program. So it's important also to deal with these things with feedbacks, because you need to know what you are doing, and you might change the plan in coordination with the local faculty that is in the country that you are going to. So you are sure that you are proceeding, you are improving. It's not that you are going from scratch every time. Due date, and this is one of the issues that is lacking in general in missions. When I went to Nicaragua first time, I talked to the Minister of Health, and I told her, I will not say to you that it's an indefinite time to do surgeries. I promise you that you'll have, after 2 years, a local team that can do the surgery. You must be dedicated to some time that you can have local people, local team that can do it, and you need to think how you can do it. It's not an indefinite thing. Collaboration over hierarchy. We must know that it's not like a one pathway, just information coming from the global organization to the local organization or to the local doctor. It is a two pathway, and there should be more of a two-way communication, and it should be collaboration. It shouldn't be a hierarchy, somebody in the top and somebody in the bottom, and all of the information come from top to the bottom. This will not work. Also, there is a problem, local and international surgeon relationship. This is a problem that not many people would like to talk about. And I published a paper in the JBJS about that. There is a problem that
there might be kind of student-master relationship forever. This is not right. And unfortunately, it might come with the interest of both sides. The global surgeon is happy to come every year. He is, of course, treated like God, and everybody likes him, and everybody waits for him or her. And the local surgeon would be away from any complications that might happen, but he is part or she's part of the process. This is not right. Should be some sort of a definite time that this local surgeon should be with some time equal to the global surgeon, and with specific knowledge, with specific experience that he or she can have. And the local surgeon might, after some time, be a global surgeon with the global surgeon that was teaching. This is a very important issue. Data and research. This is a big problem. In low middle income countries, the least issue that we are interested in is gathering data and putting the data. And this is one of the main differences between developed and developing countries. In developed countries, everything is registered and you are having a clear data about it and you can have information from it. So we need to put guidelines that are readily culturally adaptable, evidence-based, financially sustainable, easily accessible, but not ineffective, harmful, or wasteful. Obstacles preventing dissemination of pediatric spine surgery in specific. Surgery was relegated as low priority in global health. You know, when you talk with people, global people, they might tell you that, well, malaria might be, cholera might be, TB, but it was, surgery in general was not a priority. Many short-term missions were used as an alternate, or I might say an excuse, not to implement permanent pediatric spine management. Misconception of high per unit cost of pedicle screws. So what has changed nowadays? Actually, there is a big change globally in the pediatric spine. There is an increased awareness about the importance of the problems and the importance of early management of scoliosis cases. I mean, 20 years ago, when I first came to Palestine from the US, the trend was, well, let the patient continue until they finish their growth. And it is a catastrophic issue. It was a myth that was unfortunately well known in many low middle income countries. Epidemiological shift with the global industrialization giving importance to surgery as an important health factor. Global activity has changed from short-term. Actually, now the organizations are now focusing more and more on educational, not missionary issues. The change in perception of high specialized surgery has changed. Awareness of the effects of the globalization, and we can realize with the COVID, nobody is away from the danger. So now we are really a small village and everybody wants to improve health problems in these countries. And also there is something, the middle class in most low middle income countries are expanding, and with the internet, there is now a difference in the thoughts, and they are more demanding, and you need to have to cope with the demands and the ambitions of the middle class in low middle income countries. Now, artificial intelligence has a great role in training programs for spine, if utilized in global training programs. Actually, I think this is the real future of training for complex spine surgeries. So this is an example actually, this is a surgery. This is my hand. I was at that time in Palestine, and they were doing in Nicaragua a surgery. This was the first time that they do it alone, and I was guiding them through my hand, and I was, I have a short video, but unfortunately because of time, I wouldn't put it. You can say, go here, go there, and even you can look at the CR and tell them, no, go downwards or upwards, exactly as if you are in the OR, but you are not scrubbing. So it's a great support for the surgeon in these countries. Because you can, the local surgeon can have information from the YouTube and can see everything. But in the OR, it's a different story. He or she needs a real backup. And the real backup cannot come with frequent visits because of inability for a surgeon to come 6 times a year or 7 times. So this might play a good role. Pioneer's role. If you succeed, you'll be a pioneer also in your region, and you'll be a model for your young surgeons to do whatever you do. A story of success of any local surgeon will be a story of success for the team, and a story of success that will help other surgeons to be, younger surgeons to be motivated, which has a huge role also. So, and also, in low middle income countries, there is nothing called lobbying. It's not like in the West. You should, if you want to have a successful program, you should attach it to either a university hospital or a university or the MOH, Ministry of Health. And here is in Nicaragua, this is the Minister of Health. And here is the attachment with a university hospital that will make these programs sustainable. Otherwise, you'll just do a mission, a couple of children will have benefit from your surgery, and that's it. And also there are blended learning courses with digitalization. You can activate the local surgeons through blended learning courses. These have specific protocols, and we did a one in Tanzania through Will Cornell, and we did a one in Latin America. Actually, in Latin America, 300 people were doing that for 3 weeks. And for Tanzania, Massimo Balzano was with me also in the blended learning course, and it was very successful. So what I'm doing now, my main issues now is how to give the local surgeon the facilities to do the surgery within the context without paying too much money. One of the examples is that the APC technique that I'm doing. This is a surgery that we did in Italy. Dr. Balzano invited me to do the surgery, and you can see the early onset scoliosis, you need to do it, you must do a 96 degrees Cobb angle. But if you don't have resources, you can do it with just regular implants. So we need to think about these things. We cannot change the policies, but we can put some scientific ideas that are appropriate scientific ideas, updated, evidence-based to some extent, to the local surgeons to do it. So this is one of the issues, and now I'm more and more going to research, to have multi-center studies to prove the efficiency or the non-efficiency of this technique, and to modify it more and more to be within the context of with low middle income countries. So, and also the other thing is the proctorship program, which I've shown you about Nicaragua. Actually, this is a case with scoliosis. The team in Nicaragua, this is the third case, by the way. They didn't even call me. They have done it alone. So now in Nicaragua, after just 2 missions, I went just 2 times physically. And after that, they are doing the adolescent idiopathic 50 to 70 degrees alone. And this will make you, when you come back, to raise the bar, to do something more. It's not just going from scratch. And this is one of the most important things I'm working on, because I think this is the future, especially for doctors in low middle income countries. You avoid the visa problems, financial problems. So the advantages of this proctorship, it's non-costly tool. It can be used connecting many areas at the same time. So even in India, you can do it in a center, and you can also expose doctors in district rural hospital to it. Up to my knowledge, it's the only educational tool that support the surgeon in the OR during doing the surgery. It can be used in both ways. Either the surgeon, the global surgeon will do the surgery, and the others will look at it and will participate by putting their hand and asking, or other way. Can be used for any other surgical procedure also. Now the specific aims that we are doing, develop assessment rubric for posterior scoliosis surgery, to use this rubric to assess the competency levels, to evaluate the improvement of competencies. This stage one we have done. We have the support from the AO spine, the global spine, with this program. So we had a modified Delphi process, and we had establishment of a Delphi panel, development of list of competence, evaluation. This was done, and we have finished it recently. And we are going to stage two. Hopefully we'll begin in Kenya, but think seriously, it might have a real chance here in India to do. And another thing, which is humanitarian, you know, when you are beloved by your people, by your patients, and you are beloved by people from other continents, these are girls who gathered to say hi to me from Nicaragua. All of them, I did scoliosis cases for them. And this is a girl that I did scoliosis in Rwanda, and this is her aunt. Her aunt is a nun. She knew after 1 year that I came to Rwanda, to Kigali, and she was 250 kilometers away. She came immediately just to say hi and to have coffee with me. This is something we truly appreciate in our work. The most important, one of the most important thing is adding friends and having friends. And this is a privilege for a global surgeon to do and to have. And this is Dr. Peter Kolonzo from Kenya. He's the head of the Orthopaedic Association, and this is his family. He was kind enough. And of course, you know, Dr. Balzano and all of our friends here. This is from Vietnam. And this is Dr. Martha Hernandez. She's the first spine surgeon in Latin America, and she invited me to Ecuador. She's a lovely lady. Unfortunately, she have passed away 1 month ago. She was a great lady, and she was doing great things in Latin America. Thank you very much.
Thank you. Up next, we have got case presentation on early onset scoliosis. Amongst the panelists, we have Professor Dr. Alauddin Ahmed, Dr. Robert Crawford, and Dr. Shomajit Basu. To talk brief about Dr. Robert Crawford, he is a consultant spine surgeon, past president in British Scoliosis Society UK, chair of the Grants Committee UK, and is a retired consultant spine surgeon having practiced in Norfolk and Norwich University Hospital. He is a member of the British Association of Spine Surgeons, the British Orthopaedic Association. He has been involved in the development of British Spines Registry and continues to promote its use. He is the reviewer and guest editor for the European Spine Journal. I would request Sir to come to the stage and take a seat. A round of applause for Sir. I would request Dr. Shomajit Basu to come to the stage. He is the consultant spine surgeon in Kolkata, president-elect ASSI, actively involved in Scoliosis Research Society, program director AO Spine Fellowship, Clinic, Kolkata. He has performed about 1,500 spine surgeries till now. His area of interest includes spinal deformities and cervical spine. And I would request Professor Dr. Alauddin Ahmed to come to the stage. For the case presentation, I would request Dr. Rajesh Chaudhary, who is MS Ortho, Consultant Orthopedic Spine Surgeon, Treasurer in the Association of Spine Surgeons of Nepal. He has got publications in different renowned journals and possesses expertise in spine surgery. A round of applause for the panelist and the case presenter.
Good afternoon, everyone. First of all, I would like to thank Dr. Ujjwal for inviting me and allowing me to share my case. And I am very privileged to have my esteemed panelists, Dr. Ala, Dr. Crawford, and Dr. Subhas Basu, Dr. Basu. So the main aim of this case presentation is to show how the cases get neglected, present late with severe deformities, and what are the challenges that we face while managing in the low-income countries or the resource-constrained situation. So please, can you share my presentation? It's in the desktop. Dr. Arkes. So I think we are waiting for the presentation. Yeah. Okay, so please share my presentation. So yeah, thank you. Yeah, thank you. Thank you. Today I'm going to present one case. This is another the ideal case from growing rod maybe, but we have applied the growing rod in case of thoracic insufficiency syndrome, and we'll be discussing and getting information from our esteemed panelists. So before starting my case presentation, I would like to show my hospital where I work. This is the 100-bedded small setup where this is the Hospital and Rehabilitation Center for Disabled Children, HRDC, 30 kilometers away from Kathmandu, and here we do charity work. Basically, all the children with different kinds of deformities like clubfoot, DDS, cerebral palsy, all kinds of spinal deformities are treated, and we as a spine surgeon, we look after the spine deformities. And due to some different kinds of constraints, we just operate 2 cases a month, so average of 30 to 40 cases per year. So the main objectives of this case presentation and discussion would be to discuss the challenges in management of such cases that I'm going to present as a representative case in Resource Constraint Center, challenge in follow-up of such patients and its impact, the challenges in management of patients in context of poor socioeconomic background, and of course the scientific discussion about the best management option in such cases. So this is X-ray of a 5-year-old girl who presented with deformity on her back. Her parents noticed deformity when immediately after her birth, her parents noticed the deformity. And this X-ray was taken 5 months at the age of 5 months in the other center. I think in this X-ray we can see there are lots of congenital anomalies like multiple fully segmented hemivertebra. There is rib fusion in the multiple levels with scoliotic deformity, right-sided scoliotic deformity. So now she visited our center about around 9 months of age. And this was the X-ray. Again, this X-ray shows the more clearly the congenital, multiple congenital anomalies, multiple rib fusion. And at this stage, this was actually in 2011 when I was in postgraduate training, and our mentor, he advised for Vector. But Vector was not available in our country, and we are not trained for this application of Vector as such. So we referred the patient to the higher centers. I would like to come to the panelist. Basu sir, what would be your approach in this case? How would you, what would be the management?
Thanks Rajesh for sharing this case. The first and foremost is I'd advise you to look beyond the spine, because whatever you see as a spinal deformity, you need to assess the spinal cord regarding neuroaxial anomalies. There is about a 20 to 25% chance of a neural anomaly. You also need to do an ultrasound of the abdomen, because there is about a 25 to 30% chance of a genitourinary anomaly, and also echocardiogram to rule out cardiac anomalies. So whenever you get a patient like this who comes to you with a major spinal deformity at such a small age, it is mandatory that you do an MRI, an ultrasound of the abdomen, and an echocardiogram to rule out other congenital anomalies. I will ask Dr. Crawford to further details.
Yes, thanks. Well, first of all, I should say that we wouldn't actually treat such a patient at our hospital, as we don't have a fully fledged pediatric intensive care unit. But I quite agree that you need to do a considerable amount of diagnostic workup with imaging and looking for other congenital abnormalities. And it would be important to get on and address this deformity, because it's a very early onset, severe curve. It's unusual to have a congenital spinal deformity be visible at birth. But these ones with congenital effused ribs do present a significant problem, and I would look for a centre that does use the vector or an equivalent implant, because it's primarily a chest problem rather than a spine problem that needs to be addressed. That would be my view.
Dr. Ala, you have something to add on?
You can fix it. As my previous colleague said, when you have a congenital deformity, you must check for all congenital deformities. MRI to exclude any intraspine lesion, echo to exclude 30% are having cardiac problems and 25% are having urological problems. So you need to do ultrasound of the pelvis and the abdomen. And to check for any, because you are treating here a child, you are not treating here a spine. But what I've seen here is that there is I think this is the left side, am I all right? Because I don't see the heart, so I don't know. Anyway, this side is having a unilateral bony bar.
Yeah.
And on the right side, or on the other side, you are having a hemivertebra, which is the worst in progression, actually. And you need to do something. Vector, if you look, by the way, Vector now is decreasing in use
much far than before. So, but the vector is very big, it's 7.4 millimeters. So, I mean, it will just go out of the skin, and it cannot be used in this age and in this child. Whatever you would use is really challenging and dangerous. In my practice, I prefer to begin doing surgeries for children around 3 years of age, not less than that, because the implants are prominent. Whatever you do, that is aside of the complications that might come from anesthesia or surgery by itself. But now I'm really supportive to casting more and more in early onset scoliosis, especially in these children, that you cast them, but you are under general anesthesia with like the meta technique. But you must tell the family clearly it's not a therapeutic issue, it's just buying time. Because if you leave this child, she will be 90 within the next 6 months. So at least something to buy some time. And in the literature, they said that there is you can buy 39 months in dealing with early onset in general, of course. So I would think I would go for casting under general anesthesia for this child. But after full evaluation, full diagnosis of this.
So we also usually, we have the protocol like we do USC, the abdomen and echo and the MRI, but usually we do before going for any surgical interventions. But I think that's the very important point that we should follow. And Dr. Ala, what would be your protocol in casting? Like how would you follow and
Well, in casting in general for early onset scoliosis, we need to differentiate. There is infantile idiopathic scoliosis. Casting might be fully therapeutic if it's done below 1.5 years of age, if the child has less than 60 degrees scope angle. So we need to acknowledge that and do it. Below 2 years of age, you change the cast every 2 months. After 2 years of age, you change the cast every 3 months. After 4 years of age, you change the cast every 4 months. This is according to Sanders' new technique. Previously, you put the cast for 6 months and then you change it. Of course, there will be 1 month of bracing as a comfort from the cast, you know, a relief from the cast. But for these cases, also you do the same issue, but in a different way. You look at the child, and it's not necessarily every 3 or 2 or 4 months. You assess the child, how much improvement did he or she have, and you must put always in your mind that this child will go to surgery. At least, how can we just stop it? So you might put the cast, for example, for 4 months, 5 months. If you see that the child is to some extent balanced, keep it.
Okay. I think to be frank, like in our center, almost none of us are that much trained about casting. And another important thing that the challenge that we are facing is the patients are from the remote areas and we are not able to follow them in a regular basis. So that is the main challenge in such conditions. And in this case, he was as I said, he was advised for that, but he did not go for that procedure. And he visited once again, but he lost the follow-up. And she presented 7 years, at the age of 7 years, almost 6 years, almost 7 years after the initial presentation, and this was the deformity she presented with this X-ray is in as if she is in the prone position, so the left side and the right side is kind of so it is severe deformity with rib fusion, again the same kind of finding, but the severe tongue shift on the left side, the shoulder imbalance, the pelvic imbalance, and then the CT scan and all the MRI was done. There was no intraspinal pathologies as such. in this case. So this was the clinical picture at this moment. The severe trunk imbalance, shoulder imbalance, pelvic imbalance, and the ilocostal impingement on the right side. So at this stage, how can we proceed further now? Dr. Basu, can you just?
Thanks for presenting this interesting case. At this point in time, if the child comes to me without any neuraxial anomalies, I will definitely go for halo. I will put him on halo gravity traction for at least 12 weeks and check out how much the flexibility of the curve is. Young children would respond better to halo, and considering the fact that there is a hemivertebra at the dorsolumbar region as well as in the mid-dorsal region, at least in the lumbar spine, the costopelvic impingement shall be definitely better, and the imbalance of the shoulders will be better. So once the correction is completed to some extent after say a couple of months or 3 months of gravity traction, then I will consider some sort of a growth modulated implant with apical fusion. The areas which needs to be fused would possibly include the mid-dorsal spine. If you can go back to the CT scan, there is a hemivertebra as well as an unsegmented bar on the opposite side. If you can go back to the CT scan. One up. Yeah, here you can see that there is something going around in the mid-dorsal spine or lower dorsal spine, which is the apex of the curve. So we can do a short segment hemivertebral resection or correction at that point, which would be an apical fusion, and then balance the rest of it with a growing rod from T2 to L4 and check out for the next couple of years, or she's now 8 years. So for the next 3 or 4 years, go on expanding every 6 months, and then she will definitely be planned for a definitive fusion, which would be a very long construct, possibly from T2 to L4, sometime at around 12 to 14 years age.
So would you do something with the fused ribs?
So if you are planning to put on vector, we do a what is known as a osteotomy at the level of the fused ribs, which is open thoracostomy. But with these fused ribs, so far as the spinal deformity is concerned, I wouldn't be too aggressive on them, but rather be aggressive on the apical fusion part of it, because that is which drives the deformity.
Thank you, sir. Dr. Crawford, anything to add on?
Thanks for giving me such a simple case to start off with. This is a horrendous problem. You've got a severe lower thoracic apex there. I think it's lower thoracic, and also a very bad takeoff angle from the pelvis. So you've got to try and keep the child reasonably in balance, and which is not at the moment, but you certainly don't want to try and avoid making that worse. This curve is going to be extremely stiff with all the congenital anomalies of the spine and the fused ribs. And again, I think addressing the rib problem is part of the solution with a vector. I would want to look very carefully at the axial imaging to see whether there's a segment on the convexity of the curve that looks like it ought to be fused. There is a hemivertebra there somewhere that I saw. If you can reduce the growth in the convexity of the curve, then that is something worth considering. And I agree, a period on traction to see how much flexibility there is available in the curve overall, which you'd want to continue for probably a few weeks. It's quite a slow process.
Dr. Crawford, Dr. Ala, anything to add on?
I fully agree with putting a halo traction in the beginning if you have the facility to do that. And to deal with that, though, to be honest, I don't have experience in halo because the insurance policy doesn't give us a chance to put halo in Palestine. But put halo traction, correct as much as possible, then go and do surgery. For the surgery, let us not be idealistic. You are the one who will face the problem, and you are the one who will be confronted if the patient has paraplegia. You have, in my opinion, you have two issues to do. Just do a hemivertebrectomy on the apex of it, and try to control the apex of the curves with a couple of screws or 3 screws that will at least maintain the apex and do some compensation. Some compensation with growth and try to distract within the dominoes. Other thing, if it's really hard and you don't have enough facilities, just do it as an internal brace. Two anchors above, 2 levels of anchors above, 2 levels of anchors below. Put a rod, do distraction every 6 months. At least you will prevent the progression of the curve until the child grows. So, I mean, safety is the most important issue for you. Be sure about it. This is mine.
Thank you. In this case, like in routinely we do PFT also on the pulmonary function test in such cases. And in this case, the pulmonary function test was severely restricted, and anesthesists, they were very reluctant to give long anesthesia. So they also advised us for quick procedure. So, after my fellowship, we had just started putting growing rods in cases, and we thought, why not put growing rod in this case, as you also mentioned. So we put growing rod in this case, like this was the 2 anchors above. Due to severity of the deformity, we just put 1 rod. It was not dual rod. So domino was connected, and it was distracted every 6 months. And there was breakage of the implant, and again we revised it. And due to COVID pandemic, she lost follow-up, and this was the clinical picture during the follow-up while distraction. And there was not much of distraction while after many, like maybe the rule of diminishing returns kind of thing was occurring there. There was not much of distraction as such. So at that phase, we just assessed the fusion, and there was quite good fusion. So we removed the implant, and this is the current status. This is the X-ray about 5 days back. The clinical picture. These are the comparative X-rays and the comparative clinical picture. And she is now 13 years old, studying in class 8, and she is happy. So I think what we achieved in this case, we did minimal deformity correction. And most importantly, we prevent the progression of the deformity. So, lastly, anything to discuss? Maybe.
I think Rajesh, you have done a great job. We've been able to control the deformity, and the more significantly, we've been able to reasonably control the pelvis. The costopelvic impingement is a bit better. It's all fused now. And she's now 13. If she continues to grow and if she continues to worsen on her curve, then a VCR is on the cards. But again, if you leave it like this, and if she doesn't grow and if she's happy with her cosmesis, then that's it. You've done a great job.
Thank you, sir.
I think you have. I'm not quite sure how long post-op that is, but I think you have achieved some correction with growth, or at least the trunk to leg proportion looks better than it was to start off with, to my eye. I wasn't quite clear, did you do any fusion on the convex side? It's just all fused anyway, is it?
Yeah, it was all the posterior fusion, the interlaminar fusion. We are just decorticated the lamina and just fused it.
Okay. Thank you.
I think we stop here because we got long time. Oh, we already delayed by 1 hour. Okay. In the program. Thank you very much. Next speaker, please.
Thank you, sir.
The next case presenter, Dr. Shubhadeep Chakraborty, ortho resident of JIMSH.
This is an example of what Dr. Ala was saying, to hold on until you fuse later.
Very good afternoon to one and all. Myself, Dr. Shubhadeep, I'm a postgraduate resident in the Department of Orthopaedics at JIMSH, and this has been done under the guidance of Professor Dr. Ujjwal Kantadevna, sir. We have a patient whose name is Tithi Pan. She was a 16-year-old female and had early onset scoliosis with a right-sided thoracolumbar curve. She was diagnosed at the age of 5 years in 2012. And she had undergone 5 surgeries, the first being in 2012 and the last being in as late as 2020. Here the history of the growth rod surgeries that she has undergone. She had a growth rod in situ with anchors at T4 and T5 proximally and L1 and L2 distally. And then she had annual growth rod increments, and the last date of surgery was 2016 Feb. And the spine was decompressing from 2018, and when she was 13 years old in 2020, the change of pedicle screws and rods were performed with 4.5 mm screws in the upper segment and 5.5 mm screws in the distal segment. The technique that was used was active apex correction. Now I'm going to show some images. Here, this is the condition of the patient when she was 5 years of age. We can see the clinical photos and the x-rays in anteroposterior lateral views. This is after the first surgery, where the rods were put. This is the follow-up in 2016. This was a follow-up in February 2020, and at this point, the apex correction was done, and this was post-op in March 2020. This was the patient came to us in April 2022 for a follow-up. This was March 2023, and in this setting, in this year's OSS workshop, this was done on the 4th of April 2023, a revision surgery. There was removal of the implant rods, and new screws were placed at D12, D11, D10 on the left hand side, and on the right side she was put a new screw in the level of D12. And osteotomy and correction was done. These are the post-operative x-rays from the surgery that was done on the 4th of April 2023. This is where she was at 5 years old, and this is a photo when she was 13 years old with Dr. Ala and Professor Ujjwal Kantadevna, sir. Thank you very much.
Okay, we go on to the next program is AIS Lanky 1 curve. A case presentation would be done by Amitosh Pandey, and I invite the panelists in this case, followed by debate on the standards of treatment of anterior versus posterior. So Apaji Krishnan, please come to the dais. Dr. Girish Swami, Dr. Raghav Muluktala, and Dr. Ankur Nanda. 4 of you, please come to the dais. And Amitosh, please present your case. Okay.
Next, we have a case presentation by Dr. Amitosh Pandey, author resident of JIMSH. In the panelists, we have Dr. Apaji Krishnan, Dr. Girish Swami, Dr. Raghav Muluktala, and Dr. Ankur Nanda. To talk a brief about Dr. Apaji Krishnan, He is a consultant spine surgeon, Chennai, over 21 years of experience, MBBS from JIPMER in Pondicherry and specialized in spine surgery at JIPMER and Apollo Hospital in Chennai. He has participated in national and international academic forum as a guest lecturer and faculty member to share his knowledge of spine surgery. He has got clinical practice in complex spine surgeries to treat spinal deformities and complex ortho trauma conditions. We have got Dr. Girish Swami, FRCS in Trauma and Ortho, consultant spine surgeon from UK. He is the coordinator of the Senior Norwich Spinal Fellowship training senior spinal surgeons for future consultants positions. He has got publications in over 30 peer-reviewed journals and book chapters. He holds honorary academic position in several overseas universities. He has got clinical practices in treating all forms of spinal conditions affecting the cervical, thoracic, lumbar, and sacral spine, including spinal deformities in children and adults. We are also having Dr. Raghav Dutt Maluktala in the panelist, who is the Chief of Spine Surgery and Consultant Orthopedic Surgeon with Omni Hospital Orthopedic Center since 1993. He is an additional professor of Orthopedics, SVS Medical College, Mehboob Nagar. He is the international faculty of AO Spine International 2012. He has got expertise in the areas including all aspects of spine surgery. We are also having another guest in the panelist, that is Dr. Ankur Nanda, who is a consultant spine surgeon, ISIC New Delhi, one of the leading spine surgeons in India with 18 years of experience. He has performed more than 3,000 surgeries over the last 7 years. He has expertise in spine surgery, spinal instrumentation, spinal cord injury, and management of critically injured patients. We shall begin with the guest presentation.
A very good afternoon to all the faculties and delegates present here. I am Dr. Amitosh Pandey, PGT first year from Department of Orthopaedics. Today I am going to present a case. A very good afternoon to all the delegates present here. Today I am going to present case of a 15-year-old female who stays 200 miles away from Kolkata in Murshidabad, presented with 95-degree curvature of thoracic spine T3 to T12 and diagnosed as adolescent idiopathic scoliosis. And I may request the panelists to give their opinion on this. I'm requesting Dr. Ankur Nanda sir, kindly give some opinion.
Yeah, so thanks for starting with me. So this is although I can't see the x-rays very clearly, but I assume this is an idiopathic scoliosis with a main thoracic curve. So whenever we see these curves, what we are interested in is basically also assessing the other areas of spine, whether the upper curve is stiff, whether the lower curve is also stiff, how much is the bending. So we'd like to get some more investigations done in the form of bending x-rays, traction films, and try to understand the deformity better. It's a right-sided thoracic scoliosis, so I'm not expecting it to be having any intraspinal anomalies. But a thorough neurological examination should also be carried out. See your cutaneous markers if they are absent. And if you are convinced it's idiopathic, then you can, plan further.
Thank you, sir. I am requesting Dr. Girish Swami, sir, kindly give some.
Thank you. Is it okay if I stand so I should point out as well? So the key question here is, was it a boy or a girl?
So female, girl.
Okay, how old is the child?
15 years.
15. Yeah. And is she pre-menarchal or post-menarchal? So menarche?
Post, sir.
Post-menarchal. Okay. So these are all the relevant questions you have to ask, because you get given this patient who comes to you, pitches in front of you, and you see this big massive curve. But what is more important is this curve, will it progress? Will it get even worse within the next 2 months, 3 months? And how would you address this? There are several factors. This is a right-sided thoracic curve. One slide back, please. But equally, the challenge is the shoulders are equal. So what would your correction techniques be? Where would you go from the top? What would your upper instrumented vertebra be? What would your lower instrumented vertebra be? And what is the technique you would use to correct the scoliosis? Because over the last week, we've been discussing with a lot of our fellows and other surgeons about the different techniques. Would you go for a cantilevering technique? Where would your anchors be in the top? Where would your anchors be in the bottom? Would you be able to derotate the spine? Would you have to do any osteotomies? Will you have to do further procedures? And as my colleague here said, you need a lot more investigations, MRI scan to make sure that the cord is okay, bending films, or even bolster views, whatever your standard practice is, and then plan your surgery accordingly. And in my practice and in our practice in Norwich, we do predominantly posterior surgery. We would address this with a single stage posterior scoliosis correction, and we would do pedicle screw. And my own technique, which I learned from my mentors Hilal Nuddin and several others from Stanmore, I do cantilevering as my primary technique. But if it's it also, but don't be fixated on one type of technique. You really need to understand that there are sometimes you have to use different techniques to address the tool. So whatever tool technique you're used to, use that. But the upper instrumented vertebra, the lower instrumented vertebra, and what's the rib hump, and I would do it all in posterior single stage.
Thank you so much, sir. May I request Dr. Appaji Krishnan, sir, please, sir, give some opinion.
Morning, everyone. So, as I agree with Dr. Girish and Anku, we have to rule out whether the upper thoracic part, the proximal thoracic curve, has become stiff or not. If it is not stiff, then it becomes a straightforward Lenke 1 and posterior correction. T2 or E4 to L1 should be the maneuver, and whatever maneuver you're familiar with, rod derotation, osteotomies, and cantilever technique should do.
Thank you, sir. Thank you. I am requesting Dr. Raghav, sir, please, sir, give some.
See, whenever you present a case like this, we need a clinical picture because we need to see where the shoulders are. Now, if you look at the X-ray there, I'm not too sure whether the hand is next to her or is elevated on the X-ray. Fundamental is to show us the bending films. Now, I agree with all of that, but my own principle is if the correction on bending films is less than 50%, even if it's very rigid, I would do an anterior posterior in these patients. It all depends on the correction that they get. But again, if the correction is more than 50%, I will certainly do pontes here. And the top part, I'll put hooks rather than screws because we may have to go to T2 here, and then we have to be very careful because if we put pedicle screws, we may push the shoulder up. The lower level again, I may have to go, I can't see from here clearly, may have to go to L2 to get a good correction.
Thank you, sir. Next. So, after that, she has, next slide, next. Yes. She has done her surgery in 2013. After that, the surgery was very difficult and multiple osteotomy were done, and 2 rods were placed for the correction of the scoliosis. And during follow-up, there is a considerable reduction in the correction, and she is happily married and she is doing well. And also she is going to have a baby soon. Thank you, sir.
Just a comment to the audience. what they have used is hooks at the top using a claw technique. So you're just stabilizing the top segment, especially if it's a stiff upper curve. Then if you don't stabilize the top segment, then that'll be the point of failure.
Yeah, that's very important because we had to level the shoulders. The shoulder was down on one side by at least an inch, and she came like that, and she was tilt, as well as there was a truncal shift, you can see. And so we had to correct everything on one go. So proximally, we had to use this anchor of hooks, so we can close on one side. Okay, so we go on to, thank you very much, panelists, and we go on to the next stage of the program is we have a debate here about posterior fusion remains the gold standard. It will be spoken by Dr. Samajit Basu, and anterior tethering is the best treatment in AIS, Dr. Massimo Balsano. So I invite Dr. Basu to come to the dais and deliberate his talk on posterior fusion remains the gold standard. Dr. Basu? Huh? What did you say? Oh, yeah. Please do come in the debate, yeah. Please come on to the dais. Dr. Massimo Balsano and Dr. Samajit Basu.
Can we have the presentation up, please? A very good morning. Sorry, it's afternoon, and I'm thankful to the organizers for asking me to speak on this debate. I'm sure it will be a very interesting one. So we have a Lenke 1 curve. We do not know the age, we do not know the premenarchal status of this patient, let's see. And we go on to protect fusion and see what we can do. So we have a growth modulating technique here, which is a vertebral body tethering, which is the concept of modulating spine growth differentially. On the other hand, we have a fusion technique, which is a concept of permanently correcting the deformity. Now, when applied to scoliotic spine, means arresting growth at the convexity and promoting to the concavity, so that there is a differential growth and hopefully the spine would stabilize and retain motion. As against that, we're trying to protect a fusion technique, which is basically means a fusion at the convexity and concavity to prevent progression and to obtain a permanent deformity correction. Now, if you really look at the growth of the spine, you would realize that approximately at 10 years, you have 80% of the thoracic growth and about 90% of the lumbar growth nearly completed. So what we are looking at is during these 3 growth periods of life, you have below 5 years, 5 to 10 years, and at the level of the puberty, in which you can see that the maximum growth occurs in this case, that is in the period, in the time of puberty. So in this area, we are working upon and we are trying to debate whether fusion is better or whether vertebral body tethering is better. Now, the concepts are not valid here, it is only valid there, and the concepts are not, this debate doesn't occur here when the child is nearly fully skeletally mature, that's about 2 years post-menarchal in a lady. Now let us look at the 3 criteria or 4 criteria which I have organized. So VBT has emerged from concerns about the use of fusion for treatment of scoliosis and its related complications such as loss of movement over segments, leading to permanently decreased spinal movement. Now, what is the range of motion of the thoracic spine? A patient who has a completely mobile lumbar spine, a completely mobile hips, can bend down and touch her toes anytime. The next is, VBT holds the promise of mitigating these complications by preserving the flexibility of the spine while applying corrective forces in the scoliotic spine using intraoperative positional corrective forces and growth modulation using the Hawk-Walkman's principle. Now, after this position is done, a patient who has a 60-degree or a 70-degree curve, there is a significant residual curve, and how does VPT manage them? The next is, utilizing the flexibility of the curve, the correction is done in positioning in lateral decubitus position, and it allows a little bit of manual corrective maneuver while applying the cord which connects the tethers. Now, the issue is how much is the flexibility of the curve and what happens to reasonably rigid curves. Even if it's a 60-degree or 40 degrees curve, it might be rigid. And so what is the solution? It's a large residual curve in VBT. Now, regarding further correction obtained, what happens if the tether snaps? There are many patients whom we see. We'll be visiting a paper recently addressed the retrospective study, in which they've shown that there is a 16% revision rates. So what happens if the tether snaps? Now, there is a 16% reoperation rate, as I told you. Now let's go to a case example. A nearly matured, completely matured 14-year-old female, right thoracic AIS, 2 years post-menarchal. So is there a question of a VBT here? It's a 60-degree curve and it is a 27-degree thoracic curve, 60 correcting down to 35 on the bend films and 27 correcting to 10 degrees. So obviously the lumbar curve is not addressed. It is a thoracic fusion only, and this is a one-step surgery with a completely balanced spine from 60 to 10 degrees, as you can see, with a well-maintained thoracic profile also. So these are the pre and post-op clinical pictures with level shoulders. And as you can see, this is from the internet because I don't use VBTs till now. So this is a 12-year-old female with a reasonably similar 50-degree curve. And the challenge is, with this beautiful looking X-ray, does VBT control growth till skeletal maturity? This is a gray area which we do not know in the next 5 years what's going to happen to the curve. So that is where the concept is not one of finish it and letting the patient go off. Now let's look at another case example, which is a curve above 60 degrees. VBT is definitely not an answer to this 70-degree curve, and you can see that the fusion results in a good curvature with a balanced spine, the lumbar curve straightening up. And does VBT address large curves with hypokyphosis? And you can see that the hypokyphosis has been well addressed too. Now let us look at what are the so-called parameters over which VBT scores above fusion. Now the accepted indications are immature patients, the Cobb angle 30 to 65 degrees, failed brace treatment, or are unfit for brace therapy. Age group should be usually Sanders 4, 10 to 12. The tweeners are the best mistakes of me. The relative contraindications include high curves. That means if you have to go above T2 or before, that's a real challenge. And curves which are more than 40 or 45 degrees, that's another major challenge. The area of VBT usage means that the indications are very narrow, and this is a perfect surgery for a narrow group of patients. Now let's look at another case example, which is typically used for tweeners. This is an example of a 10-year-old female. She's the daughter of a doctor, and she came to me at 10 years with this extra 70-degree curve, traction films reducing to 30 and bending films reducing 6. And at 10 years, she has significant growth left in it. So I had a discussion with the child's father, and we put her on a growing rod, and I said that we have to revise this to a definitive fusion in the next 3 or 4 years. And we started off with 30 degrees, which was the traction films correction, which was achieved. And this is first expansion, second expansion, third expansion. And this is after 13 and a half years when I converted it to full fusion. As you can see, this is the up and down scar of the growing rod, and this is a full scar of the final fixation. And this is 70, 30, and 12 degrees. So at the end of the day, you leave a patient with a permanently fixed spine, but with again 3 motion segments down there, which is good. So this leaves enough movement, so predictable correction, and I would still go for it even if I have the options of VBT. Now the largest or the best retrospective study which has come out as late as in December 2022 is by Peter Newton, who represents the Harms group. Peter Newton is actually San Diego. This is a large multi-centric database, 237 VBT, 2,000 spinal fusion with mean follow-up of 2.2 years. 76% of thoracic idiopathic scoliosis who underwent VBT had a residual curve of less than 35 degrees, which means 24% had more than that, compared to 97% in PSF. So that's a residual curve is much, much less in fusion. Additional 4 cases had more than 50-degree residual curve, which would possibly have to be revised. And a total of 16% of cases had to be reoperated in VBT as against 1% in the post-spinal fusion group. So the debate continues. The other thing which VBT possibly does not address is a selective thoracic fusion in a 60-degree curve of 50-degree thoracic. As you can see, it bends down to less than 24 degrees, good derotation achieved on bending films, and the curve comes from 36. And so we did a selective thoracic fusion in which we could see that it is reasonably balanced at 26 and 24, and this is 12 months follow-up. So this is a patient who looks better, and you can see that the lumbar hump has also flattened down. So VBT is difficult to address the issue of selective thoracic fusion. So the debate continues. The take-home messages would be, the VBT would undoubtedly score higher in children tweeners, Sanders 4. Fusion undoubtedly scores higher in grown-up with more than 13 or 14 years age, especially with large and rigid curves, and this is with small and flexible curves. VBT preserves growth, preserves motion, and is a single intervention, which is why it is much better than other modulating techniques, which requires repeated interventions. Fusion gives larger predictable corrections, allows for STF or SLF, and is a single intervention with about a 1% chance of a repeat surgery. Treatment should be tailored to each individual patient, considering the severity, flexibility, location, and the predicted growth of the child. Thanks.
We have another debate session by Dr. Massimo Balsano. To talk about Dr. Massimo Balsano, he is the Professor of Spinal Surgery, Orthopaedic Clinic of Verona. He is the President-elect of ISASS, and he clinically practiced in EOS and juvenile scoliosis, adolescent scoliosis, and adult scoliosis. Can we have a round of applause for Sir?
So thank you. Can I have my talk, please? So thank you to all. Thank you for the invitation again here in this place. It's the second time for me to visit Budge Hospital, and hopefully it's a fantastic experience for me and a surgeon and a human being. Can you please? And actually, I'm not well elected, but the president I was elected the last year. So it's here on the desktop. We have copy just now. It was on the desktop. So it's very difficult to debate, but the wonderful presentation done by the previous very experienced surgeon. And what I have to say, something to debate is talk. Of course, I have done many posterior approaches for spine surgery for AIS Lanky 1. This is my disclosures. You see, actually the president. So, what is, as Sabu mentioned before, the meaning of fusionless correction is to have a progressive correction of the curves without fusion of the spine, but there is no interference with spinal and lung growth, was ideated for the treatment of early onset scoliosis. And you know that fusion always is not indicated usually under 12 years because of alveolar growth block and the rib cage expansion, and to avoid the typical crankshaft phenomenon. So this is the typical growth images of the growth modulations where we can do a traction and compression, we could do a compression in the convex and a traction of the concave. So why I like BBT? Because it's a real MIS surgery. We can perform in the thoracic, on the lumbar. Now we are talking about lanky one. And we can do a mini open with a thoracoscopic approach. We can also approach the lumbar, but it's not the talk of today, but later we do it with a transpsoas or antepsoas approach. It's very important to put the convex bicortical screws, and then a polyethylene cord rope is placed and gradually tension between the screws to create the correction. This is, what is the crankshaft phenomenon when you fuse prematurely the spine. That is the torsion, this is for fellows, is the torsion of a few segments that increase the rotation. So the premature fusion stops the growth of the spine and chest wall, impairs the respiratory function. We can have a chest syndrome, reduce height growth, and increase mortality. So, we know which are the growth-friendly devices, which is a list of also the combination. We have to add this new technique that Professor Ahmed, that APC technique, the next. So, what was the initial indication of BBT? Was idiopathic scoliosis, adolescent and juvenile, but more than 10 years old with remaining spine growth. Research between 0 and 2 and center stage less than 4. Thoracic, mild thoracic score between 35 and 60 degrees and flexible below 30 degrees and bending field. My actual indication are these. These are BH 12-16, pre-menarche, post-menarche, with research 3-4, Sanders 5-7, steady growing and rapid growing. See, the range is little change between 40 and 80 degrees, lumbar curves 40-70, but the most important is the flexibility of a curve, at least 50% or then less than 30 degrees. This is, and also should be not hyperkyphotic, and the rib hump should be less than 20 degrees. How we perform BBT? We perform in a true lateral position. We approach always to the convexity, and we do with anesthesiology a selective lungs ventilation. You see here positioning. When we do a C-arm check control, we do a identification of the apex, like here, and you see here in the key wire positioning in the upper part of the thoracic. And then we do a mini thoracotomy, more than 3-4 centimeters, preserving all the muscles. We go inside the chest, and we use this minimal invasive approach that helps us to introduce the camera. And these are the holes of the thoracoscopic approaches. When we are inside, we see all the spine, you see the pleura, you see the sympathetic trunk, you see the vessels, segmental vessels. This is the lung that is deflected. Can we move this? I think this is what we do. This is a movie. Can you please, no, here, should be, yes. You see here, now we stop the pin on the vessels, and we wait 40 seconds, 30-40 seconds to check if there's some monitoring changing. If not, we go through, you see here, okay, I'm moving on. Can we go over, please, to the next? Okay. And now, in minimal invasive, we cut the segmental vessels if we have not responding, negative responding for the neuromonitoring. Then we put the staples, and then with the finders, we go through the body, the position of the screws, and we insert the screws. The most difficult screw is T5. It's very difficult because we are very close to the azygos vein. So this is the trick we have to do during this surgery. It's very easy. The learning, I have done the learning curve with my thoracic surgeon, and then I do this surgery by myself alone. Then we put the screws. This is one of the company that can give you the implants, that can sell you the implants. I like this kind of a reflect. We use this diameter specific staples. This is the screws, but always the screws must be inserted in bicortical shape, because you perform a very important correction with this tension tool, and you reach roughly 400 newtons. So it's very important to insert the screws in a perfect way. Okay, I go through. See here, step by step. And this is an example of a lanky one. You see the AP and lateral. Now, some example. This is, you see here the girl, a typical lanky one, because you see in the bending field by the correction, we reach less than 25 degrees, so we consider this a lanky one. And we have two options: we fuse or not fuse. I had discussed with the family with this hump, and this was the surgery. Of course, the correction with the BBT is less compared to the standard rods, but you see, so MIS, the patient is lifting the second day after surgery, and this is also the shape you can see here. She's very happy, and I think we have a good result. Sometimes, if it's not the case, we can also, this is only an example why I choose I like the BBT. Look at this girl. She's a very flexible girl. Of course, we can do a fusion, but why we can do a fusion in a girl of 15 in the lumbar curve? So we can do in the lumbar vertebral body tethering, we can do a minimal invasive of antepsos or with a retractor MIS, transpsoas. And this is during surgery. You see how is flexible the curve, how we correct. We put the screws with bicortical. You see here, the correction is fantastic. And this is preoperative, post-operative, 1 month post, and this is 4 months post-operative, before and after. And the scar is very limited, and of course 1 year post-op is completely well balanced. So look at this, is very, very important how this girl can move the spine when she has a VBT in the lumbar. Of course, it's only to how you can see how normal is the movements in the lumbar. So this is another case. AIS lanky 6C. We can fuse. It's not. It's a. You see the girl, hump. Again, very good, flexible, So what you do, this is a normal supine, this is the normal supine. We can do a fusion, of course, but what? Why? In this case, I have done a double VBT, lumbar and thoracic with this result and with this very good shape after surgery. Which is another case, number 4. This is more rigid. This is a very challenging case. We have discussed with family, fuse or not fuse. They decide with me. Of course, I accomplished, but to avoid fusion, of course, this is you see, less than 30 degrees of in the bending, 23, so we can consider a lanky one. Look at the shape, but after VBT, but of course the correction is not so high, roughly less than 50%, but for me is an example of how she can increase perfectly the balance of the spine, and she can come back immediately to the normal activity in a very, you see the scar is very small. She can do back to the activity of course, in few months. Of course, we have some complications. The complications are about 10%. You have to deal with the complication, we know, but what about the complication of a normal fusion? Infection, infection, pain, bulking of in the thin patient, bulking of implants, and we have many. And this is another paper of the outcomes of a BBT in I like now to use the double tether in the lumbar to have because one of the problems should be the rupture of the rope. I never had this in my cases right now. So the conclusion for my talk is that BBT is a real MIS deformity surgery, and we have a real low bleeding. We can have a growth and motion sparing, and this is very important. We have a low complication rate. Of course, I say that there is a real alternative to fusion, but it's limited. If I have a curve of 100 degrees, 90 degrees, I don't perform, of course, a VBT. So we have selected very carefully the patients. Of course, we need a long outcome. The outcome now is short comparing to the fusion. So, but I think the future will be very bright for this technique. Thank you so much from Italy.
Raise their hands, whoever in favor of anterior after looking at the deliberation by Massimo Balsano and Dr. Samajit Basu posterior approach. So how many raise hands for the posterior approach? It's quite a high number. And anterior approach? So both are winners of the debate. So it's still a controversy in this part of the world as well as everywhere, whether to go anterior or posterior for correction or to have cosmesis of the spine. So with this, we conclude this and we go on to the next session, which will be a case presentation by Jaideep Ghosh as a congenital one, and then before that there will be Dr. Ankur Nanda to present about congenital scoliosis, how he treats his scoliosis cases. Dr. Ankur Nanda.
Good afternoon, everybody. So, moving from idiopathic scoliosis, so we'll talk about a little bit about something which really is less common, but is quite important part of our practice, which is congenital hemivertebra. And Dr. Ujjwal has given a very specific topic about 2 levels with growing spine, but I'm going to try and cover hemivertebra a little bit as a whole, because I think this is the only talk on this aspect. So what's so special about this? Why are we separately talking about it? So we know that early onset scoliosis, the concepts of treatment of early onset scoliosis are a little different from the idiopathic scoliosis. And EOS, is a term which is used for multiple etiologies, and it is more related to the age. So any child which is less than 10 years qualifies under EOS. So what's so special? Why have we put up different etiologies along into a single category? And that's because it's a growing spine, and we know that a growing spine of a child is a mosaic of growth plates, and it's all a matter of how these growth plates are growing. Are they growing symmetrically? Are they going asymmetrically? And are they causing a harmonious growth of the spine and of the limbs or not? So we know that the thoracic segment growth, it happens at different speeds at different ages. So up to the first 5 years, the growth is quite rapid. It's an active phase, and you see around 1.3 centimeters per year of growth of the trunk in the first 5 years. And then it's followed by a little bit of a quiescent phase, where the growth slows down between the 5 to 10 years, and the growth is maybe half of what was happening in the first 5 years. And then the troublesome period is followed, where you have a rapid growth which happens almost at the same speed as the first 5 years. And this is very important to understand the concept, because this is how you are going to plan at which growth period is the child presenting. And because of these growth periods, the prognosis of the curve and your ability to correct the curves will be decided. Now we know that the spinal growth will peak around 5 years, but the pulmonary growth will continue till the age of 8 years. That means, there is still multiple alveoli which are getting developed. And if you end up fusing the thorax at an early years, there is severe pulmonary restriction, and even the number of alveoli which the child will be able to develop will fall behind. So by the end of 8 years, the number of alveoli which have developed is almost of the adult number. So that is why, this age group is very important for the child to grow at least till 8 years. What it means for us is, so this paper talked about the spine height should be at least 22 centimeters for it to not cause a respiratory insufficiency. And if you see here the figures, till the pre-adolescent age group, the chest size is only reaching up to 22 centimeters. So it's very important for the chest to grow beyond this, so as to avoid any pulmonary insufficiency to the child. Now moving on to the types of congenital scoliosis, we know there is failure of formation, there is failure of segmentation, and they can be mixed anomalies. What we are talking about here is about the hemivertebras, which are basically the failures of formation. And we know that the hemivertebra can be of different types. And why it's important to recognize these types is because the severity of the curve progression is different with different types of hemivertebra. And if you are able to identify these on the X-ray, then your attitude towards your patient, your alertness towards the patient would change. So if we talk about, so we know that the fully segmented hemivertebra is something which has a completely formed disc above and below the hemivertebra, whereas a semi-segmented will be only one disc below and the other part will be fused. And then there are incarcerated and non-segmented and wedge hemivertebras, which are basically, not something which will progress. So how do we decide what are the aggression dominants, or which curve is going to be aggressively becoming bigger and bigger and which curve is not? So one is the pathological anatomy, which we will look at. The other is, where is the hemivertebra? Is it in the lower thoracic? Is it in the upper thoracic? Is it at the junctional area? That will help in deciding what you want to do with it. And how many hemivertebras are there? And if there are multiple, are they all on the same side? Are they on the opposite side? What's happening? So these are the things which will decide. So now if you look at this table, you'll realize that the mean yearly rate of deterioration has been well studied, and the hemivertebras and the deformities which are with a bar, which you see on the right side, the hemivertebra which is associated with a unilateral unsegmented bar is the worst kind of hemivertebra to have, because they will progress rapidly, almost 6 to 7 degrees per year, followed by a unilateral unsegmented bar. If you have a double hemivertebra on the same side, it will also progressively rapidly produce. So all these will definitely require surgery. However, if you have a single fully segmented hemivertebra, you can observe and you can see if it is progressing and then decide. Whereas the block and the wedge vertebrae are less likely to progress. So if you look at the series of diminishing severity of progression, so the worst is the unsegmented with hemivertebra, then the unsegmented bar. Then if you have a two fully segmented hemivertebras followed by a fully segmented wedge. So what it essentially means is, usually these three will always require surgery. However, a fully segmented you can observe and see if it is, but it is likely to require if it is progressing, and usually these will not require a surgery. The site of the anomaly is also very important. We know that a hemivertebra which is happening at a lumbosacral junction is quite deforming, and it's not because of the scoliosis, but it causes a very oblique tilt at the pelvis level, and the patient tends to go completely imbalanced. So a lumbosacral hemivertebra would be something which will be aggressive and will require an excision. Similarly, at the CT junction, if you have a hemivertebra, this is also likely to give tilt of the head. However, many a times these are associated with anomalies like Klippel-Feil syndrome, and doing a hemivertebra excision in this area is a little more challenging. There may be involvement of vertebral artery which may be there, you may need to sort of trace around it. So preferable here is to catch these hemivertebras early and do an in situ fusion in these scenarios, which will be an easy escape rather than probably going through an excision in this area as opposed to the lumbosacral area. When you have two hemivertebras together which are on the same side, unilateral, so they have a worse prognosis, and they usually increase by 3 to 4 degrees per year, and without treatment they are definitely going to end up more than 50 degrees in 10 years, and by skeletal maturity all of them will be 70 to 80 degrees. So whenever you see two hemivertebras on the same side, it's a no-brainer, it needs to be excised, and both of them need to be excised. However, if you have two opposing hemivertebra, then you have to actually look at the X-ray and see what's happening. So let's say if these opposing hemivertebras are very close to each other within the same region of the spine, then they are likely to balance out each other and you can observe these hemivertebras. However, if these hemivertebras are in a different region of the spine, then they are going to cause imbalance still, and probably they will need to be dealt with surgically depending upon the age and the site. You can directly go for correction, or you can go for a growth modulating procedure followed by a final correction. So if I want to say, in a hemivertebra in a child who is growing less than 5 years of age, that is the best time to operate them. So if it's a single fully segmented hemivertebra, if it's a balanced spine, convex hemiepiphysiodesis can be given a trial, or a hemivertebra excision can be done. But for an unbalanced spine, the best thing to do is a excision. If there are two unilateral hemivertebras, then excision of the both vertebra, or depending upon the age, if the child is too young, then a growth rod can be considered followed by a final fusion. So just going through the steps of a hemivertebra excision. So what you do is basically you do a standard exposure. You identify your entry points for the screws. You can get your screws placed. Then the posterior elements are removed. The lamina, the transverse process. Once you have done that, you are able to expose the hemivertebra, and it's easy to do this excision because in these scenarios the spinal cord is lying on the concave side, your hemi is on the convex. So if it's a more neurologically safer scenario to do. So you get your retractors subperiosteally under the vertebral body, separate the vertebral body out, start removing, decancellating the vertebral body. And it's very important to remove the superior and inferior disc, and also right up to the contralateral side to be able to get a good correction. And you can then apply compression and close the gap. And usually you are able to get a very good correction, provided you have done this in an early time, within less than 5 years of age, maybe around 5 or 6. And if the superior and inferior bodies have not deformed, because once those bodies have deformed, it is very difficult to close this gap. Just showing a couple of cases before I finish. So this is a 8-year-old female. Her parents observed a deformity around a year back. She was neurologically intact. She had multiple hemis along with a posterolateral quadrant at the thoracolumbar junction. She had a significant kyphosis. This was her MRI, and you can see somewhere at the T10 level there's a hemi which is sort of creating the kyphosis as well. There was no tethering or no diastomatomelia. The patient was neurologically normal. And what was done was a growth rod was planned, because the patient was around 7.5 to 8. But on the physical looks of it, she had not really gained a height. The chest was quite small, and so we decided to sort of go ahead with the growth rod, and we planned for a distraction for this patient, regular intervals. Unfortunately, this was just before the time of COVID, and because of the COVID, so we followed around around 4.5 months. With the application of the growth rod, the kyphosis corrected beautifully. There was no procedure which was done at the apex, and the scoliosis also was nicely controlled by these growth rods. But by the end of the patient was not seen in the hospital, and by the end of 1 year we saw that the kyphosis correction had started to again wear off. There was some loss of correction. And by this time, we had not done any distraction at all. The patient was planned for a distraction, and when we did the first distraction, patient was followed up 6 months later, and the screws had pulled out by that time. So only one distraction was done, although we got a very good correction in the first go, but then the screws started pulling out. And then we planned to, by this time, it was already 2 years since the index procedure. And then we planned to do a definitive procedure for this patient. This was her clinical photographs, and we did a final fusion for this patient, and the deformity corrected quite well. The kyphosis was well controlled. We had done a D10 hemivertebra excision, but we did not bother to do anything for the above 2 hemivertebras, which were at D4 and D7. This is another case. This is again a hemivertebra at the D11 level. This patient had again significant kyphosis along with scoliosis. Patient had a low-lying cord, which was this is how the supine X-ray and the bending X-ray.
I think we are a lot of people are
Sure. So I'll just finish this case. Yeah.
Yeah.
So the pedicle was hyperplastic at the T10 level. This is what the clinical photographs looked like pre-op. We have already done the dethering for this patient around 5 days back, and this is how. This is the correction we got after doing a hemivertebrectomy and a cage. The kyphosis was quite nicely corrected. Started following her up, and this was her post-op day 4. But by the 6th month, we started seeing that there was some add-on which was happening. So we have put her on a brace, and this is her now 3 years post-op X-ray. She looks quite well balanced. Yeah, so I think the take home would be to. Basically, the idea is to identify these curves early, to be able to understand which ones are the ones which are going to progress rapidly. So identify them, that is the key. And at the same time, we have to understand that 2 hemivertebras are something which need to be looked more carefully at.
if they are on one side, they're going to be aggressive, need to be dealt with surgery. If they are on the opposite side, probably we can observe. Thank you. Sorry for taking.
Thank you very much, Anku. Wonderful presentation. We'd like to invite on the panelist Dr. Mukhopadhyay, KK Mukhopadhyay, Dr. Chinmay Nath, Dr. Junaid, and Dr. Shah Alam. Please come to the dais, for we're going to discuss a short case of congenital kyphoscoliosis in a young adult, which will be presented by Dr. Jaideep Ghosh. And let's keep it very short because a lot of people are waiting outside to barge in here, but I'm hanging on. And next debate, we have to cancel that because it's on congenital scoliosis, and Bob said that he is including some of them in his 30 years experience. So, Girish, I think we'll have to skip that because of the lack of time. All right, so we get on to this next presentation by Dr. Jaideep Ghosh.
Jaideep Ghosh presentation. No, not this one.
Dr. Junaid is from Bangladesh, and he is assistant professor in the Department of Orthopaedics in Nidor. Dr. Shah Alam, everybody knows, is the current president of Bangladesh Spine Society. He is the inclusion in the last minute, and we have Dr. Professor Kiran Mukhopadhyay, who goes a great way in supporting Operation Straight Spine. I thank him for sending us 3 very difficult patients for surgery this year, and we have accomplished those cases. I thank Dr. Chinmay Nath to be part of the program and was helping me out with all the topics that is required, and we had made this program together. And Dr. Chinmay Nath was present on the 6th and was with Dr. Girish Sami for a surgery. Okay.
So here I am. I'm Dr. Jaideep Ghosh. I'm from Guwahati, Assam. So I'll present this case. I have been associated with Operation Straight Spine for last 3 years, and this is a 20-year-old female patient. And proceed next, please. Okay. So the neurology is normal. These are the clinical pictures. So I'll go next.
Detailed picture of her back.
You can see that there are some cafeoloid spots. There's a gross deformity clinically. One of the shoulders is lower as compared to the other. And if you see next, this is her radiology. So there is a gross kyphoscoliotic deformity here. And if we see so this is the CT, 3D reconstruction, and we don't see the hemivertebrae very well here because the way the gantry is placed. And this is the MRI. You can see some hemis here. And though it could be a neurofibromatosis, there is no tumors around the thoracic cavity or around the spine. So what can be done in this case? Could you please discuss? Dr. Mukherjee sir, first.
This is a very difficult case, no doubt, and is to me, I will prefer a combined approach.
Why, sir? Why would you prefer a combined approach?
Because this is deformity is very, I think it's very tough to do a VCR from back because this patient is also neurologically intact patient. So I will prefer a anterior approach first and do a hemivertebral from anterior. Then I will try to have the deformity from the back.
And Dr. Chinmayanath, sir, please.
This is a very stiff curve and very sharp, and I think before proceeding to surgery, I need to get the respiratory reserve and pulmonary function test. And I also suggest to give some halopelvic traction to see how much reduction is achievable. Then I'll proceed to plan to proceed accordingly, maybe posterior.
Salam, sir, please.
Thank you for your nice case. No doubt it's a very complex deformity. So do you have your CT angiogram?
No, we don't have the CT angiogram. We'll keep a note of it.
Yeah. So in your history also you have mentioned there is a hemivertebra?
Yes, sir.
Hemivertebra. So it's a true pathology, hemivertebra along with neurofibromatosis.
Yes, sir.
So patient doesn't have any neurological deficit. So what is our problem? Only deformity or pain?
Main thing is the deformity, and second thing, we suspect that the patient could develop further neurology in the future. So
But right now, no
right
neurology
now she is okay, but
okay, fine. If for the deformity or pain is the main complaint, you can go for surgical correction. But to me, definitely I'll do CT angiogram because the vessel, it needs no doubt both the anterior and posterior combined approach because otherwise it's not possible to correct, and also it may be required that to resect the vertebral body as the hemivertebra, or depending on to correct to achieve the most correction, maybe other than hemivertebra you can also need to remove the vertebra. That's why both anterior and posterior the approach will be required. But before doing both, the thoracic surgeon as well as vascular surgeon should assist with you.
Dr. Junaid, what is your take on this?
Actually, this is a very interesting case. So almost in any case of kyphoscoliotic deformity, you have to assess the case very carefully. First of all, the clinical presentation as well as the neurology. Yes, because the management totally different. Suppose this is a case of neuromuscular type, as there is a caveolate spot, and in that particular case, you need to assess the radiology very carefully. Suppose if we take the chest X-ray, simply a chest X-ray, we can see that rib seems that pencil-like thinning. And if we do an X-ray lateral view, there is a, it seems the scalloping of the vertebra. So it definitely indicates there is the neurofibromatosis. Why it is important?
Because X-ray is for you.
Sorry?
X-ray is for you.
Yes, yes. So why it is important in the management? Because in case of management of kyphoscoliosis, neurofibromatosis along with others is totally different. Because in a simple case, you can do either the posterior, the common approach is BCR or like that, depends on the flexibility of the curve. But whenever it is associated with the neurofibromatosis, then you have to be very cautious. Because in that case, if you do only posterior, suppose BCR like procedure, then again there is high chances of pseudoarthrosis. That is very much important. So ideally, this should be done both anterior and posterior to avoid the pseudoarthrosis. But in our context, like you and our context, it is very difficult. So for me, I do only the posterior. Thank you.
So point well taken. So this was a scheduled case in this current OSS camp. So what happened? There's something different happened. The plan was to do a single stage posterior with vertebral column resection VCR. The patient was taken for OT, the patient was placed, and the patient, we had anesthesia problem, the patient was desaturating, the respiratory failure, we don't know why. So the case was reversed, the anesthesia was reversed and brought back, the surgery was not done. So it is planned for next year.
Bound to happen because in the X-rays there is the lung compromise. There is in a X-ray itself there is a chance of lung compromise. So we should have
seen in the X-ray that you can see that the lung volume has reduced. You can see here So from this, we take the information that this is a difficult case, no doubt. We can go anterior and posterior preferably, but sometimes posterior only. Third thing is that sometimes you can do a halo traction also to somewhat improve the deformity. So these are the options. So we'll see next year, and somebody of you might do the surgery. Thank you.
She has very poor respiratory reserve. So we had to come out of the theater after being anesthetized, put on to sleep. We're about to incise and we couldn't. So thank you very much for this session, panelists. And I would like to thank you, Jaydeep. And I just want to present a little bit of about a person who I had adored when I was a young surgeon. R.N. Mitra Memorial. So this year in OSS we have arranged a E-Poster Award for deformity correction papers which we have asked, and this is in the name of Professor Dr. Ratindranath Mitra, and I'm just going to present something because you would not know him. Few slides. Dr. Mitra was born in 1920. So he was the first man to do scoliosis surgery in this country, and Tiolo. এতক্ষণ লাগে তোদের? এইটা না, আমি একটা কথা বলছি আর তুই কতক্ষণ অন্যটা শুনছিস। এই যে ডক্টর মিত্র। So I was in his tutelage in 1990s when I came back from my MS Orthopaedics, and I was with him for a couple of years before he died, and I wanted to learn more about scoliosis. So I looked for British Isles to be my next agenda, and this man is Professor Dr. Ratin Mitra. And he was born in 1920 and died in 1995, the year I left for British Isles. Next slide. So his life is, he did a lot of research work. And Role of Plasma Protein in Health and Chronic Osteomyelitis in 1950 was published. He did residency training in US in 1953. And 1970 he did his MS Orthopedics from Lucknow. And he was head of National Medical College, Department of Orthopaedics, and he did a research wing in scoliosis at Kolkata Hospital in 1970. So he was the president of West Bengal Orthopaedic Association in 1986, and 1988 he was a fellow of International College of Surgeons. In the last days, I collected his 30 years of work and published a book called Scoliosis Facts, Figures, and Follow-up, and it's lying in my library. I took a picture yesterday. And he had acknowledged in this book about me, how I worked hard for 2 years and got on to write this project. And we got some good papers from John Hall from Toronto, Uvis Cottrell, and few others like John Costwick to have contributed in this book. So in his name, his daughter has donated 10,000 rupees for the best E-Poster Award. And so we're going to give a memento as well as a check of 10,000 to the person who wins this. So we have few posters in the outside. And I request Dr. Nirmal Dey, Dr. Sanjay Keskar, and Dr. Aninda Basu and Dr. Deva Pirai to select those E-posters which is the best. Okay, there are only 6 or 7. You will be able to easily acknowledge it's outside. So with these few words, I invite, I have already spoken about Professor Robert Crawford, and I would like to invite to give his talk on scoliosis correction in UK. He's 30 years of experience. So Bob Crawford, please, I welcome you to the dais.
Well, thank you very much, Ujjwal, and thank you for inviting me here, and for my colleague Girish Swamy for arranging this whole trip, which has been fascinating. I'd like to talk about my experience specifically in relation to starting off with anterior surgery. Okay. I don't know how much of that I need to repeat. But I'd just like to relate my experience from when I started off in scoliosis surgery using what I regarded as the conventional posterior approach. To going into what I believed was the up-and-coming field of anterior scoliosis correction, which I pursued for a number of years, and then decided that this was not the best way anymore, partly because of the complications that I had, and partly because the posterior techniques and the posterior instrumentation in particular had improved considerably. This is my hospital, which we moved into in 2001 on as you can see, what we call a greenfield site. A very nice location, a very nice spread out, light and airy hospital. And this is the main reason that we managed to recruit Girish Swami, because it has a nice cricket pitch out the front. He's a mean hand with a cricket bat. He's okay at operating as well. So I'm going to just start off by talking about what the scoliosis service was when I first started and how it developed, how I developed it. A little bit about about the nature of scoliosis. And then this vexed question of whether we should go anteriorly or posteriorly, and the lessons that I learned from the anterior experience. This is a picture of Oliver Cromwell, who led the parliamentarians in the English Civil War in the 17th century. And when he had his portrait done, he insisted that the artist paint him warts and all. So he's got that spot on his face, or two or three of them actually, that he insisted should be included. He didn't want to have himself glamorized as per Facebook or something like that. This is the old Norfolk and Norwich Hospital where I first started as a single-handed spine surgeon. And in addition to doing spine, I was doing general orthopedics and trauma. In total, I had 20 hours of elective operating per week on average. Such is the way things have developed that as soon as we moved into the new hospital, we found it was too small for the number of patients and the number of doctors. So we now have 5 consultant spine surgeons, and the total time of elective surgery at that hospital, at the new hospital, is only 38 hours. So things have got rather badly out of joint, and we're looking forward to the opening of the new Norfolk and Norwich Orthopaedic Centre, which will hopefully address that. So that's where Norwich is in relation to the rest of the United Kingdom. I think one of the main things that we've improved in regards to scoliosis management, there was a colleague of mine who did do scoliosis beforehand, again single-handedly in combination with general pediatric surgery, pediatric orthopedics, and general surgery in general. He did everything. An amazing guy, but surgery has become so much more specialized now. So what we've got now is a big team of not just surgeons. We've got all sorts of very important ancillary staff. And as you can see, we have a pediatrician who comes to many of the clinics. We have orthopedic nurse practitioners, specialist care practitioners, of which we've just met Joe, a physiotherapist and orthotist, and we also have, I think uniquely, we have this system of recruiting old ex-patients and their parents to act as liaison volunteers in the clinic. And we've had 2 regular volunteers who you can see here, the lady on the right in the top picture and the lady on the left in the bottom picture, all mothers of patients. So the nature of scoliosis, well, as I'm sure you know, orthopedics is derived from the Greek meaning something to do with straight children, and this chap, Nicolas Andry, a Frenchman, came up with this concept of a bent tree being made to grow straight by tying it to a stake, which is very similar, obviously, to what we do. And you see this orthopedic logo wherever you go in the world, and we've got it up there. And so, to my mind, you can say scoliosis surgery is orthopedics. You're almost bound to be interested in it. So here's a little teaser. What's been the biggest medical advance in scoliosis? Sort of trick question, really. We've had all this fancy metalwork introduced. We've now got all sorts of other things, bracing, monitoring, genetics, etc. But if you look at what's really affected scoliosis numerically, it's probably polio vaccination. So I think this reflects the general principle that if you can work out the cause of a disease, then you stand a chance of being able to cure it. Not that polio is obviously just a spinal disease. But adolescent idiopathic has always been and remains a bit of a mystery. We know it's familial, there's a strong genetic component, but other than that, we have very little idea about what causes it. We know, well, people have investigated the link to melatonin and the pineal gland, to osteoblast control, growth factors, and numerous other things, but it so far remains obscure what is the primary cause of adolescent idiopathic and early onset idiopathic scoliosis. If we look at the pathoanatomy of scoliosis, I think it sheds some light on this question. The picture on your left is a picture of the spine that originally belonged to this unfortunate chap, Gideon Mantell, who died relatively early in his 50s, I think, back in the 18th century rather. And he'd been complaining for a long time of a painful lump in his back, and he had this lumbar protrusion. And when he died, his friend and colleague, William Adams, with his patient's prior consent, dissected out his spine and found that he'd got this very bad curvature of his lumbar spine. And you can see how, when you look from behind, the spinous vertices lie in a straight line. So if you operated on the back of his spine, you'd think, what am I doing here? But if you go in the front, he's got this horrible curvature with the lumbar bodies rotated round to the left side, I think. And this rotational aspect of scoliosis has been appreciated for a long time. This chap, Edgar Somerville from London, wrote about it back in the 1950s. Stagnara, a Frenchman, realized that if you take what he called a plein d'élection, or a true lateral of the thoracic spine in a typical adolescent idiopathic scoliosis, you would find that the thoracic spine is hypokyphotic or even slightly lordotic. So it appears that it has something to do with overgrowth of the anterior column of the spine. And so he described this method of taking x-rays where you try to get a true lateral of the thoracic spine. Robert Dixon from Leeds in the UK also emphasized this constantly, and he came up with this, what he termed the Leeds operation, which was aimed to combine the benefits of a Harrington rod with the Luque system, which some of you will be familiar with. And so the Harrington rod is placed on the concave side, it distracts the two ends of the curve, and then the wires you can see on that X-ray go around underneath the lamina and pull the spine dorsally, hopefully correcting the hypokyphosis. Why is scoliosis commoner in girls? Well, this could be explained by the fact that when girls have their growth spurt earlier than boys, the spine is at the stage where it is relatively hypokyphotic. So my introduction to scoliosis was in the 1980s with this chap, John O'Brien, who trained in Hong Kong, where he learned to do a lot of anterior surgery. And I got interested in it there, and I asked him, why can't we just use a Harrington rod but keep distracting it? So I came up with this little idea of an expanding rod, but it was he rather poured scorn in it and said it will. If you don't fuse the spine, the rod's bound to break or the hooks will cut out. And so I somewhat regret having abandoned it. He suggested that I should try going to Stoke-on-Trent, where his friend and colleague John Dove worked, and he was quite interested in basic research. And I did some research there for a CHM degree, which involved measuring the loads in a spinal implant in sheep, which you may think is a bit of a waste of time because they walk on four legs, but it was to prove the concept, and we rather hoped to move into humans, but unfortunately the insulation of the strain gauges proved to be too difficult. So I went off and did a fellowship in Sydney and Brisbane, Australia, and I think that was my most formative part of my training. I worked with Tom Taylor, a professor in Sydney, who was always described as more English than the English, and Jeff Askin, who I still keep up with, who's a good friend and mentor in Brisbane. I'm sorry, I'm having trouble with advancing the slides. Okay, so I'm just going to say a little bit about the parallel evolution of posterior and anterior instrumentation. Posterior instrumentation, people always refer back to Harrington as the first person, which is more or less right, in the 1950s, and shortly after him, Eduardo Luque in Mexico invented a very different idea with, as he called it, segmental fixation. He fixed the spine at every level using sublaminar wires and two parallel rods, which were later joined together in the form of a rectangle. And the reason for the upsurge of interest at that stage was, in fact, polio. There'd been some big polio epidemics, particularly in the USA, in the 1930s, 40s, and 50s, and this was a very potent cause of neuromuscular scoliosis. Meanwhile, in Australia, this chap, Alan Dwyer, came up with an anterior approach based on the same sort of reasoning that I was giving earlier on, to do with the fact that the anterior spine appears to be growing too fast in relation to the posterior part of the spine. So if you can compress the anterior part of the spine, that is a fairly logical thing to do. And so he came up with this system that was a little bit like the vertebral body tethering, except that he aimed to get it to fuse, and he used a titanium cable rather than some polyester fabric. And these systems have continued to proliferate with the Cottrell-Dupuis system and the Texas-Scottish Rite system, and eventually progressed to the point where people were routinely putting in lots and lots of pedicle screws all the way up the thoracic spine, which was very different from when I started training. And Zilke in Germany and Webb Morley in London, Messrs. Webb and Morley, came up with an anterior system, following on really from Dwyer's approach, whereas Kaneda in Japan developed a two-rod system, which was obviously stronger because sometimes these anterior rods would break. So, do we go anterior or posterior? Going anteriorly allows you possibly to mobilize the spine better. but if anyone's ever tried to cut down a tree, you may have come across the fact that you really need to divide at least 90% of the trunk before it begins to move. And so you really, I think the same applies to the spine. You just going in and cutting the disc annulus, which I have seen some people do, is a complete waste of time. You've got to really go for that disc annulus all the way around. And similarly, disarticulate the rib head, because that articulates with two adjacent vertebral bodies. And even then, I find that the amount of extra mobility that you get is quite small. And this has been looked at experimentally in cadaveric specimens, and it shows how you get a progressive increase of mobility. I think that graph is a bit misleading. You know, you could spend 20 minutes, half an hour, fiddling around trying to completely release a thoracic disc, and still be rather disappointed by the result, in my experience. Oh yes, a little plug, conflict of interest. The so-called Bob's bent curette, absolutely crucial bit of equipment. So the more time you spend doing these anterior releases, the better, but of course all the time you're losing blood, you're using time, and you have to temper your enthusiasm a bit. One of the theoretical advantages of anterior instrumentation is that you're shortening the anterior column, and also your screws are much further away from the center of the curvature of the spine. It makes obvious sense. So anyway, I was beginning to get interested in anterior instrumentation, and I joined up with this Canada Anterior Spine System group. And I would just urge a word of caution here. When you join these groups, they're full of people you know, you become good mates, you go drinking together, and you become convinced that you're really in the forefront of what's happening in scoliosis surgery. And there we were all feeling very pleased and chuffed with ourselves. And I can tell you that everyone, bar one of those surgeons, has really given up anterior scoliosis instrumentation as a routine thing to do. The one person who's an exception is Dralant Mehta, who my colleague here knows, in Birmingham. So just a bit about the technique that I used. I came from, I'm afraid I didn't, I came from an era before thoracoscopic surgery, and so this was involved a big incision and appropriate anesthetic. Just, yeah, I should say that well, the anesthetic side of this operation is very important, not least because the anaesthetist actually does the correction by adjusting the position of the patient on the table. You have to get underneath the patient's head and shoulder, lift it up, and pull towards you from the anesthetic end of the table. And that is a very, very effective way of correcting the curve. And as you can see, I've done a pretty reasonable radical discectomy at all the levels there, and it's quite bloody. If you put this particular type of system in, you get this nice sort of arcade of the screws. This is using the OSS system, and it gives you a good idea of the screw trajectory. And when you do the correction, you can see those screws fall back into line, apart from one where I think the stick is loose. And that's you can't tell very well, but that's the correction bone graft, and then you can sew the parietal pleura back over the instrumentation, which at last stops the bleeding. I did a number of these cases, and a lot of the results were very pleasing. And I have to say, for a type 1 scoliosis, this is pretty well ideal. Slight shoulder imbalance, perhaps, but you do get a good correction. The advocates of anterior surgery always say that you save levels. I'll come on to that point later. And it produces consistently good results in that type of curve. Is it a shorter length of instrumentation than posterior? Yes, it probably is. Why is that? Mainly because you can't get above T5 without considerable difficulty, and T4 is the highest I've ever been. So ideally, if you were doing that posteriorly, you'd go 1 or 2 levels higher. And then sometimes the top level will fail because there's a lot of load on the end level, and this had to be revised very early. The thoracolumbar and lumbar curves are, I think, everyone's favorite curve because they're generally quite flexible, and it's a part of the spine that is easy to operate on either anteriorly or posteriorly. And again, another one of those. Problems I've had. So the commonest problem by far has been top end fall off, and this comes back to that, what I was saying earlier, where it's actually very difficult to take your instrumentation high enough. And again, if you want to instrument both curves, that's really not so possible without doing 2 operations, which I have done once. I'm just rattling through a bit because I'm aware that we're short of time. And then extending into the lower curve here proved impossible, and that, if we'd been doing that posteriorly, we would have gone lower. This, I would question the sense of this. In retrospect, I regret doing that. I think it was would have been much more sensible even then to have done a posterior approach. Nevertheless, the patient did reasonably well. And that is another issue, going to the lower end vertebrae. There's always this feeling that you can, when you see the patient's x-ray on the table, that the curve is corrected quite nicely, and you stop short, and then you're disappointed when they stand up that you find that you should have gone 1 level lower. So complications of this, as I mentioned, top end fall off is by far the commonest, and by the same token, distal angulation is also quite common. Chest and pulmonary complications are certainly greater than in posterior surgery, and we had 1 canal penetration with paraplegia, which was obviously a disaster, a big disaster. And I'll start with this case because we believe very firmly in presenting our complications, and it's the only way that you can learn from them. What's the most important thing? I suppose it's duty of candor to the patient, and the knowledge and the acceptance that you are committed to them for life, really, and you have to do everything to help their unhappy situation. There had been 2 other cases that I learned about at around the same time in the UK of screws going into the canal, though neither of them resulted in paraplegia. So again, coming on to the commonest problem of top end falling off, that was 18 out of the 25 cases. Failure to instrument to the lower end, 6. Chest and pulmonary complications are very common. We had 1 pneumothorax, which was the only one we had, thankfully, but it was quite alarming. I'm very sorry, I just can't advance this thing. And just to mention that case, you can see on the post-operative day that the lung is already collapsed. If you're alert to the appearances of chest x-rays, you can tell that there's a pneumothorax, so I had to take the patient back to theatre and put in a chest drain. what does the literature have to say about this? Well, very much what I've been alluding to all along, which is that the anterior approach allows you to instrument fewer levels, but maybe that's not the right term. I think it's partly making a virtue out of necessity. You can only fuse fewer levels because it's difficult to go to the same length of spine than you would posteriorly. Interestingly, this paper that was, the author I know on this paper is Aki Olin, who's one of the group that I showed earlier on. He was a keen advocate of anterior correction. And in this series, they actually found that the comp correction was better for the posterior instrumented cases, and there was no significant clinical difference. Another paper by Peter Newton, who was also a big advocate of anterior surgery. Again, the instrumentation is shorter. You have a greater angulation below the instrumented section of the spine and less preservation of lumbar lordosis, so not good. This paper from Germany somewhere, Cologne, looked at pulmonary complications, and they are a hell of a lot more common in the anterior approach, as you would expect. It's probably less if you do it thoracoscopically. Oh, sorry. Chris. So in 2006, this book came out, and I was asked to review it for the Journal of Neurosurgery for some reason. Well, I met the editor of that journal down in Cambridge, and three well-known authors, proponents of anterior scoliosis surgery, a big, expensive textbook. And I have to say, it was absolute rubbish. If I'd bought it, I would have asked for my money back, because for the simple reason it was full of all sorts of errors. If you looked at it, if you read the book carefully, as you do when you're doing a review, there were at least Yeah, that's the one. So going back to my old boss and mentor and friend, Jeff Askin in Brisbane, he came over to the British Scoliosis Society meeting in Belfast. And he did a presentation entitled, Should We Persist with Thoracoscopic Scoliosis Correction? So my answer to that is definitely yes, because there is this technique of vertebral body tethering, which has become much more, it's become of much more interest recently, even though it was described at least 20 years ago by Randolph Betts. It's never really taken off until recently, when I think people have got to grips with the type of instrumentation and the cases on which it can be used. That's it, really. That's a little quotation from the poet, the English poet T.S. Eliot, saying that when we return to where we started, we'll know the place for the first time, which is sort of fits with what I'm doing at the moment. I'm currently sailing a boat around the United Kingdom, and I've got about halfway, as you can see. Thank you very much. Anyone want to fire a question or anything? I guess everyone's pretty hungry, aren't they? Lunchtime.
Thank you, sir. Now I take the privilege of starting off the felicitation of faculty, organizers and guests. I would like to request our respected chairman, sir, and the other delegates to come to the stage and take a seat. Sir, we have the honor to introduce to you our respected Chairman, Sir, Shri Jagannath Gupta. I would like to request our staff to felicitate Sir. I would request Mr. Ashok ML Budge to come forward for the felicitation. A round of applause for Sir. Our respected Vice Chairman, Sir, Mr. KK Gupta, to come forward for felicitation. I would request our respected CEO and MD, Dr. Balram Gupta, sir, to come forward for felicitation. A round of applause for sir. Now we shall respected Principal Sir, Professor Dr. Shudhodhan Bottabal. A round of applause for Sir. We take the honor to felicitate our respected SVP Sir, Brigadier Dr. Now we our Principal Ma'am of Nursing College, Mrs. We shall felicitate IC Budge, Mr. Shantanu Bose. We shall felicitate IC Mahesh Thakur. A round of applause for sir. We shall be felicitating IC Nodakhali, Mr. Parthupratim Ghosh. A round of applause for sir. Now we shall Mr. Ajay Dash. Ajay Dash, Mr. Ajay Dash. Now we shall be felicitating Ms. Ria Hajra, President of Budge, Block 1. Can we have a round of applause for ma'am? Now we shall felicitate the Vice President of Budge, Block 1, Mr. Nityanand Burman. Felicitating the Vice Chairman of Budge Municipality, Mr. Mohammad Sur. Now we shall call upon the member for Jela Church. We will be felicitating the President of Budge PS Shamanno Community, Mr. Shankar Ghoshal. We take the privilege of felicitating the member of Buita Gram Panchayat, Mr. Shapon Noshkar. Now we shall felicitate Mr. Rauf Mondal, member of Buita Gram Panchayat. We take the privilege to felicitate Dr. Mayuk Mukherjee, OSD Registrar Section. Now we shall felicitate Dr. Shuparna Datto, Director of Health and Family Welfare, Shastro Bhavan.
Everybody, a very good afternoon. Let me introduce myself. I am Professor Shuparna Datta. Currently, I am the director of the Institute of Health and Family Welfare of the Government of West Bengal, Department of Health and Family Welfare. This institute is the pivotal institute of teaching and training of the Department of Health and Family Welfare. I am very grateful and thankful to all the team of Jagannath Gupta Institute of Medical Sciences for inviting me in this auspicious program. This is the first time I have got the chance to visit this college, and I am very happy to see the infrastructure of this sort of private medical college. And I am very happy also to know about this training system and the teaching and training curriculum and all sorts of infrastructures and the standard of training, teaching that is being given by this institute. It is a very good chance. This sort of programs are a very good chance to get ourselves being trained of difficult surgeries. So after getting, I just have a chance to hear the last presentation, and I am very much impressed by the state of art of these operations and the standard of care that is being given by you. Basically because spine is Homo sapiens, I should say. The straight spine is Homo sapiens. So many in this, now in our society, it has been seen after the age of 40. Other than kyphoscoliosis, many of the patients are suffering from spine problems. So we will be happy to have these sort of programs, and I will request the authorities of the Jagannath Gupta Institute of Medical College that if these sort of programs can be done online, so that it can be, if these types of programs are arranged, and that can be in a PPP model with our government of West Bengal, so that very many medical colleges, our students, our SRs, our PGTs, our assistant professors, associate professors, and professors will be able to attend these programs out of their busy schedule. Along with that workshop, they will attend along with this authority of the Jagannath Gupta Medical College. So in future, I will request from our department that if this sort of auspicious programs are being arranged, it is to be done online, so that many of our students and our PGTs and SRs will be able to see, and a wide will be done in the state of West Bengal. So I will request this, sir, as because Chairman Jagannath Gupta sir is there, I take the privilege to thank him, sir, again, and please arrange it in an online mode so that our students may also get a chance to have this sort of programs, and they will have an experience regarding this sort of training and teaching. So that will be a very good privilege from our department also. Thank you, sir, again. Thank you for everything. Thank you for inviting me.
Thank you, ma'am, for encouraging us. Now we shall continue with the felicitation program. I would request Mr. Kamlesh Singh, PRO of JIMSH, to come forward. We take the privilege to felicitate Mrs. Taposhi Gotobal, Registrar of West Bengal Nursing Council.
Good afternoon. I am Taposhi Gotobal, Registrar of West Bengal Nursing Council. I look after the GNM and BSc nursing program, and I am very glad that I am invited today and I can visit this conference. Sorry, our government also has done this type of CNE program and CAME program with collaboration with sometimes with Singapore, sometimes with UK, sometimes with Australia, and like that. So I would request if you can collaborate with our government also, so that we can update our knowledge in every aspect. Thank you very much.
Thank you, ma'am. We shall continue with the felicitation program. I would be requesting Mrs. Papia Dash, Assistant Registrar of West Bengal Nursing Council, for felicitation. Now I would request everyone to stand up because we are going to have the national anthem being sung.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग तब शुभ नामे जागे तब शुभ आशीष मांगे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I would request all the guests to come forward for the lamp lighting ceremony.
সারা রাজ্যে একটা নাম করে ফেলেছে। যারা আছেন হেলথ ডিপার্টমেন্টের বিন্দু যারা আছেন তারাও স্বীকার করবেন, দেখতে দেখতে জিমস একটা মানুষের দুয়ারে পৌঁছে গেছে। সন্ধ্যাবেলা যখন আমরা রাস্তায় আসি তো এত ভিড় দেখলে বোঝা যায় যে গভর্নমেন্ট হাসপাতালকে টেকে দিয়ে যাচ্ছে। এখানে গুপ্তাজি আছেন, বলরাম আছে, কে গুপ্তা আছে, কমল সিং আছেন, নিত্যা থেকে শুরু করে, রিয়া থেকে শুরু করে, রূপ থেকে শুরু করে, বড় থেকে শুরু করে, সকল ঘোষাল থেকে শুরু করে সবাই এখানে আছেন। এটা ভাবা যায় যে আমি কখনো ভাবতে পারছিলাম আমার এলাকায় এত হাসপাতাল হবে, আমি কখনো ভাবিনি। আমাকে একবার সিএসসি অধিকতা বলছিলেন আমি আপনার হাসপাতাল তৈরি করে দেবো, ঠিক আছে, কিন্তু হাসপাতাল চালাতে পারবেন না। হাসপাতাল চালানো খুব দুষ্কর এবং কষ্টকর। আজকে আমরা বুঝতে দাঁড়িয়ে এরা গ্রামের আশীর্বাদ পাচ্ছে, মানুষ আশীর্বাদ পাচ্ছে, এবং যে ডাক্তাররা আছেন, কর্মচারী আছেন, নার্স আছেন এবং অন্যান্য শিক্ষকরা আছেন, তাদের অনুরোধ করব এই সংস্থায় বাঁচিয়ে রাখার চেষ্টা করুন। তৈরি হয়েছে গুপ্তাঙ্গি তার ফ্যামিলি, বাঁচিয়ে রাখতে আমাদেরকে মানুষের স্বার্থে, এলাকার জনগণের স্বার্থে, সেই সব চেষ্টা করবেন। এবং হেলথ ডিপার্টমেন্টের অনুরোধ করব যে কোনো সমস্যা হলে কড়া নজর না দেখে নিচু নজর করে দেখার চেষ্টা করবেন, যাতে এরা তো ভালো পায়, সুযোগ পায়, কাজ করার চেষ্টা করে। আমি সবাইকে আন্তরিক ধন্যবাদ, নমস্কার, শুভেচ্ছা জানিয়ে আজকের অনুষ্ঠানে আমি গুপ্তা ফ্যামিলিকে ধন্যবাদ জানিয়ে ছোট করবো না। তারা সুন্দর এবং বৃহৎ কাজ করছেন। আগামী দিন আমরা যারা বসে আছি আপনাদের পাশে আছি, সঠিক কাজ করলে আমরা আপনার পাশে দাঁড়িয়ে 100 লড়াই করবো। আমরা চাই আপনার পরিবার সবাই মিলে কাজ করুন, এক করে লড়াই করুন। সবাইকে আন্তরিক ধন্যবাদ জানিয়ে শুভ নববর্ষের অগ্রিম প্রীতি শুভেচ্ছা নমস্কার জানিয়ে আমি যারা ডাক্তার এসছেন ফোন থেকে কষ্ট হলো তারা দেখে যান যে মানুষের প্রচেষ্টা হলে কি হতে পারে। প্রচেষ্টাই মেইন জিনিস, মানে এটা আপনারাও যখন ডাকবেন আসবেন, সাহায্য করবেন। শুভেচ্ছা নমস্কার।
What a wonderful word of experiences and encouragement to all of us.
We are sorry about a little bit of an issue here. I invite Dr. Devapi Roy, President of WBOA, to come and say a few words, and we will felicitate him as well. Yeah, we will felicitate him first, and then he will give us a little talk. একটুখানি বসে যা ভাই, হ্যাঁ, এটা দাও, পেপারটা দাও।
Good afternoon. On behalf of West Bengal Orthopaedic Association, I would it was a great experience, the third Kolkata Spine Deformity Correction course. And we would like to, on behalf of the association, West Bengal Orthopaedic Association, we would like to welcome all the delegates, the faculties, all the participants, and thank all the organizers who have done a splendid job. It was a great event, and we are looking forward to more of these events in future. And especially I would like to thank Dr. Ujjwal Devnath, who has been organizing with a great heart and great strength. Thank you so much. And
Dr. Balram Gupta to present a token as a memento, as a token of this meeting to Dr. Devapi Rai.
Now we shall be having the break for lunch. I would request everyone, all the guests, to come outside. We have the lunch preparation made. Thank you. We shall be back in a short while.
We will gather after this within next 40 minutes for lunch, and we have to quickly run through our program because a lot of people have to leave for the airport by 3:30, somebody for 4 o'clock. So let's quickly grab our lunch and come back here. Okay, thank you.
Yeah, I think I'm speaking only to 3 of you, so that's fine. This is a very interesting topic about shoulder balance. We all know that scoliosis is not just radiological correction, it has to be cosmetic correction. So we have to have the most important, 2 important factors with which the parents come. One is a rib hump, second one is a shoulder imbalance. So most important, shoulder imbalance. Most of the time the parents notice the scoliosis in a child because they have shoulder imbalance. So importance of shoulder cosmesis is very, very important. And we have to see both coronally and as well as in the frontal plane. Shoulder balance is a very complex thing which we all take it for granted. It's an important aspect in the management of AIS. And balancing of shoulder is an intricate art. It's not like easy. So, and that too in type 2 Lenke where there's a proximal thoracic curve, you have to be very, very careful. There are 3 types of shoulder balances which are possible in Lenke type 2. Before going into the correcting techniques, we have to know what is shoulder imbalance. First, we have to know these 3 parameters. One is the clavicle angle, which is the angle between the acromioclavicular joint on both the sides and the horizontal. So this is the clavicular angle. Then there's a trapezius angle, which is the angle between the horizontal and the prominence of trapezium on the convex side. Then there is a trapezium area, as you can see here. You can see here, that's a trapezium area. So that's a major trapezium area, minor trapezium area. So most often, this is what the parents are worried about. They are not worried about the curve per se. They don't know what is 60 degrees, what is 70 degrees. What is more obvious will be this major trapezial area and the major trapezial angle. So the shoulder imbalance is divided into 2 according to these 2 parameters. One is the medial shoulder imbalance. That is, medial shoulder imbalance is the trapezium and the trapezial angle and the trapezial area. The lateral shoulder imbalance is the clavicular angle. So it's an interclavicular line with the horizontal. So there are 2. It's very easy to correct the lateral clavicular angle, lateral shoulder imbalance. Very tough to correct the medial imbalance if there is a very tight proximal thoracic curve. So once you go into those are the angles from the front, then you should look into the angles on the radiograph. So again, the radiograph there are 2 things which are very important. One is the shoulder height. So you measure the shoulder height with an horizontal. So the horizontal is tangential to the acromioclavicular joint on the higher side. Then you measure the shoulder height. How much is the difference between this acromioclavicular angle to the horizontal, which is tangential to the higher side. So that is called the rib. No, that's the right side shoulder higher in this. Then comes the shoulder coracoid height, which is from the coracoid line, there is a horizontal. Then you measure how much is the difference between the horizontal of the clavicle and the coracoid process. This is called the coracoid height difference. These 2 are important when you are balancing the proximal thoracic curve again, because the third, I will come to the third point, because this is very important, whether you have to go to T2 or can you stop at T4, and whether you have to distract on the concave side or not depends on these 2 important angles. So as I said, the third one is the clavicle rib cage intersection. As you can see, this is the major clavicle rib cage intersection. Then there is the first rib angle. So the first rib angle is the angle between the first rib on the concave side and the convex side. The angle between these 2 lines is the first rib angle.
So this angle is also important if you have to correct the trapezial angle and the trapezial area which I was talking about. So these are very prominent in a very tight proximal thoracic curve. So as discussed before, the same clinical parameters can be seen in the radiography also, which is the clavicle angle, the first rib clavicle angle and the trapezius length. So the trapezius length is the difference between the shoulder height in the concave side and the shoulder height in the convex side. So the difference between the two gives you the trapezial length. So if you see from the back, so there is something called the axilla angle, which is the line drawn between the axillary fold, posterior axillary fold and the horizontal. That's the axillary angle. And then the shoulder angle, which is the line drawn between the posterior spinous process on both the sides of the scapula to the horizontal. So these two angles are also important when you are calculating the correction for the proximal thoracic curve. So the shoulder height, again you measure by quarters, that is you divide the back into 4 quarters, the middle third, then the 2 quarters, then the 2 quarters on the other side. The shoulder height is this difference between this line and this line, the second line here and this line. So that if you are doing a balancing, this line should improve and this line should decrease. But if you can see here the trapezius fullness, so to correct this trapezius fullness is very, very important. Here is, that is very important when you have to study the T1 tilt. If the T1 is tilted too much into an angle into the concavity of the proximal thoracic curve, then you may have to extend your fixation up to T1 also. So the criteria of fixation was given by 3 people. As we all know, the Lenkes criteria to fix the proximal thoracic curve is if the curve is more than 30 degree in correction films, if there is a grade 1 rotation of the T1, if there is an apex of apical translation of 1 centimeter from the CSVL line, and then there is a T1 tilt which is tilted towards the concavity of the proximal thorax. If the T1 is tilted, if it is horizontal, you don't have to fix it. If it is tilted, you have to fix it. Then the left shoulder elevation in a push-prone radiograph. So if you are doing a correction film and if the left shoulder corrects or elevates higher than the right shoulder, then you have to fix the proximal thoracic curve. So this is the Trobich recommendation for different curves. So he says 2 and 4 go to T2. This is a very generalized term. He just says go to T2. Trobich says go to T2, but he doesn't consider the T1 tilt as well as the rib angle, which I was talking about, the trapezius angle and the first rib angle. So if the first rib angle is very high, as you can see here, and if the T1 is tilted away from the not into the concavity, again you can stop at T4 here, not go to T1. But as you could see in the first case here, the T1 is tilted into the concavity, so you have to go to T1 here in this patient. So this is a Ilabort's criteria. So he divided into 3 groups where the T1 is parallel, T1 is tilted, and the shoulder is parallel, where the T1 is tilted and the shoulder is not balanced. So you have to go to either T1 if the T1 is tilted, shoulder is balanced. Both are balanced, then T2 or T3. If the T1 and the shoulder are imbalanced, then T2 or T1. So most of these, the Lenke and the Ilabort criteria tell us to go to T1, but Trobich criteria says stop at T2. So examples where we use hooks at the top, we have gone up to the C7 here. If you can see, we have put a compression hook on the top. So this was a tight curve, a parallel T1. You could have stopped, but you can see the right side is higher, left side is lower. So this is a curve, a primary length 2 curve with a proximal thoracic curve. So we had to go up to T1 and C7. We made a claw for it on the convex side for it to be compressed, and we made a upgoing hook on the cavity to distract it little bit. So you can get the shoulder, even there you can see the left shoulder has gone slightly higher. So it is a very difficult situation in these type 2 curves. Again, another curve where the primary curve is slightly lesser
But this curve never corrected even on correction, and there is a concavity on the T1. The T1 is tilting, so we did go up to T1. We use again the hook construct. We use a claw. On the convexity, we compress on the claw, and then we distract a pedicle hook or a pedicle screw on the concavity. So we can use very little implant and do the correction as much as. So this is another patient where there is a type 2 curve where the right shoulder was very high. So we stopped at T2 here. We could get a shoulders balance, as you can see, but what we have to keep in mind when you correct the proximal thoracic, if you don't achieve a good, or if you achieve a slightly higher L1, they tend to add on in the lower end. So what happens is, I will miss these two slides. What will happen is they will try to compensate the curve in the proximal thoracic curve or the shoulder imbalance by correcting their pelvis. So because you have fused the thoracic spine, they will correct here, and then there is something called an add-on. So posterior shoulder imbalance can lead on to adding on if we do not follow the criteria properly and not do the, we have to really be careful as we correct the proximal thoracic curves in these. Thank you. So after we do the correction maneuver, every maneuver, we use a C-arm, see the T1, T2 tilt and the lower tilt with a straight line with a rod in the middle. If we feel there is still a tilt, then we do the distraction compression at the upper end. And most often upper end, we stopped using screws for the proximal thoracic curves. We have started using only the hook construct.
Thank you.
Yeah.
Thank you very much, Apache, for coming all the way this morning and waiting all this while. So I think, thank you very much for coming again. And Ankur, you are leaving today? Now? Hello? আমি এখন কথা বলতে পারবো না। All right, Ankur, thank you very much. Thanks for coming all the way. And very silly, but it's a lot. Okay, we go on to the next thing we have on is we have panelists for this, Dr. Massimo Balsano, Dr. Alaluddin Ahmed, and Dr. Rajesh Chaudhary. What we have is a debate between traditional open surgery for AIS versus robotics, allowing precision in AIS surgery. Because Bhavuk Garg in Delhi, he could not come, but he is supposed to be online and give a present online before 4 o'clock. So I am inviting Bhavuk Garg first, so you can counter. All right, Raghav, that will be better, because whatever he speaks, you can negate by your talk. All right, so we need online. Like, why don't you ask connect Dr. Bhavuk Garg? If you don't, I will then. Where is it?
Hello.
Okay, Bhavuk, you're on. I'm sorry that you're sick and unable to come here. And thanks for being online and giving us a presentation. And Raghav is there waiting eagerly to say things against you regarding robotics versus open surgery.
Okay. Thank you, Dr. Ujjwal, and I am really sorry that I am not able to come there. I have to cancel because of this, I think, viral illness. But the talk given to me is a debate about the the robotics allows precision AIS surgery. So let me admit that this is a futuristic talk, and right now I don't believe myself that they are useful in AIS surgery. So Dr. Raghav is already a winner here. Uh, and I still believe in freehand. The major reason is because I can do much faster and with freehand. But the one thing is certain that if we talk about the precision, then the precision is definitely better with robotics. However, that precision translates into clinical thing. That's again an issue, and because I am able to achieve the full corrections with the not so precise placement of the screws as well in my clinical practice. So coming to the talk, the evolution of robot as such, they have undergone a great evolution, and the spine assist was the first commercially available robot, which was by the Mazor company from Israel in 2004, and then came the Renaissance in 2011, and then came the Mazor X from the Vetronics, and now we have these Rosa Spine and the Excelsius GPS, which is the latest one, the robots, and I have the Excelsius GPS in my hospital. So this is a paper from my institute in which they have studied the pedicle morphometry, and they have shown that the concave pedicles are much thinner and they're directed more medially, and there are curved pedicles near the apical regions. And recently we have presented a paper in the SRS that this pedicle morphometry also depends upon the rotation and not actually on the corpse angle of the scoliosis. So this is our study. We looked at the pre-operative radiographs and the CT scan of 25 AIS patients. They were reviewed by 3 independent observers, and we looked at these these various parameters at the apex, and the pedicle length and the pedicle axis length, it increases on the concave apical and the periapical regions, and the transverse cancellous channel diameter significantly decreases on the concave apical regions, and the sagittal pedicle diameter decreases on the convex side. So these variations, they make the accurate pedicle screw insertion challenging. And this becomes very important, especially if you're talking about some, the adult deformity when the bones are osteoporotic and you need precise correction. So what is accuracy actually? The accuracy means that you're reducing the number of pedicle screw breaches. And this is the modified classification in which you can see that how we divide the pedicle breach medially, laterally, or the inferiorly. And the literature says about the accuracy that the robotics accuracy is very, very high. And this is about the spine assist robot. And they said that the accuracy is 92.8%. And most of these significant breaches were at the incision ends. That means the proximal of the distal end. And that usually happens because there's a soft tissue which is impinging on the robotic arm. Now, this is another study in which they have shown, that the accuracy is 98% with these robots, spine assist, and now we have evolved. So with Renaissance robot, the accuracy has come to be 99%. People have done the meta-analysis, and they have shown that the new generation robots, they reach the accuracy of 99% as compared to 97% with the old generations. So this is a paper in which they have looked at the accuracy of freehand pedicle screw insertion, and they found that only the 86.5% screws, they were perfect. So people have also tried the machine learning algorithm to look at the freehand placement, and they found that the satisfactory rate of screw placement was 88.5%. So is there a learning curve? So we have seen that there is enough literature that the robotics, they allow the precise screw placement, but one should also remember that a fool with a tool is also still a fool. So, if you're using a robot, then you have to be very careful that, your registration is maintained till the end. Otherwise, the screw will also put the screws in a wrong way. So is there a learning curve? There is a learning curve, and people have shown that as your accuracy keeps on increasing as your experience with the robot increases, and people have shown that the major peak occurs between cases 10 to 20, and the second smaller one at about 40 surgeries. So these are the phenomena which we know that when the person is unskilled but aware, and when there is increased confidence of a surgeon, that means the patient is unskilled but is still unaware. So again, this is another this thing. So they have shown the same paper. They have shown that there was a 42% reduction in the last 30 patients. So the accuracy again reaches up to 98 to 99% in these cases. People have shown that in adult degenerative scoliosis, the accuracy and blood loss is significantly less. In accuracy is significantly more, and the blood loss is significantly less in the robotic assisted group. And the ideal screw placement is like, that you are spanning the complete pedicle length, and you are going through the pedicle and you are engaging the cortex. And these, they vary actually. The old school, they were also said that you're putting like in an ideal way, but the navigated wants to play the maximum length of the screw into the vertebra, so you can have the maximum purchase and you can derotate the spine. So again, it depends. So if I am operating a case with free hands, if my neuromonitoring is okay, if my purchase is okay in the pedicle screw, I'm okay with it, and I'm able to achieve my correction. However, if you have some difficult cases and in which each and screw parameter depends upon its pull-out strength, then obviously the robotic makes a strong case. But how many cases do you operate such cases? Again, a question for debating. So accuracy, we have to redefine it. The accuracy of robotic pedicle screw placement is based upon the planned versus actual screw implant position. So if a freehand person says that I have planned to put my screw exactly in this thing, and how much accuracy I'm reaching it, then obviously the robotic is a major the advancement and major help adjunct. Radiation exposure is also more with freehand technique as compared to with the robot. So it is just accuracy? No, you have to plan your best entry, ideal trajectory. You have to look at the optimal screw length and the width. You have to plan to avoid the tulip collisions. You have to align if you are using method. You can optimize the collinear rod reduction alignment, and then you have to determine the rod length. So these sort of things, you can adjust with the robot. And imaging is obviously a challenge in complex deformity. So again, registration becomes an issue. So unless you are sure that your registration is okay, then only robotics will make a difference. Otherwise, it will not. So severe curves and significant rotation, they make the inability to obtain clear images. And in those cases, robotics is no help in its current format. The mounting options are very complex. The multiple registrations may be needed if you're using it a long segment fixation. If you're doing releases in between, then again robotic registration is not perfect. Soft tissue impinging the robotic arm, again it is a problem, and skiving is again a problem. If the patient is obese, then there is a major soft tissue wall which keeps on skiving, deflecting your robotic arm. So one has to be aware of all these pitfalls. But again, if you are able to take care of the pitfalls, if you know how to negate the problems which comes with the learning curve, then obviously the robotic makes a strong case for its use in spine surgery. So my take-home message is that the precision is certainly more in robotic navigation. Time per screw is significantly reduced with experience. Troubleshooting to all pitfalls is on the way. We know that how to avoid that particular problem, and technology is here to stay. But obviously, one should know that how to use the technology. Then only you can use. So I have used both robot and the freehand. So right now the freehand is the best, because the current robots, they are not perfect. But with using it again and again, we are getting it perfect. For simple scoliosis, for simple deformities, the robotics is much better. For osteoporotic spine, for degenerative scoliosis, again the robotics is very good, but it is not good for very severe deformities. And yes, the 97 to 99% is always better than 88 to 93%. Thank you.
So I invite Dr. Raghav Muktala to speak on in AIS surgery. You just require direct open approach. Here is Raghav.
Ujjwal, is Bhavuk hearing? I hope so. Right. If you ask an old man, he will always say no to robot. And if you ask a young man, he will always say yes to robot. There's a huge age gap between me and Bhavuk. Can I have my slides, please? As they are going to open up the slides, it's extremely important to remember that most robots are done by expert surgeons in the world today. whereas pedicle screws are done by from the registrar resident level to the consultant. So there is a bigger chance of pedicle screws cutting out amongst the younger generation of surgeons than the experienced surgeons. So when we are comparing huge series, we are comparing experts using the robot with experts where the pedicle cutout is slightly higher among studies done in large volumes of cases and pedicles that are presented. I hope you got what I'm saying. The first one. It's there, I can see it. I'll show you. Fortunately, I also have some experience using robot, and I can now figure out where I need them and where I don't need them. Now, is there a need for a debate here? Debate should be amongst guys who have at least used robots in at least 200 to 250 cases to get some experience to say whether it is needed or not. These are recently introduced robots. They're still evolving. There are so many changes in the robots that we are seeing every few years, used by a minuscule of spine surgeons. So how can we say, like the AO said, unless a tool is used by a lot many surgeons and that technique is useful, we cannot say that it is universal. It may work in the hand of a few surgeons, that's a different matter. There is not much literature on their use and results, and mostly individual experience of or few centers reporting about their use of robots. And surgeons are still learning, that is the truth. Is it actually a robotic surgery? It is really a robotic assisted surgery. It is just the screws being put. And in a situation like adolescent idiopathic scoliosis, the easiest thing to do is to put screws for an experienced surgeon. Hardly it takes any time, especially if you're doing selective thoracic fusions, etc. Now, robots are here to stay. There's no doubt about it. Now we started our careers way back with freehand technique. And then we had these navigation, image intensifiers at that time. Then we had the navigation systems, and then we went on to do 3D models. And about 10 years ago, we thought these are the best things to come. We can avoid radiation. And today, hardly anyone talks about 3D modeling and preoperative preparing of these models and using them in spine. So robots have come over. This is the latest fashion. Now you see a case like this. Such a simple case. You can see all the pedicles, you can visualize them, and all you need is identify where the pedicle is in the thoracic spine. Just see where the superior and inferior facets are. Take a ronger, make a small removal of the bone there, and put a K-wire if you are not confident. Take a shot. All you need is one shot, and that too if you are not confident and early in your series, and then put the screws. Once you put the screws, you put the rods. Once you put the rods, you derotate them or distract them, compress them, whatever technique that you want to use to achieve a good result. That's all you need to do. Why do I need a robot for this? If you don't know how to do this, you must go and learn. That's the first thing. But when do we need robots? Now, when I'm doing a surgery like this, that's when I need a robot. That's when I'm worried about where my screws are going. So that, and again, situations like this, where I can't identify the pedicles, as Bhavuk said, there are segmental bars, there is dysplastic pedicles on the opposite side, and these concave pedicles are not easy to pass screws. That's where I need robots. And also situations like this. If I have a robot, 58 degree, this girl was becoming became a paraplegic, that's when I need a robot to do my surgery for me at that level, at cervicothoracic junction, to go from the front. This I had to do with an open technique. That's where I need to go in between the vessels. That's where I need the robot, but it doesn't work there. Now it is just, again, you see that's how anterior surgery. And then just to put the screws, either pedicle screws or lateral mass screws or screws here is no big deal if you have the experience. Again, another situation, see this. Cervicothoracic junction, what happened here? Now this girl, about 17 or 18 years old, see the myelomalacia with an onset of paraparesis. This is where, if I have to do a surgery from the front, again, I want to go to the front, excise it. But you can't do that. So we need to go all behind. And this is where I had to do an anterior decompression on the cord. How do I do it? If I have a robot, I can do well. So, but again, the robot doesn't help you there. So most times, most of the work done on robots is for lumbar fusions, and most results are for that, not for complex surgeries. That's when we need robots. Now again, as I just said, you see here the great man Suk, just 1.5% malposition, and only 17, this is for his selective thoracic fusion paper, just 1.5%. And Ringel et al., you see there's 85% had acceptable screw placement compared with 93% using freehand. That means that freehand was better than robotic placement. Now again, now see this paper, various patient, surgeon, implant related factors, females, bigger problem, obesity, and of course the skill of the surgeon performing the procedure and a huge learning curve. So here look at this paper, 3 randomized control trials, 6 retrospective comparative studies, no significant difference between robot and freehand technique. The current literature does not prove that robot supersedes FH. Conclusion, robotic assisted posterior lumbar spinal fusion is independently associated with risk of revision surgery, infection, instrumented complications, post-operative opioid utilization compared to conventional techniques. Now 30-day readmissions, complications, infections, all higher with robot. 2,528 patients, 4.45-fold higher risk of revisions due to infection, instrument failure, everything high with robots. So what anybody can produce literature for and against robots. So you have to take all this with a pinch of salt. Duration of surgery is about an hour more with robot than with conventional surgery. And of course, we all know that the longer the duration of surgery, the more morbidity and of course the infection rates. I don't agree that it's all about accuracy. If you have a few screws cutting out, that does not mean that the patient has symptoms, or that does not mean that patient gets paralyzed. To me, ease of use and applicability, ease of learning, those are much more important. Otherwise, like some other hospitals, they bought robots and they are just put in a corner like we do for treadmills. Now, our own experience, you see this child was about 12 years old, small child, paraplegic with grade 3 power. We used this robot And in this situation where I thought I needed robot, it took hours for us to put these screws. And then of course we had to do an osteotomy to correct the spine. So robot is too difficult in difficult situations. In easy situations like lumbar spine, it's too easy perhaps. So is it worth the cost? How long is the learning curve is very important. So I reiterate by saying that we need robots for cervical spine, cervical pedicle screws, tumor resections, and in complex deformities. In AIS, it's not all that important. Certainly for the youngsters, learn the craft, like we did a little bit, but keep it simple. That's the way for successful results in adolescent idiopathic scoliosis. Thank you.
Hi, Babu. So here we have a panel here.
Yes, please.
Dr. Massimo Balsano.
Please, lights on, please.
Dr. Alayuddin and Dr. Rajesh Chaudhary from Nepal. So I would like to have a couple of minutes from each for their view between the two deliberation. So Dr. Massimo, what do you think? I think
Babuk, can you hear me?
Yeah, I can hear you.
How do you stay? I feel better. I heard that you have a problem. So, just a question. Congratulations for the study. For an experienced surgeon to put the anchors, the pedicle screws in the spine is easier. Question is, in the very thin pedicle, probably you can put the most large size screws that you can, and probably you can put a monoaxial screw, but that means, when you use polyaxial screws, we reduce the power of the rotation. Yes. So, what do you think? That using robotics is more useful to use monoaxial screws in the concave side or in convex side to have a more power for deformity correction? This is my question. Also to you, of course.
So I use uniaxial screws for derotation, and I feel that if you need a strong derotation power, if the deformity is complex, then robotic is definitely an advantage, because you can put that in the maximally advantaged biomechanically position. While you are doing freehand, you are able to place, but it may not be the best biomechanical position. But again, you have to be very well versed with the robot. So, like, if I have to give my resident a case, a new resident who has done maybe assisted me in 10 cases, the freehand I think is much easier for him as compared to the robot. So robotic needs more training as compared to just freehand, because you need to know, because once you are drilling with the robot, then you have no control over it. While with freehand, you have much control. So I think in current form, the robot may not be the panacea, but yes, in coming years, as the robots are evolving, they are going to be of great use.
Thank you.
Well, I might say anyway, the freehand, I think it's much higher than 2%. In the literature, some people would say 40% even. It comes in some papers. But the thing is that we are happy with the freehand technique. But I think, as you said, that the robotic is something to stay. And this is kind of the machine learning and the big data. And as soon as it improves and it will be cheaper in price, I think it will be the main of management. And it will be, I think, a medical legal issue in the future, like the neuromonitor now. But the thing is that it's like about cholecystectomy with the scope, but you need to know how to open in case there is a So I think within 10 years, the whole spine will change to a robotic, some sort of robotic or robotic technique, but still there is a necessity that you train in the free hand and to have the sense for putting. This is my opinion. I don't know both speakers. What do you think about that?
I fully agree that the freehand technique is a must, because I have seen in many cases when we were using robot, in the middle of the case the robot suddenly went wrong, that the thing was working and this thing, and that in those cases obviously if you are not aware with freehand technique, then the patient is lost. So I think the freehand is definitely must for any surgeon to begin with.
I think I totally agree with you. I think having used robots, not much experience, but use them. I think we need 10 more years to know where freehand is good, where robot is required, so that the combination of that would help the surgeon to do the best for his patient. I think so. 10 more years, we'll be there.
Pleasure to the seniors who are doing the advanced spine surgeries and the freehand techniques, and we are in the learning phase. But at this stage, I just have some few comments regarding this. You discussed about the advantages and disadvantages and of both the techniques. So I think regarding the robotics, like the main issue comes in the availability, affordability, and the learning curve that we have to go through. And in the scenario where we are working, the robotics may not be available. And in the center where for us, the freehand technique is working well. And as Dr. Raghav also said, in many a time, if there is cut out of the screws also, most of the time they are just asymptomatic cutouts, not clinically they are not so significant. So definitely I would say there are indications for robotics, which Dr. Pavuk has definitely highlighted. It's our, as a young surgeon, we should pursue on that also. But I think for me, freehand technique should be we should master on that at this period. Thank you.
Okay. Am I okay to make it just one comment? I think all the juniors here, both the speakers have very valid points. Your points are extremely valid, and Dr. Garg's points are extremely valid. But my only thing is, if you are using your most valuable asset for the hardest and the toughest case, and you do not have the experience of using it on your regular cases, please don't do that mistake. The thing is, you bring out your best bat if you are a cricketer. You bring out your best tool if you are any craftsman to do your hardest cases. So if you have a robot, and I agree with your point, I use freehand, but please use your robot every now and then, hone your technique. That's when you can use it for your cervicothoracic junction safely. Otherwise, please don't use it.
I don't think they're ready for cervicothoracic junctions, these robots, number one. Cervical spine, I doubt at all. I mean, if they're ready at all. We have used them in the lumbar spine, quite a few, and then only we went into this patient. But we had this technician from Israel next to us when we did this case. It wasn't tough, but we were scared whether the robot was correct or not, so we kept on checking the robot. So it was okay. Yes. You have to do, as Evo said, you have to fix a transverse fracture of tibia first to learn how to fix a complex fracture of tibia. That's how we were taught. Thank you very much.
Thanks a lot for a wonderful discussion. I think thank you, Dr. Bhavukar, and thank you, the panelists. And we go on to the next short talk. No, not yet, because Kashinath has to leave for Bhubaneswar. Could you come, Kashinath Swain? Can you come quickly and present the cases, please? Quick. That's why I was looking for you. I phoned you earlier. Kashi came here as a fellow this year, and we had 8 fellows for the 5 days of session. And following this, we'll continue our normal, will be Sagittal planning in AIS. That will be followed by actually Professor Shah Alam and Junaid, because they have to leave by 4:30. So we'll get on to with their 2 talks, and then we'll follow the line of action with the next 5 talks. I'm sorry for all these happenings, but it all happens everywhere, and this is no exception. So, and it's far away from the airport, and everybody is in a hurry to go, so we have to be in precise time, but we didn't have any timekeeping today. I'm sorry to hear that, that the organizers did not have that with us. So we lost our time on our presentations as well, but never mind, we had good talks and good discussion. So Kashi will be showing all the cases that we have done. Only 8 cases, is it?
9 cases.
9 cases. So 10th case X-rays you don't have. All right. Thank you.
We have done 9 cases here. All the cases, 10 cases. All the cases were done under the neural monitoring. First case is 2-year-old congenital scoliosis. Where is the slide? I can check. With D11 hemivertebra. The baby is from Haryana. Clinical image with pre-op X-ray, CT, MRI. This is the post-op X-ray. Deformity correction was done by hemivertebra excision and PSIF from D9 to D11. And post-operatively, patient is fine. The second case is Adrija Basu. She is a 19-year female. She has adolescent idiopathic scoliosis. This is the X-ray, preoperative X-ray, MRI. She underwent PC D10 to L4 with deformity correction. Case 3 is Tithipan. This patient has been already discussed. She has gone multiple operation. And case 4 is Kanak Srivastav. She is from also outside West Bengal. It is a case of congenital thoracolumbar scoliosis. This is the pre-op X-ray. And she underwent deformity correction and PSIF from D3 to L1. This is case number 5th. This is Master Akash Sheikh, a 15-year-old male with syndromic scoliosis. Now, this is the X-ray. Deformity correction. This is nicely corrected deformity. Case 6, Region of Irvin. Case of adolescent idiopathic scoliosis. This patient underwent growing rod fixation from D to L3 with apex correction technique, active apex correction technique. This is a case of syndromic scoliosis again. This patient underwent, this patient underwent both anterior and posterior approach as we performed OLIF at L2, L3 and L3, L4, and we fixed each patient from posterior side from D10 to L4. This is case number 8 is a left L3 hemivertebra in a 20-year-old male. This patient looks normal, but patient has a significant pain. So with pain, we perform the surgery in the patient. Interrupter now. Oh, I don't know. And this is case 9. This patient also underwent previously 1 year back operation for hemivertebral excision. Now she is 5.5 years old. Actually, this patient is operated yesterday only. That's why we have not the post-op X-ray with us. Thank you.
Okay, thank you very much. So we continue with our deliberation with Professor Dr. Shyam for surgical experience of complex thoracic and thoracolumbar kyphoscoliosis in Bangladesh. Professor Dr. Shyam, please come and give your precise case presentations, I suppose, and we'll continue after that with Dr. Junaid, and then we'll follow whatever we have in the same order. Thank you very much.
Good afternoon. Thanks to Professor Ujjwal and his team for inviting me here. As my talk is on surgical experience of complex thoracic and thoracolumbar kyphoscoliosis in Bangladesh perspective. I am from Dhaka, Bangladesh. I was the head of the department orthopedic and spine surgery in Medical College. Right now I am retired and I am working as a chief consultant of Bangladesh Spine and Orthopedic Hospital. So as the talk is on scoliosis, all we know by this time that it is one of the most complex, the spinal deformity among all spinal problems. So as per SRS, it is defined as the lateral curvature more than 10 degree when in erect posture. It is measured by Cobb's angle. So how we'll see the scoliosis? From the back we will see that the tilted pelvis or rib hump or elevated shoulder or unequal length or shortening or limping. So this is the three-dimensional deformity. So before going for any diagnosis or treatment, better we should know what is the balanced and imbalanced and the spine. The first picture, if you draw a line straight, when it is straight, the bisecting the all, in the midline, when she has been line down, so it is a balanced, it is the coronally balanced. Again, when we see there's some deviation from the midline, maybe positive or negative, that is imbalanced, that is coronally imbalanced. So again, also come to the point of a sagittal imbalance. When we are drawing the plumb line starting from C7 to posterior superior aspect of the C1, then it is called the balanced, the sagittally. But if it goes front, then positive, or it goes behind, then we consider that it is imbalanced coronally. So that's why it's a combination of the rotation and the sagittal and coronal deformity that leads to produce this sort of deformity. So before going for surgical intervention or diagnosis, we must know there are some vertebrae that are the culprit vertebrae, as that considered as strategic vertebrae. So this is the vertebrae that producing the curve, and this is the vertebrae that needs to stabilize, and this is a big concern for a surgeon. So the vertebra that make the deformity, vertebra that needs to be instrumented, and vertebra that is the most concern for the spine surgeon. So this is the two end of the curve, the above and below, the three thing is most important. The above is the neutral vertebra, that is there is no rotation. Next one, the stable vertebra, that is when sage base line is bisected equally, that is the stable above and below. The other one is the most, the rotated vertebra, there is the end vertebra that is leading and initiating, and the end and starting of the vertebra, there is the end vertebra. These two is the most important because along with we needs to know the apical vertebra, the mostly, the distal vertebra from the CSBL line. That's why when we'll go for the instrumentation, that the lower, the neutral vertebra should be instrumented, that is the ALIV. Again, the upper instrumented vertebra, the upper neutral vertebra, end vertebra, because these two neutral vertebra is most important for correcting the curvature. There are a lot of classification systems that most of popular, the treatment purpose, the Linky classification, especially is the major thoracic, proximal thoracic, major double, triple double, and there is some modifier. I am not going to in details, but this has the importance for correction of the deformity. The lot of causes, but mostly our concern is the congenital and most the prevalence and incidence of AIS. So we want to talk the AIS. Already you know the AIS is more than 10 years, 10 to 18 years. Female are sufferer, cause is unknown. Mostly the right-sided curvature. Usually there is no pain, but sometimes may be associated with the pain or neurological deficit. So when we examine the patient, we must see that whether the shoulder is balanced or the pelvic is tilted or not, or there is a shortening or rib hump. These are the points we need to consider before going for surgical intervention. So for clinical evaluation, the shoulder balance, especially when the Linky type 2, there are a lot of points already it is mentioned, that is the biacromial angle, shoulder angle, first rib angle, clavicular angle. I'm not going to in details, but these are the points needs to be considered before going for surgery. So this is the acromial angle, external angle of the shoulder, this is the axillary angle, this is posterior axillary angle. Congenital scoliosis. There are a lot of causes, especially we consider the hemivertebra, block vertebra. And these congenital scoliosis, mostly it is presented earlier, diagnosed earlier. So whether either we do conservative treatment or surgical intervention, it is since diagnosed earlier, so we can expect the result. So there are some, the degenerative scoliosis also we find, and these scoliotic, degenerative scoliosis usually after 40 or 50 years, or sometimes they may have the initiation of the curve initially small, but gradually it increases due to increasing the age. So the management of the degenerative scoliosis is mostly conservative before 40 years, but after 40 years, depending on the curvature, depending on the deformity or depending on the symptoms, then it requires surgical intervention. The diagnosis is mostly the radiology. It should include the lower cervical, cervical 7 to proximal femur, both lateral, both right and lateral bending films. Sometimes we do fulcrum bending, CT, MRI, and also we do sometimes myelo-CT. The management protocol already we have already known, but is a very clean cut. When we go for observation, when we go for bracing, when we go for surgery. The clean cut message is that when the Cobb's angle is less than 20 degree, it doesn't need any sort of, the bracing, only the follow-up, even no need to come very frequently. But when the Cobb's angle is 20 to 40 degree, it needs the, some follow-up and also the bracing. Different types of bracings are there. Mostly we do the Milwaukee brace and Boston brace. When the Cobb's angle is more than 40 degree initial, when the patient come to you, and consult with us, will go for the surgery. Other than this, the most important issue is the cosmetic appearance, or the curve is day by day is progressing, and also if the patient having the pain or neurological deficit, we go for surgical intervention. So objectives of this surgery is to stop the further progression and also to achieve the maximum correction and to improve the cosmetic appearance. These are the goal for surgery. So choice of surgery, the lot of surgical procedures, sometimes they combine, but we followed all cases the posteriorly. As because the posterior, we can correct the big curvature and also we can extend, and sometimes if it needs, we can go for 360 degree stabilization or the decompression. That's why the long segment correction is possible only by the posterior approach. So we adopted in our experience, all we did the posterior. So what is the ideal is, as the late as possible, near to the closure of the epiphysis. But thing is that when you will get a patient having the 40 degree or more than 40 degree, your Cobb's angle, definitely it is an indication for surgery. So the optimization of the scoliotic surgery is the most important. Already it is mentioned we need to see the serum albumin, especially pulmonary function. Pulmonary function and the BMD, because there is a correlation with the development of the lung function. That's why we must go through it, the pulmonary function. Counseling is one of the most important issue. Counseling with the patient attendant especially, and also among all team members. Because without any discussion, if we do surgery, sometimes there may be some catastrophe leading to neurological deficit to life-threatening condition. That's why we must have the group discussion among the patient as well as the patient attendant and the team members. And the OT setup, the ideal instrument and ideal OT setup, and if the neuromonitor is not available, better not to do any sort of, the complex deformity especially. So the neuromonitor is one of the guidelines during the surgical procedure, and we followed it nowadays. But when we started this journey, then we didn't have any neuromonitor, we didn't have any Shyam, even we didn't have the whole spine, that is the scoliogram we couldn't do. So when I'm going to share our experience from Bangladesh, we also shared that the expectation versus the outcome, because the patient attended all the time, their expectation high, because it should be good looking, the externally as well as the good looking in the radiologically. That's why there should be a balance between the expectation and the outcome. We can do 100% correction. You are a surgeon, you have scalpel, you have osteotomy, so you can do it. But how much you will do it? Our expectation, if we can achieve 50, 60 or 70 degrees is more than enough. Because if we try to do the whole correction, you can damage the neurology. That's why the target should be not that the 100%. So our experience from Bangladesh say, we are very few, we are doing scoliotic surgery in Bangladesh, and my starting was a very complex, the patient. As because when there's a less curvature, less curve, patient doesn't come to doctor. When it is, the mostly marital age, 14, 15, 16 years, because our observation is that AIS is mostly found in the lower socioeconomic condition, the family patient coming from a lower socioeconomic condition. So the marital age, the parents becomes very panic and they are finding the doctors. By this time, many, the curvature is already very complex deformity. That's why we started my starting of the scoliosis surgery with a complex patient. For an example, this patient, I did it 20 years back. You see how much deformity is there. The curving is more than 110 degree. And at that time, we didn't have any scoliogram. We didn't have the facility to do left or right bending X-ray. Even we couldn't do the CT scan. And you see only partly you can see, but not whole spine. But patient came with a good expectation. We adopted the posterior procedure, all we did, but we have also limitation for instrumentation and implants, and we corrected it. And you see, this was the correction that we achieved 20 years back. But now we can do some extent better than this. And if you compare this patient, the 20 years back, the initially rib hump, before surgery and after surgery, to some extent it has improved, but not as much as the patients expected. Another patient, huge kyphoscoliotic deformity. The curves angle is more than 100 degree, and you can see the rib hump and also the deformity, both posterior and anterior. And we did the posterior surgery, and not that much correction was achieved, but even that cosmetically patient is a little bit improving. So if you compare before and after surgery, there is some residual deformity still, but externally is looking better than before surgery. So now we have the scope for neuromonitor, we have the scope for scoliogram, and we can see whole spine including the pelvis, skull, and the proximal femur. That's why this is the patient nowadays we find out the strategic vertebrae, so we can correct the part of the curvature already there, the deformed part. So this is the patient, the before surgery and after surgery. This patient, the final outcome, there is the deformity posteriorly and almost at the normal state curve. The another curve is the Linky type 1, and the rigid variety, we corrected it posteriorly. This is the before surgery and immediately after surgery, and this is the final outcome. Aesthetically and radiologically, it has been corrected and improved. The another patient that has also adopted the posterior surgery, we did all posterior correction. Is not working. So this is the before and after surgery. This is the final outcome, both radiological and aesthetically. This is the degenerative scoliosis. We corrected it posteriorly. This is before surgery, X-ray and CT scan. This is after correction, the radiology, and this is the final outcome. This is the another patient having got the deformity of the thoracolumbar, and we corrected it posteriorly. And this is the final outcome, and this is the aesthetical and radiological. Last. This is the another patient. This is same procedure adopted. This is another patient before and after surgery. This is final outcome. This is double curve. We corrected it posteriorly. This is the before and after surgery. This is another patient. This is finally. And this is one of the cases of congenital with the respect of Allah. I learned this operation from him. This was the curvature and this was the the hemivertebra. We adopted this procedure, but there was a hypokyphotic deformity, patient with some sort of pain. Then we corrected it finally. And this is a final outcome after correction. This is a before and final surgery. So I like to say that the complete is not working. So there were some complications in my series. We did 184 cases and 3 patients developed the neurological deficit. Totally 2 patients didn't regain, 1 patient regained partially, and we lost 1 patient due to pulmonary complications. And so one of the important issues, the identification of the scoliosis is most important, and informed consent and proper counseling is the most important. And without neuromonitor, we shouldn't do surgery. This paper was awarded as one of the best poster award in 2016 in Melbourne, Australia, in 2016. We like to invite you that I'm the president right now in the Bangladesh Spine Society. So in November 12th and 13th, we have the Congress. All of you are cordially invited, including Professor Devnath. Thank you very much.
Thank you, Dada. It's very nice that you landed up early, and we go on to the next stage is Sharif Junaid, single stage vertebral column resection for rigid kyphosis correction in TV spine. These both persons has to take the flight, so we had to reshuffle and get things done in the way they wanted. Sorry about that, everyone. And okay, Dr. Junaid, keep it short. Okay? 8 minutes.
So thank you, Dr. Ujjwal Devnath, for inviting me. Actually, my previous speaker has described lots of cases with scoliosis and other deformities. Now let's see the case. So this is a case of 7-year-old girl with a progressive kyphotic deformity. At the time of presentation, she has paraparesis with bowel bladder involvement. If you see the if you see the MRI as well as the CT scan, you can see that the extent of magnitude of kyphosis is so high. That is, management of these sorts of deformity is always challenging to the spine surgeons. So this is my talk, single stage PPCR for correction of rigid kyphotic deformity. So at the end of my presentation, you will be able to see understand as well as evaluate the post-TB kyphotic deformity to demonstrate the PPCR with its merits and demerits. As you all know that kyphosis is the most common dreadful complication of the tuberculosis, and surgery is always indicated for both corrective as well as the preventive. But surgical correction is extremely difficult and there is a potential dangerous too. So if we look for the kyphotic deformity, basically TB starts with the paradiscal lesion that causes the weakness of the end plate. Ultimately, the disc is migrated to the body and there is the anterior body destruction, which leads to the angular kyphosis. Even TB is treated conservatively with a successful treatment, there is a still chances of 15 degree of kyphosis progression. But if there is more than 2 to 3 vertebra involvement, in that case there is high chances of severe kyphosis. So the healing potential is also depends on the involvement. If there is a single, there is a wide area of contact. If there is one, the single facet joint is subluxated, then restabilization by the point contact as you saw here. But if there is more than 2 to 3 year facet joint subluxated, then there is a direct horizontal of the proximal segment over the caudal segment. So this progression again has two phases. One is the active phase, is actually starts 18 to 24 months, and the heal stage, that is called the rigid deformity ultimately. So these sorts of deformity again depends on the extent of the destruction, age of the patient and level of the lesion. So if your patient has age is less than 7 years age, if involvement is thoracolumbar with 2 vertebral body involvement, if he or she presented with spine at risk and more than 2, then definitely kyphosis will be progressed high. In the adult patient, if the kyphosis initial is 30 to 60 degree, but there is involvement 1.5 vertebral body. So in that case, there is a chance. So difference is that in case of children, even the healed cases, it may progress. In adult, until it is not progresses the 60 degrees, so chances of further progression is very low. So management again depends on the extent of involvement, neurological deficit and cardiopulmonary status. So if we see this scenario, in the ancient time, as there is no effective treatment, there is only direct compression. Nowadays, with the advent of technologies as well as instrumentation, things is little bit easier. So though there are lots of procedure, but rigid deformity, actually it needs more strategic correction, and BCR is one of that option. And it is actually popularized by Suk in 1922. So this can be done either by anterior, posterior, combined. As we all are accustomed with posterior, that's why we choose the posterior, because we all are familiar with it, and there is less chances of complication and less chances of morbidity. So this is the technique. So before going to start the technique, you have to properly position the patient, because that is very much important. Next is insertion of the screws, and next step is the PCO, that is vertebral column osteotomy. You have to start with the laminectomy, then step by step by excision of the transverse process, and selective cases if needed the rib excision. And the important things is that before going to start So, because counseling is the important part. Otherwise, if you not counsel properly, that is not ideal for the patient as well as the safety of the surgeon. Next, please. So, it is always said that prevention is better than cure. Why? Because if we prevent earlier, we can detect the rigid type of kyphosis. If it is detected earlier, so technically it is easier to correct and there is chances of less neurological iteration with a good outcome. So finally, I would like to say that you have to mention the safety of the patient, counsel the patient, though it is highly technically demanding, but as it is associated with complication, you have to be very cautious regarding this procedure and can be performed safely with a proper patient's training with a good infrastructural facility. Thank you all for patient sharing.
Thank you very much. I request Dr. Prashant Bed to come on the dais for his talk on sagittal plane planning in AIS surgery.
Thank you. Hello. Prashant. Prashant. কোনটা চলছে ওয়ার্কিং হ্যালো hello yeah good afternoon so I will try to keep the presentation short this is already a post lunch session and I think everybody is a little busy All right. So before coming to the sagittal balance, because in scoliosis, AIS especially, we are more bothered about coronal plane deformity, and we very oftenly, I think most of the surgeons, they forget about sagittal balance. But I think the sagittal balance is a key to prevent early and late complications scoliosis surgery, especially in AIS. So before coming to the sagittal balance, let us brush ourselves about the sagittal balance. So this is called global sagittal balance. So before coming to this, we need to know some terms like SVA, which is sagittal vertical axis, which is a line drawn from the mid C7 vertebra down, and ideally should be touching the posterior part of the sacrum. So it can be neutral if it's touching the posterior part of sacrum. The balance is negative is falling behind sacrum, and positive if it's falling in front of sacrum. Now, the sagittal plane harmony is basically a combination of a lot of curvature of the spine, namely the thoracic lordosis, the cervical lordosis, thoracic kyphosis, and neutral thoracolumbar junction and lumbar lordosis. But don't forget about the pelvis and sacrum because this is the key bones for the sagittal balance. Now, the normal sagittal balance or alignment is very wide, is variable, and it changes with growth. But we are talking here in terms of only adolescent and adulthood, where typically thoracic kyphosis is in the range of 20 to 45. The TL junction is neutral, which is 0, and lordosis is about 45 to 75 degree. Now, the normal sagittal alignment it has a wide variability. The reason for wide variability is nothing but is the orientation of sacrum and the pelvis. So recently presented a very good paper about the orientation of sacrum and the pelvis, which led to the variable PI, pelvic incidence. So you can see there are 4 types of variabilities. The sacrum can be sticking straight or horizontal, and depending on the type, the sacrum is presented in the pelvis. In terms of pelvis, there is a wide variety of sagittal alignment. The spinopelvic relations is the most important for the overall global alignment of the spine. It is mainly the orientation of sacrum and the pelvis which determine everything. Sacrum is basically as a pelvic vertebra as defined by Debouche, rightly defined by Debouche, and as you know that the spine is built up from the ground up, from the sacrum up. Now, the alignment of the overall side alignment depends on how the sacrum is oriented. It can be neutral or it can be horizontal. If it is horizontal, your lumbar lordosis will be higher, or it can be vertical, and then your PI will be lesser and the resulting lumbar lordosis kyphosis will be smaller. Now, the spinopelvic relationship is between these parameters, which is pelvic incidence, which is constant. It does grow during the adolescent period, but it's largely remain constant whether you're sitting, you're upright, you're bending, or whatever the position of spine is. Normally it is 40 to 60 degree, whereas sacral slope and pelvic tails, they're constantly changing with position of the spine. Now, here the PI, we know the PI is equal to SS plus PT. So whenever the pelvis is flexed, the sacral slope increases, whereas wherever the pelvis is extended, the sacral slope decreases, and vice versa. Now, if you look at the images on A and B, if you look at the orientation of sacrum in A, it's quite vertical, and that's why it needs very little of lordosis and kyphosis to be aligned on the sacrum, whereas on the B, you see the sacrum is quite tilted horizontally. That's why this person requires a lot of lordosis and kyphosis to maintain the alignment on the sacrum. So the sacral slope is basically is a takeoff angle of spine, and the SS correlate with lumbar lordosis. But actually it is a pelvic incidence which is a key which determines the overall alignment of the spine. So in summary, the normal sagittal alignment is a harmony of kyphosis and lordosis. It has wide variability and is directly influenced by the orientation and attachment of spine to the pelvis. Now, coming to our talk, sagittal alignment or malalignment AIS, we are, as a surgeon, we are so much focused on the coronal plane of deformity, especially in the AIS patient, that we forget about the lateral view or the sagittal alignment. And spine is, as Dr. Alam said, spine is deformity, the scoliosis is a combination of coronal, sagittal, and axial plane abnormality, which is 3D deformity. But it is the apical lordosis, which is the main deformity. This is the apical part of the apex of the curve, and this is the main deformity, and most of the time we ignore it. We ignore it because we tend to focus more on the coronal view of the spine. So the sagittal malalignment often is underappreciated. It's not appreciated. And the 3D deformity, we try to see 3D deformity in 2D. The easiest tool we have is the X-rays. So X-ray is a 2D plane where we cannot see the 3D deformity. And that's why we always underappreciate the deformity. So this is a place where the majority of deformity is located. This is the apex of the curve, and it has a lot of rotation which causes thoracic lordosis. Now, this is a paper which came long back, which is 91, and which shows that lordosis, or thoracic lordosis, is a significant aspect of scoliosis, and it's difficult to assess with routine clinical radiograph. So what is the remedy? The remedy is, the remedy comes from this paper. Peter Newton did a very good job, and they came out with a solution to it. They tried to analyze the deformity using the EOS machine. So basically, the lateral X-ray of patient is not equal to lateral X-ray of the spine, and the rotation and coronal plane deformity, they give you the apparent kyphosis. So most of the kyphosis is very low, and we tend to measure it higher. So they tend to, they came up with the EOS machine, and they did the 3D reconstruction of the spine, where each vertebra, each single vertebra was, they untwisted on each single vertebra and defined the kyphosis in vertebra. And it is, with the profound, the finding of this paper, this shows that it is actually, there is a thoracic lordosis rather than kyphosis in the spine. So So the 2D lateral views overestimate the thoracic kyphosis by almost 11 degree, and difference increases with increasing rotation. So we cannot accurately measure sagittal plane with X-rays. And so when we derotated the spine, we thought we were creating lordosis. We actually not. We are actually unmasking lordosis. So these are a lot of implications. The implication, if you undercorrect your kyphosis, the implication is you will have PJK, you have DJK. So there are early sequelae and there's a late sequelae to sagittal malalignment. Take much time, just 5 minutes more. So I won't go into PJK in detail, what definition, but I've shown you what happens. The reason of PJK is pre-existing deformity, iatrogenic hypokyphosis is one of the most important, and improper level selection. So never forget your sagittal plane, and you will get it wrong more often in sagittal plane rather than coronal plane. So as a paper says that you always underestimate the kyphosis by 11 degree. Always remember this, more the rotation of the vertebra, more the apical rotation, more the corpse angle, more the chances you will undercorrect the kyphosis. So always bear in this mind and then correct deformity accordingly. And there's a huge evidence that, level B evidence that pre-op hyperkyphosis is a risk factor, as well as pre-op hyperlordosis risk factor for PJK. And if the thoracic kyphosis is more than 40 degree pre-op, then make sure that you don't decrease more than 5 degree. If you decrease more than 5 degree from the pre-op, your chances of landing in PJK is huge. So iatrogenic hyperkyphosis, for each degree of kyphosis you're decreasing, you're increasing PJK chances by about 7 degree. And if the patient has already pre-op hyperkyphosis, and if you're decreasing by 5 degree, your chances increase chance of PJK. And you also avoid iatrogenic hyperkyphosis by and these kind of curves, lanky plus curve, and understanding your sagittal plan preoperatively well. Improper level selection, never go caudal to your upper end vertebra. The lower the thoracic UIV you have, the chance of PJK increases. So do not stop short. So these are so because of the short of time, I will skip this thing and I will come directly to DJK. So distal junction kyphosis is about 0.2 to 15% AIS. Definition is about more than 10 degree from your LIV to the lower caudal end plate. And the distal junction failure is when you say osseous failure. Now, how do you prevent DJK? So there's no long-term studies done for DJK. The sagittal plane deformity correlates closely with poor long-term quality of healthcare outcome, and altered biomechanisms may lead to accelerated degenerative changes. So the main reason of DJK is high BMI and pre-op thoracic hyperkyphosis, especially if you are undercorrecting it, or iatrogenic disruption of adjacent anatomy, and if you choose your LIV incorrectly, the chance of DJK is very high. Selection of fusion level is the single most important modifiable factor in this case. Now, the LIV selection, the surgical planning is very important. A more proximal LIV preserve motions, but it also increases chance of developing imbalance both in core and sagittal planes. So the rules exist for choosing the fusion level. The most only take the coronal plane in account, but it's very important that you take your sagittal plane in account to avoid the DJK. So this patient, if you look at the thoracolumbar junction, the kyphosis is about 20 degrees, and this is a structural curve. When you have this curve, thoracolumbar kyphosis, you always go beyond thoracolumbar kyphosis. Don't fuse short. If you fuse short, then you will tend to have the distal junctional kyphosis. Now we come to the concept of the sagittal stable vertebra, which is called SSV. This paper, which come long before, especially in thoracic hyperkyphosis. And SSV is basically the most proximal vertebra touched by posterior sacral vertical line. Just 2 slides. So in thoracic hyperkyphosis, if you include SSV, then your chance of DJK decreases immensely from 71% to 8%. The concept of SSV now have been put into the AIS also. So the goal is to keep the center of gravity of the fused spine directly over the sacrum. So this SSV, there are 2 definitions, one by Cho, which is vertebra last touched by PSVL, and Yang is a vertebra bisected by PSVL. 50% of body should be anterior PSVL. So if you choose SSB for your LIV, your chance of DJK decreases immensely. From young it shows that from 17% to 0 degree, and from Seagull et al. It shows from 15 degree to 5 degree. So this is the patient, if you look at this, is the coronal, and if there is a discordance between the coronal and the sagittal plane, in this patient, the surgeon fused him to T12 instead of L2. But if you look at L2, L2 is basically is the SSP, but he chose T12 instead of L2, and he had a profound DJK. So up to 6 times higher rate of DJK if you see short of SSP, increased risk of DJK for BNC modifier. So consider extending fusion to include SSP in your high-risk patient. So in a pre-op planning, LIV selection is very important. Account for sagittal balance plane. Consider include SSV infusion, and intra-op you preserve your adjacent anatomy and decrease the stress on LIV. Thank you. I've not finished the talk, but since there is a dearth of time, if you have any question, you can ask me.
Thank you very much, Prashant, for coming all the way. Next is Mr. Girish Swami. If you could come up and speak on distal adding on in AIS Lenki 5 curves, please. Mr. Girish Swami.
Talk मिल गया? It's in the main folder. Thanks everyone. It's been an exhausting 1 week, and I think we've had a great culmination to the grand event. I'll try to keep it really short. It's on the desktop. G Swami, Dr. Swami, Dr. Girish. So I'll try to keep it very brief. I'm only glad that it's a core competent spinal surgeons around here. So this is where I work at Norfolk and Norwich University Hospital. I'm also associated with several other hospitals, and I was trained by Bob Crawford and several others, and for his sins I took over his job. So just a background, we all know what Lenki classification is, and we all know what Lenki 5C means. It's a structural thoracolumbar curve, and we all have our own selection criteria for surgical management, either 40 degrees or 50 degrees, depending on whether there's any truncal shift or not. And the significant challenge in these 5C curves are the fact that there can be a significant coronal imbalance. This was for the benefit of the junior audience who have all left. So as evidence, there are several papers which say what the best form of treatment is, and there is overwhelming evidence nowadays to suggest that single stage posterior scoliosis correction for the 5Cs are pretty good. But I can see that Massimo is actually not nodding his head, so I can show you some cases where anterior is equally good. The big question in the Lenki 5C types is, we all know, and there's never really a debate about what's the upper instrumented vertebra, but the debate is always, where do you stop? And that is the key question of the talk. And this has been extensively discussed, especially in the more recent times, but still we are not entirely sure. There's no certain criteria. And we all know that if you have to achieve optimal correction, you have to go longer, but equally, you want to preserve lumbar motion. And if you go too proximal, my previous speakers kindly alluded to the fact that, yes, the curves do decompensate, distal curve decompensation. If you go too distal, you sacrifice the lumbar motion. We have this concept in UK, get it right first time. That is, we hardly get it right first time, but there you go. We all make mistakes. and the selection criteria, there are several selection criteria. If you look at literature, if you look at anecdotal evidence, if you talk to the colleagues around the world, some people would love to, fix it from the COP to COP. L3 is the most commonly selected level if you do COP to COP. And people who practice a lot of anterior surgery, they would love to do that. And the next criteria is, where does your central sacral vertical line end? Is it barely touching the end vertebra, or is it touching the distal vertebrae substantially? Or do you want to go to the stable vertebra, which is basically you can see both the pedicles? Or do you want to go stable plus one vertebra? So there's no clear answer for this. So several examples, I won't dwell on this. Again, how different people have chosen different levels of fixation. Again, equal good results if you do anterior surgery or posterior surgery. And universally, we all accept from the talks from Bob Crawford, Massimo, and all the other eminent speakers, we know that we can preserve levels if we go from the front. But the crux of it is, what is the risk of distal adding on? The distal adding on basically happens when you have progressive correction loss. And it can be as a result of two things. One is there is increase in the lumbovertebral deviation. And this is equivalent to what we call crankshafting in the thoracic spine. You fix a very young growing patient, instead of adapting growth rod techniques, then you can get crankshafting. Or it could also be because of increase in the lower instrumented vertebra disc angulation. So the risk factors, as you can see in the evidence, is if you have an inappropriate LIV selection, if you have a larger LIV translation, larger LIV plus one translation, skeletal immaturity is a huge risk factor. Or if there is a significantly increased LIV disc angulation. There are several studies which have looked up on these particular issues, and this study was only published, if I'm right, a few months ago or just last year. And this has clearly mentioned that if your distal LIV is, the central sacral line is only barely touching or substantially touching, also, then and if you choose that as your distal, LIV level, then there's likelihood that there can be add-ons. Younger age, as we discussed, is a significant risk, and LIV and LIV plus one translation and coronal imbalance were also risk factors. They also talk about the definition of LIV. This is the most important thing. When we talk about where do we go, we need to know, how can I tomorrow, if I have a case, what am I actually realistically looking at? How do I translate it? So if you have an LIV translation of below 35 millimeters, 3.5 centimeters, then L3 has, across the literature, if you go and look around any literature, they accept that L3 is probably a good idea. In some literatures, they say if LIV translation of less than 28 millimeters and also LIV tilt, that is the angle, the distal disc angle is less than 25 degrees, then that might indicate to you as to where you want to stop distally. But all the literature that is available have come up with nice evidence to suggest that if the disc angle is more than 25 degrees, or if the LIV translation is more than 35 millimeters, then there is a huge risk of add-on phenomena. Again, this is an excellent study which shows that L3 translation predicted the risk of add-ons, and again they have come up with the same conclusion of less than 3.5 centimeters equals there's a likelihood that it will add on. So thank you very much. That was quite brief. I would have gone on and on, but it's a very knowledgeable audience. So two take-home messages. If the LIV translation or LIV translation is less than 3.5, that's a good choice. If the angle is more than or less than 25 degrees, that's a good choice. Thank you very much.
Thank you, Girish, for a wonderful understanding of the subject. I would then request Dr. Chinmay to come over and give his talk on preventing PJK in thoracic kyphoscoliosis.
Good afternoon. At the initial part of the day, I have seen many lectures about many advancement of spine surgery like robotics, like vertebral tethering, minimal invasive, thoracoscopy, etc. And at the end of the day, people are discussing about complications. And I'll also discuss some of the complication adjacent segment problems like proximal junctional kyphosis. So I'll keep my talk short. First, I'll discuss the introduction, then definition, then classification, measurement, pathogenesis, risk factors, then why to prevent proximal junctional kyphosis, what is the reason, then strategies to prevent, treatment strategy if PJK happens. So, the proximal junctional kyphosis is the development of the kyphosis at the transition between the fused and mobile motion segments has emerged as one of the most important complications of the posterior instrumentation fusion. It's a major challenge to the deformity surgeons, and it presents with abnormal kyphosis immediately above the uppermost instrumented vertebra. There are a lot of different definitions because there is no consensus. So the most commonly used definition is the proximal junctional sagittal curve angle, which is composed of the lower end plate of the UIV and the upper end plate of the two supra-adjacent vertebrae, that is UIV plus 2. If it is 10 degree higher than the preoperative level, then it is PJK. There are a lot of unsolved questions because it is incompletely defined and incompletely understood. But it is, we know that it is multifactorial. There are a lot of classifications, but there is no definite sort of classification. There is a spectrum of the problems in case of proximal junctional problems. One end of the spectrum is PJK and another end is in proximal junctional failure. So how to measure the PJK, I have already discussed. It's a spectrum. So at the one end of the spectrum, there is only radiological abnormality, no clinical sign or symptom. And another end is pain, deformity, prodding of implants, neurodeficit, impairment of the quality of life, and sometimes there is need for revision surgery. Say for instance this case. This case started with this implant failure, then it was done, a decancellation osteotomy was done, and then after 4 years, the PJK has developed radiologically, but there is some cosmetic problem, but patient did not complain anything about this, about her problem. So it is basically radiological PJK. But there are some many problems, many clinical problems like kyphosis, structural failure of the body or posterior ligament complex, pain, neurological deficit, etc., etc. So then it is called proximal junctional failure. So there may be vertebral body failure, there may be PLC failure, there may be vertebral subluxation, there may be implant failure, and at the extreme end, myelopathy due to stenosis. The pathogenesis of PJK is multifactorial, and we have to consider it, otherwise we cannot recognize or prevent. Extensive paraspinal muscle dissection at the upper instrumented vertebrae is one of the most important cause. Disruption of the supraspinous and interspinous ligaments, facet violation at the UIV, improper end vertebra selection. That is very important because end vertebra selection is controversial even today. Proximal severe disc degeneration, compression fracture at the uppermost instrumented vertebra, especially in case of osteoporotic individuals, instrumentation failure of the proximal construct. Then there are compensatory mechanisms in case of any deformity, either preoperatively or even after the operation. So preoperative compensatory mechanism is happening in case of primary deformity. Post-operative compensation also happens following the limited or long fusion. And compensatory changes versus intrinsic deformities can influence the decision regarding UIV and required degree of correction. So PJK can be considered as a compensatory mechanism for the overcorrection of the sagittal balance, and correction for every individual is different, because if you correct in a plain osteoporotic individual fully, then there will be more chance of PJK. So there are certain risk factors like patient-specific radiological and surgical risk factors. I'll discuss the surgical risk factors only because all other risk factors are discussed previously by previous speakers. The surgical risk factors are soft tissue disruption, fusion to lower lumbar or sacrum. A magnitude of correction, if it is greater magnitude, chance of PJK is higher. Choice of UIV is very important. Use of only pedicle screws in the whole construct, and thoracoplasty, which is not discussed. Now, why to prevent PJK? Because there is no well-established management guidelines for PJK, so we have to prevent it. There are three-pronged strategies: patient-related factors, radiological factors, and surgical factors to control proximal junctional kyphosis. So try changing modifiable factors, because some factors are non-modifiable, like age. Risk factors should be sufficiently considered before surgery. Sagittal alignment of the patient should be checked. Careful decision making should be done about the UIV. Damage to the facet joint capsule and interspinous ligament should be prevented at any cost. And weight loss, nutrition counseling, osteoporosis treatment like with teriparatide or denosumab. Smoking should be stopped. Increased paraspinal musculature should be tried before the surgery. We should avoid the inadequate restoration of the sagittal balance. Consider correcting the PI-PLL mismatch, pelvic tilt and SVA. Patient with high PI require slightly less LL, less lumbar lordosis, and people with low PI, less than 40, requires slightly more LL. That is to be kept in mind. Sagittal vertical axis should be age adjusted, not same for everyone, and personalized radiological target should be taken. We have to consider the SVA, we have to consider the spinopelvic parameter, and we have to understand the primary deformity, lumbopelvic parameters, primary deformity, and compensatory mechanism. And the two basic things for sagittal balance should be kept in mind: keep the pelvic tilt less than 25 degree and try to keep SVA less than 5 centimeter. That is two simple points. And important factors in sagittal decision making are number of the instrumented vertebra, soft tissue protection, choice of UIV, etc. We have already discussed. And proper correction of the sagittal profile is important. And sometimes we have to use vertebral cement, that is PMMS cement, at the UIV or the vertebra above the UIV. That can protect screw pull out and as well as compression fracture and PJK. So where to stop the fusion? At the end vertebra, neutral vertebra, stable vertebra, that is important. And long fusion versus short fusion. Long fusion, less chance of PJK, short fusion, more chance of PJK, but long fusion has more chance of other complications and higher pseudoarthrosis rate. That is to be kept in mind. And less soft tissue destruction at the UIV is very important. And selection of the UIV. If UIV is T8 or above, less chance of PJK. If it is below T or at the T8, then is more chance of PJK, but higher less complication rate. So to prevent the stiffness of at the UIV, we can add supralaminar hook, sublaminar wear, or we can use the vertebral hybrid construct, or we can totally supplement the pedicle screw with a supralaminar hook in case of UIV. That can reduce the chance of PJK. And the proper correction of the sagittal profile is important. Achieving optimal sagittal alignment is critical. Sagittal parameters including SVA, PI should be included in the PJK risk considerations, and correcting the PI-LL mismatch. Now, augmentation of the fixation, I've already told that PMMA is a very important tool, not only for the vertebroplasty, but also with the fenestration screw. It can be used to prevent screw loosening and to pull out. And last but not the least, MIS fixation, especially for the UIV vertebra, to minimize the chance of scarring, chance of prevention of the paraspinal musculature injury, and stripping of it can avoid the stripping of the tendons and denervation of the muscles, and it can minimize the approach related thermal injury to the muscles as well as the ligaments and bones. So PJK is a reality. If it happens, what we should do? We should extend the fusion to include more levels. We can reduce the instrumentation stiffness by using hooks or sublaminar wears along with the pedicle screw in the upper vertebra. We can use osteotomy to restore the sagittal balance like PSO or VCR, or even the Ponte osteotomy. and Smith-Peterson osteotomy. We can use cement augmentation, I've already told, and we can use transition rod to reduce the chance of proximal junctional kyphosis. So the take-home message is, proximal junctional problems are multifactorial. There are surgical, radiological, as well as patient-related risk factors. Some factors are modifiable. We have to modify those factors. For reducing risk of PJK, modifiable risk factors should be seriously taken care of. Thank you very much for listening.
Thank you very much. We have exactly 3 talks left. We have one gentleman, Dr. Hao Hua Hu from San Francisco. He would like to speak on how can we prevent post-op truncal shift in lanky 1C curves, and he will not take more than 6 minutes of his talk. And with that will be followed by Dr. Raghav Maluktala, selective thoracic fusion in thoracolumbar or lumbar AIS, and followed by convex derotation technique in AIS surgery. And the last one would be Dr. Massimo Balsano, technical tips in anterior vertebral tether in AIS surgery, which is, I've kept it last because then people will be waiting for him to hear. So that's what we're looking for. Okay, so let's start.
The significance of post-op structures in patients with Scoliosis is that first, it is common, the 13% of surgery that the patients have, and the whole way together. This also is not for the analysis, so even the post-op is a reflection of the alignments, post-op function, so and those that lead to other spasmodic effects without the patients with So our factors we use the
it on a few vertebrae, not moving. Yeah. And then leave rest of the spine unfused so that they have a good flexible movement. I am a big proponent of anterior surgery. I was brought up on that, but as that was discussed, I have removed those slides and we will only talk about posterior selective thoracic fusion in adolescent idiopathic scoliosis. This is for the youngsters. See these simple curves, 40 to 60 curves. All we need to do is either you fuse from top to bottom for a very good result, or you do a select thoracic fusion. You just heard the problems of selective thoracic fusion. So we were brought up in our young days to fuse everything from D4 to L4. Until today, all those patients whom we have fused from D4 to L4, hardly any one of them came back to us with back problems. So that is not a bad idea to fuse them to avoid a lot of problems, but of course you lose a bit of flexibility, no doubt about it. So for better correction of both curves, to diminish the risk of post-operative coronal decompensation, avoid adding on phenomena, this and junctional kyphosis, and to avoid revision surgeries, you do a long fusion. That solves most of your problems. So a situation like this, we end up doing a fusion from here to here, leaving two vertebrae below so that they have no issues of low back pain. That was what we thought, and good correction of the deformities as well. Another patient with a long curve, and again managed with a long fusion. This selective thoracic fusion is debated critically. We just heard these previous two talks. This comes from the belief that a strong belief that a more rigid and straighter spine provides predictably excellent outcomes versus STF with a mobile and less straight spine. In India, whenever we do a selective thoracic fusion, the parents are really worried because the lower lumbar spine is still curved, and it takes hell of a lot of time from us to explain to them that that's good for the child. So the fusion of the major thoracic curve where the minor lumbar curve is left unfused is selective thoracic fusion. Prevents increased intervertebral motion, distal to the motion, and of course decreases the operative time. It's one of the simplest of spine surgeries to do, provided you know where to fuse from which vertebra to which vertebra. The advocates of selective thoracic fusion prefer a balanced and mobile lumbar spine and take comfort from the fact that the rate of progression requiring fusion is very low in the current published literature, which is true. So what should I choose? Which is best for my patient? Long or selective? So it all started with these King type 2 curves. These were what we studied when we started our scoliosis career, deformity career, when Moe thought that by selectively fusing the thoracic spine and leaving the lumbar spine to be more flexible and to eventually balance out and give a good coronal balance, he was the one who talked about just fusing the thoracic spine. This is from the internet. You see here, Lenki 2C, 67-degree curve, corrected to 10 degrees. The lumbar curve automatically corrected to about 15 degrees without doing anything, which is extremely acceptable and satisfactory result. Here's a patient, again you see here, very flexible, thoracic hump, and do a limited fusion in the thoracic spine, you would end up with leaving at least 3 to 4 vertebrae in the lumbar spine, which would give them the flexibility. Where to stop is the most important thing in selective thoracic fusion. These are some of the examples. Here we stopped at L1. So when you stop exactly where you need to stop, when you know where to stop, then your selective thoracic fusions do give a good result. Now here's a young lady, 60-degree curve. See here again. very flexible. See the thoracic hump here, bending film, and again see just with a few strategically placed screws. I am not a proponent of filling up every pedicle. That's a complete waste of time in simple curves. Whoever says that it is very good for action, I totally disagree with them. All you need to do is to either rotate or, as I said, use your distraction compression technique to get a very good result. Just contour your rod well and you'll end up with good results. Another patient, again gone up to L1 with a very pleasing result. Now, who are the candidates for selective thoracic fusion? King type 2 or some of these Linky curves? You should have a good idea about patient's lifestyle. Some professional dancers or athletes, I operated on a young budding cricketer, and today now 8 years down the line with a selective thoracic fusion, is a moderate, medium pace bowler in cricket and is doing very well in the leagues. So patient's lifestyle, activity level, age, and preference to sports, professional dancers, you have to be very careful in fusing from top to bottom. And they are good candidates for selective thoracic fusion. Of course, clinical parameters, thoracic rotational prominence, more than lumbar prominence, extremely important. If somebody is loose jointed, perhaps this is not a good indication. You read up this paper and you'll get some radiological criteria for doing selective thoracic fusion, and this is very important. And to me, most important is age and skeletal maturity. Extremely important when you choose your patient for selective thoracic fusion. Now see Linky's paper, 123 patients, they concluded that instrumented thoracic and spontaneous lumbar correction was statistically better after anterior surgery. We have a few patients where we did anterior selective thoracic fusion, and we've been fortunate to get good results. Out of 203 patients, 6 patients again, mean patient age at the time of operation is 13.8 years. The older the patient, the better the result. Please remember that. So they obtained a preoperative scoliosis of 51 degrees, corrected to 16. The non-instrumented lumbar curve from 30 degrees came down to about 10 degrees with excellent correction. There were 17 patients out of these 200 and odd patients who had adding on, post-operative adding on, and that who required revision surgeries. So they concluded that selective thoracic fusion satisfactorily produces satisfactory radiographic and clinical outcomes at minimum 5-year follow-up, and it's a safe and effective method. Proximal lumbar flexibility was much more associated with lumbar coronal correction rate than traditional lumbar flexibility, another paper. So is selective thoracic fusion foolproof? It is not. Again, you see the age, 12-year-old female. You see here, this is again from the net. The add-on phenomenon, the fusion had to be taken 2 levels down to achieve a stable spine. So I have removed all our anterior surgeries, and we selected only patients with a minimum follow-up of 7 years and a maximum follow-up of 11 years. We removed all our patients whom we operated in the last 7 years from this data. There were 29, and we did more anterior surgery in females, but posterior surgery, it was more males than females. And our own series, we have a preoperative thoracic curve of 56 degrees, 6 degrees average, was corrected to 16. The non-instrumented lumbar curve of 28 plus or minus 5 was corrected to 10 plus or minus 6 degrees. Preoperative thoracic kyphosis of 18 plus or minus 12 and lumbar lordosis of 43 were improved to 23 and 46. So our results were comparable to most of the international the papers that were published. None of the patients complained of any back pain at 7-year follow-up. We have some issues as well. Look at this case, last patient. Now you see here, this is the curve about 58 degrees. Now you have a grade 1 spondylolisthesis. Now this is the dilemma, because if I fuse and she is overweight, if I fuse from B4 ideally to L3, if this child comes with a problem at L5S1, there will only be one vertebra left between the thoracic fusion and the lumbar surgery that she may require. So we ended up stopping here, explained to the relatives that she needs to reduce weight, and then we'll observe this curve. And now this is not included in the series, but 3 years down the line, she is pretty happy, but I'm not sure what is going to happen at that level in the long term or at the lytic listhesis at L5S1. So is this relevant? Growing child add-on phenomenon, 60-degree curve in 12-year-old child with research 0, be very careful. Is there evidence to prove that extending up to L3 has any adverse effect? None. So just because you want to copy some of these big centers and stop at T12, don't do that. You can go safely up to L3 if you are not very comfortable stopping at L1. So go ahead, do that to prevent adding on phenomenon. How much of the mobility obtained by STF is clinically relevant is still debatable, but anybody who has significant waistline asymmetry, be careful in doing selective thoracic fusions. In conclusion, especially in our country, sensitize the family, the potential for lumbar curve progression, you must explain to the parents, junctional problems, and of course, the small chance of revision surgery. What is missing in this whole scenario is level 1 and 2 evidence supporting selective thoracic fusion. Most of the evidence is level 4 based on clinical case series and studies. So STF is relevant if basic principles are strictly followed. Thank you very much.
Deliberation and wonderful. I would like to request Dr. K.K. Mukhopadhyay to come forward for his talk on, which was supposed to be in the morning, how do I prevent infection in AIS surgery?
Good afternoon, everybody. My talk is on how do I prevent infection in AIS surgery. So the incidence of the postoperative wound infection in patients with idiopathic scoliosis ranges from 1% to 5%, with the reported incidence being highly variable. The main contributors for the infection are prolonged duration of surgery, large volumes of instrumentation, presence of another remote infectious lesion, and use of allograft. These are the main contributors for more infection in AIS. But these parameters are not found to be significant risk factors. These are increased blood loss or use of perioperative medications to reduce blood loss, perioperative Cobb angle, or number of levels fused. These are not significant contributors. Of the patient skin, mucous membranes, etc., and the exogenous sources includes the surgical personnel, especially the members of the surgical team, operating room environment, including the airflow, instruments and implants and materials brought to the sterile field during an operation. This is the most important. The autoclaving is very important. The sterility of the implants and instruments is the most important contributing factor. So, reducing or preventing microbial contamination of the patient's tissue or the sterile surgical instruments is the key factor to prevent the SSI. So, these variables are easier to control. That is the preparation of the patients and healthcare workers' skin, appropriate timing of antibody prophylaxis and preparation of the OT. These are easier to control. But these parameters are not easier to control. There is a patient risk factors. There is a presence of underlying diabetes, age, smoking history, obesity. Those the two age and smoking history are not important in our country because the AIS is operated at the adolescent age. So these are not important factor in our country. And these are the aseptic technique, this hand washing, the surgical hand scrub, using barriers, maintaining a sterile field, using good surgical technique and maintaining a safe environment in the surgical area is the most important factor to prevent SSI. So, wherever possible, identify and treat all the infections remote to the surgical site before elective operation and postpone elective operation of patients with remote site infections until the infection has resolved. A pre-op shower on at least the day before, that is the night before the operative day is important. This intervention has been shown to lower the concentration of the skin flora microbials. During the pre-operative hair removal, it is not indicated nowadays. If it's at all required, then it should be removed immediately before the operation, preferably with electrical clippers. And only the incision area is cleared of hair, and saving is not recommended nowadays. The important is the patient skin preparation in the operating room. Keep preoperative hospital stay as short as possible while allowing for adequate preoperative preparation of the patient. So isolate the operative site from the surrounding unsterile physical environment and maintain a sterile field in which surgery can be performed safely. The surgical personnel who have acute communicable infections or who are colonized with a pathogen that can be transmitted during surgery should be excluded from the surgery until cured. Use of antibiotics, there are tips regarding using antibiotics, we all know that. Only one point, never leave antiseptic in open containers. And this is one of the important and debatable aspect, that is the use of preoperative antimicrobial prophylaxis. So there are few points. The giving antibiotics before a procedure to prevent infection is not a substitute for good infection control practices and surgical technique. Use antibiotic agents that are safe, inexpensive, and bactericidal with a spectrum that covers the most probable intraoperative contaminants. And administer the initial dose of antibiotics preferably within 30 minutes before initiation of the surgery. And do not prolong the prophylaxis through the post-operative period. There is no evidence that prolonged use of antibiotics offer any advantage, and instead encourages development of antibiotic resistance. And recommended controlled trials of preoperative intranasal mupirocin have not demonstrated efficacy in lowering frequency of SSI, but definitely it decreases the load of microbials in the nose. This is also small things, but it's very important. There is the preoperative skin preparation of the OT personnel. Hand hygiene is most important. Hand hygiene by OT personnel is one of the most effective ways to reduce the risk of infections. And all personnel should wash before entering the surgical field. And regarding one thing, regarding the alcohol-based surgical hand rub, continue rubbing until the alcohol is dry. Otherwise, the microbials will not die. So the protective clothing are that minimizes the patient's exposure to microorganisms, as well as also protect the surgeons from microbials from the patients. And the surgical attire should include gloves, caps, masks, gowns, waterproof aprons, and also protective eye cover. Putting and removing the surgical gloves is also very important. These small things, but very important. And you should change gloves when gloves become contaminated, after touching the outside of gloves with a bare hand, after touching anything that is not sterile or high level disinfection, high level infected, or when gloves develop holes, tears or punctures. This is also very important to establish and maintain a sterile field. This is only the sterile zone, that is the shaded area. So there are many surgeons who have habit to stand in Swami Vivekananda pose while taking shot in the Shyam. So that is highly contraindicated. And all items introduced into a sterile field should be opened, dispensed and transferred by methods that maintain sterility and integrity. A sterile field should be constantly monitored and maintained. And moisture in the sterile field should be avoided. If a solution soaks through a drape, then it should be covered with another sterile drape. and all personnel moving within or around the sterile field should do so in a manner to maintain the integrity of the sterile field. Post-operative procedural infections are more likely to occur when tissues which have been severely damaged due to rough or extensive manipulation during surgery, so try to be clean. This increases time during which it remains more susceptible to infections. Tissues are more susceptible to invasion by microorganisms after excessive bleeding and hematoma formation. Paying meticulous attention to controlling bleeding and to gentle tissue handling during surgery can reduce the risk of infection. Our anesthetic friends are very competent, but these few things that should be maintained during the operations, particularly the hypothermia, the hypotension should not be prolonged. These are the things that they take care of it. And the environmental control is usually taken care by the establishment department, but still it's important to control the traffic and activities in these areas, since the number of people and the amount of activity influence the number of microorganisms that are present and therefore influence the risk of infections. The temperature and humidity, these are two important factors which we usually overlook, but this is very important to maintain the temperature and humidity which controls the infections. The door should be sharp. The laminar flow should be in the OT where the spine or highly specialized OT are done. And the wall mounted air conditioners are contraindicated. These are the important checklists we should check frequently. And the routine microbiological sampling of the OTR or surfaces is not recommended because the results obtained are only valid for the time period and for the location sampled. So these are last couple of slides. So these are the prophylactic protocol for patients undergoing scoliosis surgery. The screening for remote infection with perioperative erythrocyte sedimentation rate and urine cultures. Closed room policy to reduce airflow contaminants. Intermittent release of self-breathing retractors. Intermittent normal irrigation of the muscles. Antibiotic administration within 30 minutes before skin incision. Addition of gentamicin for prophylaxis in high-risk groups. Limiting the use of allograft where possible. Thorough debridement or defatted tissue before closure. Surgical site reinforcement of sterile dressings to prevent contamination. No dressing changes for first 72 hours post-operatively to allow for initial wound healing. And lastly, so this is one of my cases done a couple of months ago. And in the second postoperative day, if you see this type of incision line, this type of wound incision line, don't hesitate to do a debridement, thorough debridement immediately. Don't wait for culture sensitivity and antibiotic therapy. So thank you for your kind attention.
Thank you very much, Kiran. So this is a small token of appreciation for coming all the way. And also next, our speaker is Aninda Basu. Please come onto the dais and give your talk on convex derotation technique in AIS surgery.
Good evening, everyone. It was the fag end of the day. We all need a drink. And before the all-important talk, I'm going to finish my slides as soon as possible. And I thank the previous speakers, Dr. Raghav and Dr. Kiran Mukherjee, for giving the introduction to my talk. And they've all explained why I need to do this procedure, because it is the convex instrumentation techniques is all about reducing the chances of infection and reducing money, reducing efforts, reducing surgical time. I'm Dr. Basu. I work in Institute of Neurosciences, Kolkata. I'm a spine surgeon there. So this is one of my X-rays when I started. You can see I just probably missed a couple of pedicles due to I fractured them or something. So screws at every level, and the spine looks like arrow. Something which I should be proud of, I'm not sure. All we need at the end of the day is a happy patient. We need a child smiling, we need the parents happy, we need them to leave the hospital saying, thank you, doctor. That's what we need, and they need to come back happy as well at 1 year, 2 years, 5 years follow-up. So that's what we need from a surgery. And so we are wondering always whether to take that extra leap of risk or to be safe. And always it helps to save some extra bucks if you're not operating in a country which is having patients having insurance like US, or the NHS paying for the surgeries like UK. So here most of the patients pay out of their pocket or have very little insurance money to help them for surgery. So saving extra bit of money always helps for the patients. So the surgical technique that I follow is freehand pedicle screws, like I learned during my training in the UK. And the corrective rod is the one attached to the convexity of the curve, and then always use titanium rods. Not a big fan of the cobalt chrome rods. And the thoracic correction is always carried out first with neuromonitoring, and the segmental vertebral derotation performed. The rod attached on the convex side of the main thoracic scoliosis is overbent to correct the thoracic hyperkyphosis. Sagittal balance is really, really important in all these cases. You don't want to end up having a flat back. Surgeries, AIS surgeries with a flat back in the post-op X-ray is a real turn-off. So this is like what the surgical site looks like. Screws placed heavily on one side and just a couple of screws on the top and the bottom on the other side. This is basically the corrective rod is a convex rod, and then we perform segmental derotation in each level on the apex over monoaxial screws or uniplanar screws. And we basically I had 24 cases, and grossly my operating time is round about 2.5 to 3.5 hours depending on the cases, and we lose about 950 mils of blood. Decent correction of the cob angle, and also like in our patients we had good SRS 22 questionnaire score improvement in these cases. So, and no significant, I haven't faced any significant complications, immediate or post-operative, intraoperative complications so far, touch wood. Speaking of complications, yesterday I was operating on one patient, and for the first time we had a loss of monitoring on one side. Basically it was probably a medial breach leading to a hematoma, and I did a laminectomy. The hematoma was evacuated and the child is safe and walking today morning. So that's something which happened yesterday, but till yesterday, before I prepared the slides, no significant complications. So the convex screws advantage is obviously everybody knows, like the pedicles are wider on the convex side, and apex rotate towards the right side away from the aorta. So you're not at risk of damaging the vessels or the cord. And screw misplacement, dural tears, vascular injury, neurological deficits. These are all reported complications of screw placement, scoliosis surgery. The chances are less with convex technique. And obviously the implant density, when I see implants on all sides, top to bottom, I sometimes feel a bit nauseated. But that's the truth. Many surgeons use it. I'm not saying that they're doing the wrong thing. But obviously if you can get away with achieving good results by having a low implant density of as low as 1.2, then I think it saves a lot of money as well as time, and gives more surface area for the bony fusion, and as well as saves a lot of money as well. So these are clear-cut advantages of having a low implant density. This is one of my cases. This one I did last week. My fellows were assisting me. So this is, pardon me for the bad quality of X-rays, because my routine X-ray machine is not working that well. So again, you can see that there's a decent correction of scoliosis, good balance curve, and look at the sagittal profile. I think the sagittal profile is quite good in this case. So this is the patient, this was the pre-op, and this is post-op. This is just before she went home. Again, another case. You can see that this is again a selective, convex technique. This is quite a severe lumbar curve. You can see that the lumbar curve is quite significant. And again, in the pre-op, is there a marker check? You can see that this curve was quite well corrected with this convex technique. Again, another case, 14-year-old male patient. I think I saw a convex technique being done in one of the cases that were done yesterday during this course. So again, this is another case, another 14-year-old male patient. This is an 11-year-old female patient. She's a little bit developing a little bit of PJK now at 1.5 years of follow-up. Probably I went a bit one level too low with my UIV selection, but doing well so far. The curve was quite significantly corrected, and she had a decent sagittal balance as well. So again, a 16-year-old female, it's almost 2-year follow-up now. This is a 13-year-old female patient, again, lumbar curve. 14-year-old female patient with, so all, these are all my, this again a 20-year-old lady who came 6 months back with lumbar curve. So I found decent, outcomes with this surgical technique. And I've been trained in UK in both my fellowships. I've worked with more than 5 surgeons, including Mike Gibson in Newcastle, as well as, Dave Fender, Andy Bowie. And then I moved to Edinburgh, where I worked with Mr. Thanos Sirikos, and I was deeply influenced by his technique of doing this convex instrumentation. I thought, he always used to say that when you go back to a country like India, where cost is a factor, you'll use my technique, and that's what that's what I found quite useful here. This is basically Thanos' paper, and he made me read every line of it while I was there and memorize them hard. In 2014 to 17, he published his data from 2014 to 17 of 191 cases, and he had very good results. And believe me, I've been his fellow. I've assisted him. I've seen his OPD. He has gone. I think it's now more than 400 or 500 cases of this convex technique, and all the patients. Many of the patients that I've seen have done well. So that convinced me to to start doing this technique, and it has helped me well so far. This is basically his video. Anybody wants to have a look at it, it's available online. The videos are also there, how he does this. And the hands you see in video are mine, because he was recording the video while I was a fellow there. And basically, there are other papers, one from Mr. Mike Gibson as well, I think, regarding the implant density. And so the take-home message, is the convex pericose to correction technique has achieved very satisfactory scoliosis correction, high patient satisfaction, functional outcomes. And this technique carried low neurological vascular risk due to screw placement, and low implant density obviously achieved excellent coronal correction, improved thoracic kyphosis, and normal sagittal balance. The question is, should this be the gold standard? So that's a thing of debate, and that's my fellowship days. I enjoyed them at Edinburgh. Thank you.
Thank you very much. And then I call upon Professor Dr. Massimo Balsano to give his keynote lecture on technical tips and anterior vertebral body tether in AIS surgery. And I'm not forgetting one very good talk of by Girish Swami. It's on surgeons' active recovery from a major complication like paralysis to patient in AIS surgery. How you recover. So that's a very important issue. There are a lot of issues around that, because it's a personal issue, it's an economic issue, it's a medical legal issue. So a lot of issues will be covered in a few minutes. So I call upon Professor Dr. Massimo Balsano, who is a doyen of anterior vertebral tether surgery. More than 500 surgeries has been accomplished under his care. Can you come?
Thank you again. And where is it? Okay. I hope very quickly. Is there only where can you go? Okay. So once again, I'm talking about the VBT. I'm shifting to VBT when I can. And I always discuss with the patients the advantages of this technique. Sometimes, of course, I have discussed before. This is my disclosure. So, as we can do MIS surgery, I always choose for that. And as I told you in the previous lecture, I do a mini open, very mini open and thoracoscopic approach in the thoracic spine, and I do a mini transpsoas or antepsoas like a oblique olive in the lumbar spine. I always use convex bicortical screws, and the rope is placed in gradually tension between the screws, as I show you. So, look at this case. is a case where we have 60.8 main thoracic, is a lanky free, typical. But if you look at, this is the lumbar lordosis, and this is a thoracic kyphosis with the software, where the surgeon network we use always. This is the clinical shape of a girl, the hump. And this is very important to choose. The supine correction spontaneously is correct, and especially the bending films for me are essential. I do the bending film always in supine position with an assistant, one of my fellows in the room, because sometimes the technicians are not so able, and they don't perform a very clear bending. And in this case, I have done a double tethering, you see, the thoracic and the lumbar, and I have put a double rope because, you know, lumbar is more flexible, and you can avoid the rupture of it. So this is the girl after the surgery, 2 months later, and this is how is the shape 2 months later. So it's perfectly balanced. Look at the spinal, the sagittal alignment also too. So how do I do it? Again, positioning is mandatory for first surgery. For the shoulder, because we are very close to the apex of the scapula, so we have to have the shoulder free of movements during surgery. We approach at the convex at the apex, and we do a mini thoracotomy. We identify usually we can't do a T4 positioning of a screw. The upper instrumented vertebra using is always for me is T5, so that's why it's very important to choose carefully and select the patients, the curve I mean. This is the apex, 3-4 centimeters, without cutting any muscles, so only dividing the fibers. And when we put this in skull alexis, that is like a Finocchio retractor, when is very radio transparent. So, and then we do the other approach for the, you see here, so the incision. Now we go, we see the through, sorry for the, and final, here we, yeah. So we insert the camera, and we are inside the chest. You see clearly the apex of the chest cavity. The most difficult preparation of screws is T5 because it's very close to the azygos vein. So when you insert this, of course, we have to stay very, very careful. You see here, we are preparing the positioning. The ideal positioning is 1 centimeter to the tip, to the edge of the costal transverse process, exactly in the middle of the vertebral body. Now you see here we are inserting the screw. These screws are coated by hydroxyapatite that makes this very strong to the maneuver. You see here the insertion. Okay. I always put a pin over the vertebral artery and the vein, vertebral artery of course, and monitoring what's happening. If nothing happened to the monitoring, I will go over, and what I do, I will now, you see, I tap the arterial, segmental arterial. This is the upper part, which is close to the diaphragm. Here you see in the upper part. And then with the crochet, which is close to the diaphragm, I prepare the space. You see, I prepare the space, sorry for the noise. I prepare the space, cutting the segmental artery. You see here, the pleura. Okay. Again, I prepare every place. See, we are in the middle part. You see, this is the diaphragm, the staples, the remotion of the staples. You see very clearly. Again, we check with X-ray the length. Some surgeons use the bodyguard, the perigard, not the body, the perigard, because on the other side you see we have some important vessels, because usually we are approaching the right thoracic, so maybe we can, especially in the middle, find the aorta on the other side. So we have to take it very carefully with. Again, we're approaching, and you see the positioning exactly in the middle of the body. This is very important. And all the screws must be bicortical, because now you have to correct how you positioning the rope, and then you go to tension it roughly to 400 newtons, very strong. So you have a great compression. See here, this is the tools I use. You see here, this is the tensioner over the extender, and finally we have done the correction. See here, and then we can cut finally the rope. This is the system I use. When we go to the lumbar area, it's different. We have to do an extraperitoneal approach. Of course, the transverse approach is more difficult, especially for 4-5, but we can check with the EMG where is the plexus. Usually I do this, I do my MIS surgery with this retractor or with these small incisions. Very important is the position, because we are approaching the convex part, and so you have to pull all the pelvic during the direction of the legs to reduce the spine correction. I show you a case of a lengthy. This is a girl that she refused to have a brace, and then she had this condition of the spine, not a bad, you know, very flexible, so we can fuse or not. I decide to avoid fusion. You see the typical lengthy 5, and this is the surgery. So we have spare at least 3 levels. This is immediately after surgery. You see the complete reduction of the flanks, and this is 1 month post-operative, and this is the girl. So, you know, I think it's a very good solution for this type of curves. See? So, briefly to the conclusions. This new technology and incoming results are very satisfactory. You need, of course, a steep learning curve, especially for the AIS thoracoscopic approach. For me, this has less complications versus the standard fusion. And lastly, I want to thank Ujibal for the invitation, and hope to come the next year with you. Thank you so much. And if you want to come to visit me, it's very welcome in Verona.
Thank you very much for a wonderful presentation. And with this, I would like to request Mr. Girish Swami to come and speak on how a surgeon can cope after a complication which is occurred. Thank you. After this, we will request Dr. Dinesh Jaiswal and Kiran Mukherjee to come to the dais to give the e-poster award to the winner. Please wait.
Thanks a lot, guys. End of a long day, actually end of a very long week, actually. I just wanted to have a vote of how many of you surgeons have had a major or neurological complication? Raise your hands. Major neurological complication from scoliosis surgery. Right, pretty much all of us. I know. So the thing is, I had prepared some slides for the benefit of the medical schools, the medical students and everybody, but as he's loading, I'll run it across very quickly, but I'll keep it brief to understand what we need to know. One of the things, the difficulty about doing this talk is we all practice in different countries, and the medical legal implications, the setup and the support systems are extremely difficult and different. I practice currently in the UK. We have an exceptionally good support network, but equally we get sued a lot. May not be as much as the American surgeons would be, but still the trust gets sued quite a lot. So just to put into context what it means for a patient to have a major neurological injury, as he is loading the slides, and what is the cost implication that's involved. The last case around 8 years ago that sustained upper mid-cervical cord injury following a AIS correction was recently settled for 16 million pounds. So that is the cost we are talking about. And we have a philosophy that I think patients do deserve remuneration, and we also fully understand that when a complication happens, this is catastrophic, not just for the parents, but for the family and the wider brothers, sisters, and the wider family as well. And we fully appreciate that remuneration for patients' welfare and care should be done. So again, we've got the slides now. So my topic is surgeons' active recovery from major complication in AIS. As I told you, we work in Norfolk and Norwich University Hospital, and we do practice in a few other hospitals. A couple of cases, we have had a few catastrophic complications over a few years, over 15 years. I think, if I'm right, we've had about 3 or 4 patients who had significant neurological injury. Some of them recovered to a great extent. Again, simple AIS case, neuromonitoring, 65% reduction in the cortical SCPs, and this was the intraoperative neuromonitoring alerts, and we have a lot of alert protocols. We have an exceptionally good neuromonitoring team. We do track testing, which we have published, and our neuromonitoring lead was the president of the British Neuromonitoring Society, and they do train fellows from all over the world. Again, another case, significant major neurological alert, loss of all left lower limb MAPs. I'm just going to skip through this very quickly. Again, another case. I've got some fantastic slides, and you do when something catastrophic happens and the patient day 1, day 2 gets a significant neurological injury, and then you do some an imaging, and as you can see, this was from 1997, and you can see that the screw is in the canal, and this is upper thoracic. What do we do? And this was a case from last year. Again, 13-year-old patient, AIS case, pretty stiff curve, had a fairly simple operation. Entire neuromonitoring was okay. Track testing was okay. There was not a blip of neuromonitoring alerts during the surgery. Day one, she was having some amount of patchy, altered sensations, and day two, she gets everything below T4 is gone. And you get a MRI scan, and this is what we find. There's definitely a screw in the canal. And we take her back straight away. This was around 2 years ago. So what, as surgeons, what we are really, really good at is we go to a lot of conferences. We get taught about how do you manage a complication surgically. We get taught about what catastrophic complication is, how do you intraoperatively manage it, how do you take it outside, and how do you manage it later on. We're exceptionally good at it. We have senior mentors, and we have courses and everything to teach us that. But and we also have excellent books and teaching on how you avoid complications. But what we are not good at is how do we manage ourselves. And that is one thing we are very, very, very poor on. And be it any catastrophic complication. This slide on my left here now clearly indicates what, as surgeons, we go through, the stresses we go through. At one point, this highest suicide rate among physicians was among surgeons. So this is something that we need to be very, very aware of. And we need to understand how, as a group, as surge individually and as a group, how can we reduce our stress levels. So the most important thing that we should all practice is how do we consent. Prep, as Michael and Joe were alluding to in the morning, the consenting process does not start when you actually sign a physical consent. The consenting process starts when the first time the patient walks into your clinic. And it just does not involve the patient, it involves the parents in the Western setup and much wider family in a setup like India. And the multidisciplinary approach we have to adopt. I know we all work in different environments. Sometimes we are forced upon to do the multidisciplinary team approach, but some of you practicing more remotely may not have the luxury of that. But please adopt that, because what it will encourage is the fact that you have been actively talking about your cases. And what do we do when things do go wrong? We are mandated by the General Medical Council, and of course, I'm sure all the medical councils do mandate this. We, as a profession, have a duty of candor. We have to let the patients know as to what exactly happened and why you think that's happened, and we have to be honest, and we have to keep our integrity and ethics with regards to our complications. We also have a routine practice of presenting all our cases in our monthly morbidity and mortality meeting. We normally in Norwich have it on a Friday, first Friday afternoon, and the entire department presents our complications and complaints. What this encourages is, it gives us an idea that nobody is immune to complications, be it the senior most consultant or the junior most surgeon. Everybody gets complications. And if you have a complication, do not be afraid to ask your peers their advice. Do not be afraid of opening up and saying, this is a case, this is what I did, and something happened. What it means is the biggest learning, it's not about you score, I play a lot of cricket and I can associate everything with cricket. You may score hundreds. But if you get out for a few ducks, those are the techniques you need to actually review. Your complications teach you more than your multiple successes. And of course, we have our British Association of Spine Surgeons, and what Mr. Crawford
because you learn from your mistakes, and once you start talking about your mistakes, you actually relax about them, and your peers will also start talking about their mistakes. And we, of course, have to report all our serious incidents to the serious incidents group, and we undergo a process of root cause analysis. This is a topic that is very frustrating for us because I'm a spinal surgeon and I do have a private practice. I know that this is all upcoming in India, but I would strongly advise, please take a robust medical indemnity. You may be practicing in areas where you think you do not have to take indemnity, but please do take an indemnity because it will protect you and it will keep you safe. And this was me just before I came. I renewed my insurance, and my insurance would have expired while I was here. And I would dare not tell you how much I have to pay for my insurance. It's and this is, again, as I was telling you, share your failures and not just success. We go to a conference and we see how fantastic I've been. I'm a great surgeon, and especially if you go to the American conferences, they all are telling, my friend here is so great, and that surgeon will say, my friend here is even greater. But do not be afraid of sharing your mistakes. And you can do that on a daily basis with your peer group, WhatsApp groups. You can do it over a drink, or if you have your own regional or district level or national or meetings, just put up an X-rays. Guys, this is what happened, this is what I did, and this is my complication. Just open up, and you open up, and your colleagues will open up. And you all start sharing ideas, and how can I do things better? And as I was telling you, we have our own network meeting, the East Anglia Network meeting, and we have this interesting Blue Nun Award. That Blue Nun is a bottle of wine, and it's given to the person who actually presents the worst complication and who has messed up the case the most. And it is, and we have no inhibitions. We are very open to our complications, and we have no inhibitions. And involve and empower your teams. You will be surprised. We had quite a few never events over the last few years in Norwich and a lot of NHS hospitals. Never events are regarded as those events which should never have happened. And when they did the root cause analysis, one of the commonest the cause was your team did not speak up. It could be, there was one, to give you an example, a surgeon did a wrong-sided nerve root injection. Yeah, you may say it's a nerve root injection, the patient did not come to any injury, but the staff members all knew that, but they were so afraid to talk and speak up that they just kept quiet. So please empower your team. Let them know if you're standing on the wrong side, if there's any changes, if you feel that, look, I've got a wrong size implant or anything, they will speak up. And there are a lot of people, there are a lot of clever people who are watching us and who are actually looking at us. And as I said, be open to your failures and nurture your skills and hobbies. It's one of those things that you should never give up. You know, as medical students, one of the things that happens in academics is we forget, and we are only focused on getting 99% marks or passing all the exams with distinction. And trust me, all my batchmates who got the gold medal or who were all front benchers have average practices. All the backbenchers who had nurtured their few little things have all shown quite high. So please nurture your skills and hobbies. And I play cricket, and I'm just showing off now, right? So I think I'm entitled to. So I play cricket a lot with in the Norfolk Cricket League, and on a Saturday I completely switch off. I may have had a rough run all week. I completely switch off, and at the end of the day I don't care what's happening in the hospital. And when you go to the cricket pitch, you will realize that I'm actually not the best person here. When you are a consultant in your own hospital, you're a professor, consultant, you're in your hospital, you are regarded as the best person. When you go to the team, you're probably a minion, and that actually makes you feel humble.
that actually grounds you. And surgery is one of the greatest, leveling specialties. So nurture your hobbies. And this is Bob Crawford. He's a great sailor and he loves sailing. This is when he retired, he went around the country. He took his boat and did circumnavigate the country. And we all went there. This is my daughter, Mansi. She was much younger then. And he's just demonstrating to her some sails and things. So please nurture your hobbies. And a lot of the young people will realize, and I'm sure many of us here said, once you hit 40, you'll start realizing, oh, I want something. Once you feel that you've achieved certain things, you will feel that, oh, there's something missing. And that's when you go back to, if you have nurtured your skills, you will go back, and that will really help you with any problems. And stay humble. As I said, surgery is a very leveling profession. There is nobody in the world who has not had a complication. And we cannot go into an operation saying, I will come out without a complication. Every one of us, every single star sportsman has failed. Every one of us have failed at certain points. So stay humble. And I just put this slide because I'm not very religious, but nevertheless, it just emphasizes the fact that you have to be humble. And one of this was the case that I showed you a couple of years ago that had the T4 screw cut out, and she had a late neurological injury 48 hours after the primary surgery. And the greatest gift of all is when, especially in a system like the Western system, when patients do not sue you straight away and they do not ask for, I want to go to another surgeon or another center, and they stick to you. And they actually are happy for you to do the revision procedure. And that's the greatest, confidence that your patients can give in you. So, in short, stay humble, nurture your failures, but be open to your complications. Do not worry, everybody has got them. Thank you.
Thank you very much. Wonderful talk. And I'll request Dr. Dinesh Jaiswal, Dinesh and Kiran to come over, and we will award the e-poster winner is Shubhadev, Dr. Shubhadev Chakravarti. The award is a certificate, first of all. Then there is a bigger memento, and then there is a check of 10,000 rupees. So that is very good actually to have achieved that. He has won this for a case report on definitive fusion in early onset scoliosis in a 12-year follow-up. We're coming to the end of the session, and I'm going to give a few hints or tips on how to treat Schwann's kyphosis, because this is the longest follow-up in the world, which I have published recently in spine deformity. So I'm not going to go anything further. Why do we treat? Because of pain, increasing curvature. And we had two groups. One group was anterior and posterior, and group 2 was mostly posterior. And following this, we had some good outcome in group 1, which is only posterior surgery. So all levels were fixed. And this is another case with deformity which had slipped and had to redo that. So there's increased incidence of proximal junctional kyphosis in few of the cases, although posterior ones had this and anterior posterior had less of a PJK. This is distal junctional kyphosis which was treated and also led to, you have to get to L3 at least to get your levels right. Otherwise, you may land up in DJK. In conclusion, the long-term clinical outcome for both posterior and combined procedures are comparable with reproducible results, and correction of thoracic kyphosis has a good correlation with ODI. Combined procedure has much higher complication than posterior surgical posterior fusion. So we recommend a single posterior approach with fewer complications. So you need to correct the thoracic kyphosis, and that gives a good predictive outcome and good functional outcome. So this was published last year in SRS Spine Deformity journal, and thank you very much. With this, I come to conclusion of the conference, and I would like to say vote of thanks. So we had a grooming week, and before that, what happened was I'd been trying since last 3-4 months to get this going, and with a lot of effort and with support from our vice chairman and the CEO, they said you have to do it. So I said, well, we can. We need support, a lot of support, especially in case of organizing the problems that are always there, but we have to overcome those hurdles, and I've been doing it for a long time now. 16th year is not a joke to be doing it since I was in UK. 2005 I started, and we come a long way where we have new friends in different parts of the world, and every time I seek support, and they are coming forward to help me, especially Alauddin Ahmed and Massimo. There was Francesco as well. This short meeting at our institute will go a long way in future to establish a spine deformity correction center. This will enable our postgraduate trainees to learn and organize to be spine surgeons of future. A short quote from Mother Teresa: not all of us can do great things, but we can do small things with great love, which is very important, because as you see that Vice Chairman Mr. K.K. Gupta and Dr. Balram Gupta and his father, who came today, the owner of this institute is Mr. Jagannath Gupta. They all appreciated last year's effort and said that you need to make it a bit bigger. I said, okay, and that's how we had made it a bit bigger. This time we had many more representation from around the world, especially UK, and nevertheless, Alauddin is always there. Massimo, second time. Then we had from Bangladesh, Shyam. He said on 31st of March, I want to come again. I said, well, very difficult to squeeze you in, but well, you can come. So it is not to be excluded. Anybody wants to get included, I'm here. And then I spoke to Rajesh Chaudhary a month ago. He says, I will come. So like this, we have included a lot of people in this, and I thank all of them for having a wonderful 1 week of surgical workshop. And I thank our principal here, and especially MSVP. He has been a very big support here in this institute to me, and whatever I do, he says you have to go ahead and do it. So this has been a whole program to make to succeed. So Professor Nirmal Dey was enthusiastic all throughout. He was very tired of having exams last week, so he couldn't stay more. And Chief Operating Officer Ms. Diksha Mukherjee has been at the helm of the organization and given valuable support at all stages of the program. So we thank all our foreign faculty, especially who were able to give support for the success of this program. And again, Dr. Alauddin Ahmed, Dr. Massimo Balsano, Dr. Girish Swami, Dr. Robert Crawford, Dr. Shah Alam from Dhaka, Dr. Rajesh Chaudhary, Dr. Junaid, and special thanks to Ms. Joan Silipandi and Mr. Michael Farrow, who never came to India before, and it's a great courage to come here first time and face such situations. Then we have had this meeting at our home recently, and that was on last Wednesday at dead of night. We had dinner, and I thank all national faculties, especially who were able to give support, Dr. Sabajit Basu, Dr. Raghav Datmalaktala, Dr. K. Apaji Krishnan, Dr. Ankur Nanda, and Dr. Bhavu Garg. And then we have the Scientific Society. We have Dr. K.K. Mukhopadhyay, who has been very good actually since last 2 months. He has supported me by spending patients. 3 of the patients who were treated were given by him. So I thank him very much for this effort, and I look forward to more of this support in future. Dr. Chinmanath, as I've mentioned, and Dr. Dinesh Jaiswal, he is currently the Secretary of Spine Society West Bengal. So he's a big man to be here, and thank you very much for coming, Dr. Jaiswal. Then we have Dr. Aninda Basu, as you have seen his speaking. He has been doing very great work as a young surgeon. Then Dr. Keshka, who is also one of the big surgeons in nearby Institute of Medical Sciences of ESI. Dr. Prashant Bed, who came and spoke on sagittal plane planning, and Dr. A.K. Pal, who is the head of the Department of IPGMER. And I also thank Rahul Anand and the Vikas Ray from All India Institute to come all the way to support our anesthesia. And I must thank all of our PG trainees who has worked under me, and special thanks to Dr. Rakesh Prasad, Dr. Subhadip Chakraborty, Dr. Amitosh Pandey, and Navarun and Shashank. I thank all those nursing staff who took part in the organizing this mammoth life surgical workshop in the theater. I thank Dr. Barnava, Paul, and Dr. S. Roy, who supported our local anesthetic team. And a special thanks to myself. I worked relentlessly for this meeting to come to fruition, and I think towards the end of the day, I feel very empowered to say that, yes, it has come to fruition, and we have made a team much higher, much larger, much bigger than what it was last year. And I have all the necessary steps required for conducting this difficult surgical workshop so that we can see this kind of surgery more in future in such a setting, which is important, in such a setting, which Allah was saying we have to see the cost effectiveness analysis. I have done few, but I need professional help, which I am asking my American side to do few work on that so that we can publish. As OSS is a great platform for treating patients as well as training surgeons. You know, in 5 days, you would not see anything in this country. 10 surgeries done. I don't think so. Yeah, and also a revision of a young child, because we had some problems with this congenital kyphoscoliosis, which I did not disclose before. She developed, next day, there was paralysis in both limbs. We took her to theater after CT scan. We found 2 of the screws were in the canal. And also, while after compressing the cord, I think there was a problem with the cord being compressed while the screws were fixed. We took her, and me, Dr. Balsano, Dr. Ala, we went in and put in replaced the screws. And then we did see the area where it was compressing, so we took that and did a laminectomy. We found a piece of little bone piece with the ligament of flavum attached, which was dipping into the cord. This girl is improving since yesterday, has moved her limbs, and I'm grateful to both of you that we could make such a decision to come and do that surgery again in this busy situation. So this is a complication which occurs everywhere, but you got to think about how we can manage that, right? And in this small OSS, we have managed such complications before, and we have last year we had one paralysis. She is walking well. So this is how we had advertised our Operation Straight Spine, and this is our website. You can look into it. All the activities of every year is recorded there. And this year I was awarded the Indian Social Impact Award, one of the top 20 awards in the country, in New Delhi on 21st of January for Operation Straight Spine. This is the team that worked there. There's more numbers there, but we haven't had the chance to take all of the pictures, but everybody has it, I think. And big thank to you all for coming and attending this meeting. And because this year we did the surgeries before, and this is the end. And we'll meet for a drink and cocktail dinner at Tollygunge Club at Bamalari Hall from 8 o'clock onwards. We have a large dinner for 80 people. I'm asking you all to come down there. Thank you. Thank you very much for a great week. Right? Last picture. Oh, yeah. Whoever is there, at a bhalo chobi আমাদের সবার। ঠিক আছে?